Hi guys, welcome everyone to the INI-CET marathon. I hope I'm audible. We will just take 2 to 2.5 hours of time and we will concisely and crisply revise the important topics. This is not an exhaustive revision of all the topics under medicine. You all know medicine is extremely vast. But even if you have not done medicine so far, the 2 hours that you are going to spend here should give you at least a heads up and help you pick up a reasonable number of questions, right? So that is the focus, to keep it crisp and concise, right? So we'll start with the cardiovascular system without wasting time. The first topic we're addressing is cardiology. Okay, now just tell me what all diseases come to your mind when you think of cardiology. My approach to cardiology is to classify the diseases into different structures, right? Pericardial diseases, myocardial diseases, endocardial diseases, valvular heart diseases, and coronary artery diseases, right? So let's begin with the pericardial diseases. So first we are talking about pericardial diseases. Pericardial diseases. So what are the important pericardial diseases for us? We have acute pericarditis, constrictive pericarditis, and cardiac tamponade. So first let me start with the acute pericarditis. So what is acute pericarditis? Acute inflammation of the pericardium. So first topic I'm addressing is acute pericarditis. Now in a question, how will I recognize that this question is talking about acute pericarditis? So if the patient has acute pericarditis, he will present with retrosternal chest pain. So patients of acute pericarditis generally present with retrosternal chest pain. But how is it different from the pain of MI? If I have a patient with retrosternal chest pain, which is worse on inspiration, it is suggestive of pericarditis. In case of MI, there is no relationship with respiration. Retrosternal chest pain worse on MI. Retrosternal chest pain worse on inspiration. That's initial complaint. And when we do ECG in these patients, in MI we get ST elevation and reciprocal ST depression. Here you will definitely get ST elevation, but unlike ECG, here you get concave ST elevation. You get concave ST elevation, that too in multiple leads, not restricted to any one vascular territory. You will have PR segment depression, which is not seen in MI, and you will have downsloping TP segment, which we call as spodic sign. Downsloping TP segment called as spodic sign. So ECG here, if this is what the normal ECG is supposed to look like, you will have a PR which is depressed, and then a ST which is concavely elevated, and a TP segment which is going down like this. So you have a PR which is depressed, a ST segment which is elevated but concavely elevated, and a downsloping TP segment. This is the ECG finding. So once I have this PR depression in any MCQ, mostly it is talking about acute pericarditis. Once I recognize it as acute pericarditis, then I should know what is the cause. The most common cause is idiopathic. In most of the patients, we never find out the cause. Most common cause is idiopathic. It is believed to be mostly caused by viruses. And when it comes to the treatment of acute pericarditis, remember, we treat them with NSAIDs plus colchicine. The point to note for the exam is colchicine reduces or decreases recurrence rate. If I am not giving colchicine and trying to manage the inflammation with NSAIDs alone, the recurrence rate is high. So adding colchicine reduces the recurrence rate, and this is a potential MCQ point. That's about our acute pericarditis. Key points to remember: the chest pain retrosternal, which is worse on inspiration. ECG showing concave ST depression, as concave ST elevation, and PR segment depression, and downsloping TP segment called spodic sign. Most common cause is idiopathic. Yes, we know some causes like Dressler syndrome, which is autoimmune pericarditis after MI. We also have uremic pericarditis. Etiology is known for plenty of cases, but many cases we never find out. Overall, idiopathic is most common cause. For idiopathic, we treat them with NSAID plus colchicine. Colchicine is added to reduce the recurrence rate. Okay, so that is one pericardial disease. The next pericardial disease is constrictive pericarditis. The next pericardial disease is constrictive pericarditis. Constrictive pericarditis. So can anybody tell me what is the cause for constrictive pericarditis? So as I repeatedly tell in all classes, constrictive pericarditis, the word constrictive is a misnomer. The pericardium is not constricting here. Pericardium is becoming stiff and it is not letting the ventricles expand during the diastole. So it is not squeezing it, it is restricting the expansion of the ventricles during diastole. The most common cause for constrictive pericarditis is having recurrent acute pericarditis. Recurrent acute pericarditis is the most common cause for constrictive pericarditis. Most common cause in India is different and in rest of the world is different. So in India, the most common cause is tuberculosis, tuberculous pericarditis. Rest of the world, it is going to be recurrent pericarditis. Because of recurrent inflammation of the pericardium becomes fibrosed and it becomes stiff. So when it becomes stiff, it cannot expand well. So it restricts the diastolic filling of the ventricles. It affects right side of the heart or right ventricular expansion more than the left ventricular expansion. So it is primarily a right heart disease. The key point to know about the constrictive pericarditis is that the stiff pericardium is abruptly stopping the diastolic filling. So there is abrupt cessation of passive filling. Abrupt cessation of passive filling. And when we halt the ventricle abruptly during the passive filling, this will lead to decreased RV filling because I'm restricting the filling of the RV, suddenly stopping it. Second, when the ventricle suddenly stops, it jerks vehemently and we call it as, it makes a noise called as pericardial knock. Pericardial knock. So any MCQ which talks about pericardial knock is talking about constrictive pericarditis, right? There is decreased RV filling, increased right atrial pressure, and increased right atrial pressure leads to the typical features of right heart involvement, that is raised JVP, hepatomegaly and ascites. Hepatomegaly, ascites, pedal edema. The typical right heart features are seen here. So key point for diagnosis is presence of pericardial knock on the MCQ. What else? In terms of investigation, when we do the right heart catheterization, the investigation of choice here is going to be right heart catheterization. And when you do right heart catheterization, it shows something called as square root sign, right? It is called as square root sign or also called as dip and plateau sign. I'm not getting into the detailed explanation of how does this sign gets produced. For now, for the exam going students, just remember we get something called as square root sign or dip and plateau sign. And when it finally comes to management, constrictive pericarditis is managed by pericardiectomy. The pericardium is stiff, restricting the diastolic filling of the ventricles. So we get rid of the restricting factor, which is pericardium here. Another point to remember here is on the JVP, you get a tall A wave because right atrial pressure is high. Tall A wave by default means deep or steep or prominent X descent. And here, abrupt cessation of the passive filling results in prominent Y descent. We will get a prominent X and prominent Y descent. Please remember this prominent Y descent is again important MCQ point. Many times it is used to differentiate between the cardiac tamponade and constrictive pericarditis in a MCQ. So to summarize, constrictive pericarditis means abrupt cessation of passive filling because of the stiff pericardium. That leads to pericardial knock, that leads to prominent Y descent on the JVP. And when filling of the RV is reduced, RA pressure increases, so it leads to all these right heart features. And less RV filling means you will have less LV filling, so you can also have low cardiac output. That's constrictive pericarditis. Most common cause in India is TB. Rest of the world it is recurrent acute pericarditis. The other pericardial disorder that we need to talk about is the cardiac tamponade. Cardiac tamponade. So what is cardiac tamponade? Cardiac tamponade refers to right ventricular collapse due to massive collection of the pericardial fluid. So when right ventricle collapses due to pericardial fluid, I would rather call it as cardiac tamponade. So cardiac tamponade refers to pericardial effusion leading to RV collapse. So if there is too much fluid in the pericardial space, it can compress and collapse the right ventricle. Eventually, it can cause collapse of the LV also, leading to impaired filling. But because LV is a thin muscle, RV is a thin muscle, RV gets affected first. So when there is collection of fluid and it is making the pericardium collapse, in the pericardial space, which is making the right ventricle collapse, you would term it as cardiac tamponade. So fluid has made the RV to collapse. That's your cardiac tamponade. In a question, how will I recognize? In a question, it always talks about what is called as Beck's triad. In Beck's triad, you will have hypotension, raised JVP. Why hypotension? You have a collapsed right ventricle. We can't fill much into it. So RV output is less blood comes to the left ventricle, less is the left ventricular stroke volume. So you have hypotension. Then raised JVP. And we know that fluid is not a good conductor of sound. So when you try to auscultate breath sounds, cardiac sounds, it appears muffled. So you will have muffled heart sounds. And when you look more closely at the JVP, particularly here, you will notice a tall A wave, a prominent X descent. But please keep in mind, here this RV collapse means there is no passive filling possible. You can't fill blood into a collapsed chamber passively. So there is no passive filling. And because there is no passive filling possible, you also don't have the wave of passive filling, which is Y descent, right? What is the wave of passive filling? It is the Y descent. So you will have absent Y descent. So constrictive pericarditis versus cardiac tamponade, debate can be sorted by the JVP. In the constrictive pericarditis, you have a prominent Y descent. This prominent Y descent is also called as Frederick's sign. It is also called as Frederick's sign, also known as Frederick's sign. And in case of the constrictive pericarditis, we had Frederick's sign or prominent Y descent. Here the Y descent will be absent because here there is no passive filling, right? Now coming to the management, when someone develops the cardiac tamponade, how do we manage? If it is traumatic, if the cause is traumatic hemopericardium, then the thoracotomy is the way to manage. But if it is non-traumatic causes, we can do a needle pericardiocentesis. Put a needle and drain the fluid out. So for traumatic, thoracotomy; non-traumatic, needle pericardiocentesis. Okay, so that completes our pericardial diseases, right? 3 important pericardial diseases: acute pericarditis, chest pain, worse on inspiration, PR segment depression on ECG, concave ST elevation, spodic sign, down sloping TP segment. Treatment wise, NSAID plus colchicine. Colchicin's advantages: a decrease in the recurrence rate. Constrictive pericarditis is equal to abrupt cessation of passive filling. So that is why you will have impaired RV filling, increased right atrial pressure. So you will see signs of increased right atrial pressure in the form of JVP raised, hepatomegaly, ascites, pleural edema. And Abrupt cessation of the passive filling itself leads to ventricle jerking, making a noise called pericardial knock. Abrupt cessation of passive filling becomes the reason why you get this prominent Y descent. Investigation of choice is right heart catheterization, directly seeing what is happening to the right ventricle through pressure tracing, and there you get this dip and plateau sign. Plateau appears because of abrupt cessation of passive filling. So if I recognize a case as constrictive pericarditis, we remove the pericardium. If it is cardiac tamponade, similar right heart symptoms, but here the fluid has caused the RV to collapse, and the collapsed RV cannot do passive filling. So you will have no passive filling. No passive filling means no Y descent. When it comes to treatment, if it is traumatic, mostly you have hemopericardium as the cause. So you'll have lot of blood, and blood is often clotted. So may not be able to drain that through needle. So in that case, best is do a thoracotomy and clear it off. But if it is non-traumatic, other causes, then you can put a needle and drain it, right? So that completes our pericardial disorders. Next, we'll talk about the myocardial disorders. So when we talk about myocardial disorders, we call them as cardiomyopathies, right? Myocardial disorders are cardiomyopathies. Cardiomyopathies. So let's address the cardiomyopathies now. So we know that there are three major types of cardiomyopathies. The first one, let me call it as dilated cardiomyopathy. Dilated cardiomyopathy or DCM. Dilated cardiomyopathy is where you have left ventricular dilatation in the absence of ischemia. Absence of ischemia. Ischemia is the most common cause for dilatation of the ventricles. But if I have dilatation of left ventricle without ischemia or valvular heart disease, we can have dilatation of the heart in valvular heart disease also. But without valvular heart disease and ischemia, if I develop dilatation of the LV, we will call it as dilated cardiomyopathy. What they will ask in MCQs, they will ask you what is the most common cause for dilated cardiomyopathy. The most common cause for dilated cardiomyopathy is alcohol. And the most common familial cause, means it can be inherited. The most common familial cause is going to be mutation in a gene called as titin. The gene is TTN, which codes for protein called as titin. This mutation is the most common familial cause. And I also want you to remember that these patients who have this truncating mutations of the titin, when their cardiac muscle biopsy is done, it shows something called as ninja star nuclei. It shows ninja star nuclei. A potential MCQ point. So please do remember that as well. Okay. Now how these patients present in terms of clinical features. Dilated cardiomyopathy patients, the ventricle is dilated, the muscle is atrophic. So it cannot generate sufficient force of contraction. So you will have systolic heart failure. Systolic heart failure. Systolic heart failure is nothing but heart failure with reduced ejection fraction. Heart failure with reduced EF. So if I have heart failure with reduced EF because of ischemia, it is not dilated cardiomyopathy. If I have heart failure with reduced EF because of some valvular pathology, it's not dilated cardiomyopathy. But if there is no valve problem, no ischemia, but still I have heart failure with reduced EF, then it is possibly dilated cardiomyopathy. Alcohol or this titin mutation or something else may be a cause. Now, how do we manage these patients? Management is standard heart failure with reduced EF management. How do we manage a heart failure with reduced EF? We use drugs like ARNI, angiotensin receptor blocker and neprilysin inhibitor. Then we use beta blockers. We use spironolactone and we use neprilysin inhibitors. Spironolactone and neprilysin and SGLT2 inhibitors. And SGLT2 inhibitors. Right? This is about the dilated cardiomyopathy. Then we have this thing called as restrictive cardiomyopathy and hypertrophic cardiomyopathy. How do I recognize that this particular question is talking about restrictive cardiomyopathy? restrictive cardiomyopathy is predominantly a right heart disease. Restrictive cardiomyopathy is a right heart disease. So what you have in restrictive cardiomyopathy is right ventricular relaxation is restricted. Right ventricular relaxation is restricted. So you have impaired right ventricular relaxation. What can restrict it? Storage disorders. When I stuff the muscles with something which can impair the relaxation, then I will end up with restrictive cardiomyopathy. So impaired RV relaxation results in decreased right ventricular filling. Decreased right ventricular filling results in increased right atrial pressure. So you get the same symptoms that you get in any patient with right heart dysfunction. So you will have raised JVP, you will have hepatomegaly, you will have ascites. These are the common symptoms we are expecting. Yes, Dhanush Gaude, the most common cause for the restrictive cardiomyopathy is amyloidosis. The most common cause for RCM is amyloidosis, cardiac amyloidosis. So dilated cardiomyopathy is a systolic heart failure where this dilated ventricle is not able to contract well. On the other hand, this restrictive cardiomyopathy is a diastolic heart failure. So in terms of clinical feature, you mainly have right-sided diastolic dysfunction because you're not able to fill the RV well. You have right-sided diastolic dysfunction leading to all this right atrial pressure going up, raised JVP, hepatomegaly, ascites. Management primarily focuses on treating the underlying cause. Treat underlying cause. That's about our restrictive cardiomyopathy. Important MCQ point. If there is talk about amyloidosis and has features of right heart failure, that is raised JVP, hepatomegaly, ascites, the question is talking about restrictive cardiomyopathy. So if I have right heart symptoms and amyloidosis, restrictive cardiomyopathy. If I have right heart symptoms and absent Y descent, muffled heart sounds, cardiac tamponade. If I have right heart symptoms and prominent Y descent, pericardial knock, constrictive pericarditis. So reaching the diagnosis from the question is pretty simple. Right-sided symptoms, raised JVP, hepatomegaly, ascites, muffled heart sound, think of tamponade. Absent Y descent, think of tamponade. Prominent Y descent, pericardial knock, think of constrictive pericarditis. Same right heart symptoms, but amyloidosis is mentioned, that it's a known case of amyloidosis, and think about restrictive cardiomyopathy. Now we have one more cardiomyopathy, which is hypertrophic cardiomyopathy. So what happens in hypertrophic cardiomyopathy? Hypertrophic cardiomyopathy is an inherited form of cardiomyopathy. It is an inherited form of cardiomyopathy. In hypertrophic cardiomyopathy, you develop asymmetric septal hypertrophy. So here the interventricular septum hypertrophies more than the rest of the ventricle. So you will have this so-called asymmetric septal hypertrophy. So you will end up with asymmetric septal hypertrophy. Interventricular septum hypertrophy is more. We will call it as ASH or asymmetric septal hypertrophy. What causes this asymmetric septal hypertrophy? Most common cause is mutation in beta myosin heavy chain. Beta myosin heavy chain. MYH7 gene mutation. So this results in asymmetric septal hypertrophy. Asymmetric septal hypertrophy may result in, this may lead to, I said may lead to obstruction of the flow of blood from LV to aorta. So when it leads to obstruction, we will call it as hypertrophic obstructive cardiomyopathy. So this may lead to left ventricular outflow tract obstruction. If obstruction occurs, it becomes a case of HOCM, hypertrophic obstructive cardiomyopathy. Apart from that, we will also notice that these patients have something called as SAM. SAM stands for systolic anterior movement. Systolic anterior movement of anterior mitral leaflet, because the interventricular septum is too strong or hypertrophied. The papillary muscle attached here also becomes strong, so it tends to pull the anterior mitral leaflet more forcibly, making it move anteriorly, right? This is what we call as SAM. And because of this, you get this ventricle looking like a banana. So you end up with banana shaped LV. So if any MCQ that is talking about asymmetric septal hypertrophy, systolic anterior motion, or SAM is a very important buzzword, or ASH, or banana shaped LV is talking about hypertrophic cardiomyopathy. What extra points I need to remember here? The hypertrophic cardiomyopathy is the most common cause for sudden cardiac death in young individuals and athletes. Death occurs due to development of fatal arrhythmias like ventricular tachycardia and ventricular fibrillation. Okay, apart from that, the small ventricle, because of this asymmetric septal hypertrophy, small ventricle leads to impairment of the diastolic filling. So it is more of, to start with, it is a condition where you have diastolic dysfunction. So when it comes to treatment, so you have this banana shaped LV. When it comes to treatment, and you have left ventricular outflow tract obstruction. So when it comes to treatment or management, there are two things to achieve: to decrease symptoms of obstruction, what I can do, and to decrease the risk of sudden cardiac death. Risk, what I can do. For symptom reduction, we can try to give beta blockers, or we can do septal myomectomy. The septum that is obstructing the flow of blood, you can cut part of it, septal myomectomy, or you can also do ablation. We can inject alcohol or laser based ablation. This septum is obstructing. Dhanush Gowda, yes, very good. So this septum is obstructing. I can strip that out to make the obstruction get relieved. So I can do that surgically, or I can inject alcohol to induce atrophy, or I can use laser to create burns. Yes, when they have hypertrophic obstructive cardiomyopathy, you do get the murmur, a systolic murmur, when the blood tries to move from the LV to aorta. And if I get confused between whether it is aortic stenosis or HOCM, some physical maneuvers can help us to differentiate. The AS murmur increases on maneuvers that increase the venous return and decrease on maneuvers that decrease the venous return. HOCM behaves opposite. Okay, so that's about hypertrophic cardiomyopathy. One more cardiomyopathy, that is an acute cardiomyopathy, that we need to discuss is what you call as stress cardiomyopathy, also called as Takotsubo cardiomyopathy. Stress cardiomyopathy or Takotsubo cardiomyopathy. This is a form of acute cardiomyopathy where patients, this is also known as Takotsubo cardiomyopathy, or broken heart syndrome, or apical ballooning syndrome, Basically, what happens in stress cardiomyopathy is when there is a sudden stress, there is usually release of catecholamines in the body in very high quantities. So there will be a catecholamine surge. Catecholamine surge leads to hyper stimulation of heart, and this hyperstimulation of the left ventricle doesn't occur uniformly. So you have more stimulation of the left ventricular outflow tract. So because I stimulate the left ventricular outflow tract more, this part becomes more contracted, than the rest of the heart. So you will have a hypercontractile left ventricular outflow tract. So you will have a hypercontractile left ventricular outflow tract and a non-contractile apex. So this results in the shape of the left ventricle almost becoming like that of a Japanese vessel used for capturing the octopus. So that's why it is called as Takotsubo cardiomyopathy. Takotsubo is a Japanese vessel for the capturing of octopus. So now you have a Takotsubo shaped ventricle. So when we get a patient with stress cardiomyopathy, when it comes to management, the management is mainly through intra-aortic balloon pulsations, which increase the coronary flow and increase the blood supply to the myocardium so that myocardium can recover from the insult of catecholamines. This is about our stress cardiomyopathy. Okay. Now, having covered quickly about the cardiac muscle disorders, we have done with the pericardial diseases, muscle disorders. Now let us talk about the valve disorders. Valvular heart disease. You are expecting one question on valvular heart disease. The valvular heart disease are generally simple and they are based on your diagnosis. Like there is a story of symptoms and then there is description of murmur. Sometimes there is description of the murmur behavior with respect to the maneuvers that increase or decrease the venous return, and based on that you should be able to diagnose. So if we talk about the valvular heart diseases, I will not get into the detailed discussion of the pathophysiology. I will just quickly recap what I want you to know. So for a case of aortic stenosis or a case of pulmonic stenosis, we will have the same murmur. For a case of mitral stenosis and tricuspid stenosis, we will have the same murmur. For a case of chronic MR and TR, will have the same murmur, and for a case of PR and AR, we will have the same murmur. So the murmur of the aortic stenosis is going to be murmur of aortic stenosis, and pulmonic stenosis is ejection systolic murmur. Ejection systolic murmur, which shows characteristic crescendo decrescendo pattern, pattern. The murmur intensity increases and then decreases. It is ejection systolic murmur, means the murmur starts after the opening of aortic or pulmonic valve, persists all the way till the closure. In mitral stenosis and tricuspid stenosis, we get mid-diastolic murmur with pre-systolic accentuation. The murmur increases just before the systole. Mid-diastolic murmur with pre-systolic accentuation. Sorry. They do ask you questions about when is the pre-systolic accentuation disappearing in a case of mitral or tricuspid stenosis. Pre-systolic accentuation disappears if patient has pre-systolic accentuation of the murmur is because of the active contraction of the atria. If atria does not contract, it will be absent. The pre-systolic accentuation is absent in AFib. So if I have MS with AFib, I will only have the mid-diastolic murmur, no pre-systolic accentuation. The murmur of MR and TR are pansystolic murmurs. The murmur of PR and AR are early diastolic murmur. These are early diastolic murmurs. That too, they are decrescendo murmurs. So now you might ask me a question, sir, how will I differentiate if there is a ejection systolic crescendo decrescendo murmur in a patient, whether it is AS or PS? AS will lead to problems in the left side of the heart, so you will have congestion of the lung. So dyspnea and congestion of the lung will be the manifestation. If it is PS, you will have congestion of the right side of the heart, resulting in raised JVP, hepatomegaly, ascites, pedal edema, right? So symptoms will always take you to the diagnosis. Second, they will also mention the areas of auscultation. If the murmur is best heard in pulmonic area, then it is PS. If I have an ejection systolic murmur best heard in aortic area, then it is AS. If I have a mid-diastolic murmur best heard in the mitral area, it is MS. Same murmur but best heard in tricuspid area, it is TS. If I have a pansystolic murmur best heard in mitral area, it is MR. Same pansystolic murmur but best heard in tricuspid area, it is TR. So area will take you to the diagnosis, right versus left symptoms will take you to the diagnosis. Another thing that you can do is check the relationship with breathing. The right heart valvular murmurs increase on inspiration. Murmurs increase on inspiration because right side of the heart receives more blood flow during inspiration, and left heart valvular murmurs increase on expiration because left heart receives more blood during expiration. Increase on expiration. And when right heart murmurs increase on inspiration, we do also call it as De Carvalho sign, classically described in a case of TR, but this finding can be seen in any of the right heart murmurs. So you can also look at that, whether the murmur is increasing on inspiration or increasing on expiration. So that's all I would say right now. I could revise for the valvular heart diseases. If you want a more detailed discussion on the valvular heart diseases, we have plenty of YouTube videos where you can go through the individual valvular heart diseases. Okay, so that's about valvular heart diseases. Then in cardiology, I forgot to mention, often they do ask the aortic stenosis versus HOCM in MCQs. So please remember, HOCM, aortic stenosis, is the where you have obstruction at aortic valve. Aortic valve is narrow, that is obstructing the flow of blood from left ventricle to aorta. In HOCM, we would say subvalvular obstruction, because valve is fine, just below the valve where there is left ventricular outflow tract, there you have the obstruction because of this asymmetrically hypertrophied septum. So how do I differentiate between the two then? Both have obstructing the blood flow from the left ventricle to aorta. One valve is narrow, other below the valve, septum is hypertrophied. So both will have ejection systolic murmur. But please remember, the aortic stenosis often has an ejection click. The stenosed valve, when it opens, it makes a click. There will be no click in a patient with HOCM. No click in a patient with HOCM. First point. Then both will have an ejection systolic murmur, but the ejection systolic murmur of AS increases on increasing venous return, Any maneuver that increases the venous return, like passive leg raising or squatting, will increase the murmur of AS, and any measure that decreases the venous return, like standing or Valsalva, that will decrease the murmur of AS, decreases on decreasing venous return. But HOCM behaves as an exception. Ejection systolic murmur that decreases on increasing venous return and increases on decreasing venous return. So no click, and this exceptional behavior helps us to differentiate between HOCM and aortic stenosis. Okay. Now what else I need to know from cardiology? We have already covered valve, myocardial diseases. Next is about heart failure. Heart failure. So when we talk about heart failure, we should know that heart failure refers to impaired LV filling. We need to fill blood into the left ventricle for us to be able to eject. If I'm not able to fill, that's a failed heart. Impaired LV filling or ejection. So impaired filling or ejection is heart failure. And as you know, heart failure is classified based on the ejection fraction into three categories: heart failure with reduced EF, heart failure with preserved EF, and heart failure with mid-range EF. When ejection fraction is less than 40%, we call it as heart failure with reduced EF. And if the ejection fraction is more than or equal to 50%, we will call it as heart failure with preserved EF. And if EF is between 41 to 49, we will call it as heart failure with mid-range EF. So when I have heart failure with preserved EF, that means ejection is fine, contraction is fine. It is the filling which is affected. So in that case, it is the diastolic heart failure or diastolic dysfunction which is the problem here. Most common cause for it is hypertension. Hypertension. And when we talk about heart failure with preserved EF, sorry, reduced EF, ejection fraction is reduced means the force of contraction of the heart is less. So you have systolic dysfunction. In systole, you are not able to contract well. That's why you're not getting a good ejection fraction. So this is systolic dysfunction. The most common cause for heart failure with reduced ejection fraction is ischemic heart disease. Ischemic heart disease. Now, when it comes to the diagnosis of heart failure, diagnosis is certainly clinical, but you can also take the help of biomarkers to prove that intracardiac pressures are elevated. Those biomarkers are either you can use BNP or N-terminal pro-BNP. These are considered as the biomarkers of heart failure. And once you diagnose, when it comes to the management of heart failure depends on which type of heart failure it is. If it is heart failure with reduced EF and if it is heart failure with preserved EF. Heart failure with reduced EF is treated with. Please remember, when heart fails, we have activation of sympathetic nervous system and RAS which cause more harm than benefit, and activation of natriuretic peptides which benefit. So I want to support natriuretic peptides, and at the same time I want to suppress the activated RAS and sympathetic nervous system. So how do I achieve this? I can block the RAS by giving ACE inhibitors or ARBs, and aldosterone by giving spironolactone. So we definitely use them. And I can support the natriuretic peptides by blocking an enzyme that breaks down the natriuretic peptides. We call it as neprilysin, right? So we will be using neprilysin inhibitors. So heart failure with reduced ejection fraction is right now treated with angiotensin receptor plus neprilysin inhibitor combination plus beta blockers. When we are using beta blockers, you have to use the beta blockers which have proven cardiovascular benefit in heart failure. What are those? I will tell you in a bit. Plus, we will also use spironolactone because aldosterone is harmful. It is going to cause more sodium water retention and worsen the heart failure. Plus, now we know from our experience and trials done on diabetic patients with heart failure, use of SGLT2 inhibitors is known to reduce the mortality. So we do consider using them as well. So this is the standard cocktail given to a patient with heart failure with reduced EF. So what beta blockers I can use? There are 3 of them that can be used. One of them is metoprolol succinate, bisoprolol, or carvedilol. So these are the 3 drugs which have shown benefit in trial. Other drugs, either trial is not done or they have not shown the benefit. So we don't choose any random beta blockers. You have to choose one among these 3. Okay. Then when we are considering ARNI, please remember it is a combination of ARB plus neprilysin inhibitor. If patient can't tolerate ARNI, then you can use ACE inhibitor or ARB alone. But if you can tolerate, better to give both. So when we are giving both, we only get a fixed drug combination as of now in the market. That includes a combination of valsartan, which is the ARB, and neprilysin inhibitor, which is sacubitril. This combination is currently used. Okay. This is for heart failure with reduced EF. Heart failure with preserved EF, we don't have much experience, much data to show what works and what does not. Most of the things that give mortality benefit in reduced EF have not shown the benefit in preserved EF. So the focus is mainly on treating underlying cause. Studies have shown that SGLT2 inhibitors do show some mortality benefit, so you can consider using them. Okay, now coming to this same heart failure with reduced EF, there is some advanced treatment that we should be aware about. So if I have heart failure with reduced EF, with EF less than or equal to 35%, they are at increased risk of sudden cardiac death. They are at increased risk of sudden cardiac death. To minimize the risk of sudden cardiac death, right, we might have to think about putting them on a ICD. EF less with New York Heart Association grade 2 to grade 3 dyspnea, they are at increased risk of sudden cardiac death. They are treated with implantable cardioverter defibrillator. But if they are having dyspnea of NYHA grade 2 to 3 because of heart failure, but in addition to that, see, EF less than 35%, dyspnea, plus in addition to that, they have left bundle branch block with QRS duration more than 150 milliseconds. They also require cardiac resynchronization therapy. They require ICD. ICD is already required because 35 or less ESR, but we will also need cardiac resynchronization therapy. Combined, we call it as CRTD, where resynchronization as well as defibrillator is bundled into one device, right? So this is again a potential MCQ zone, so be aware. That completes our heart failure management. Please remember now that these drugs means beta blockers, ACE inhibitors or ARBs, SGLT2 inhibitors, spironolactone or mineralocorticoid receptor antagonists including eplerenone and neprilysin inhibitors. All these drugs decrease cardiovascular mortality in patients with heart failure with reduced EF. On the other hand, digoxin long-term use may be associated with increased CV mortality. I know that there are few latest trials showing benefit of digoxin, so digoxin may come back to clinical practice in the near future, but for as of now, because it increases the cardiovascular mortality, it generally doesn't find a place in the prescription of a patient with heart failure with reduced EF. Okay, so that's it about heart failure. Okay, next, Dhanush Goda. So if the ejection fraction improves, we will call it as heart failure with improved EF. Improved EF. But we will continue to treat it as a heart failure with reduced EF. We will not switch our treatment. Okay, so then another important MCQ zone from the cardiology is going to be your bundle branch blocks and arrhythmias. Arrhythmia discussion will take a lot of time, so we'll not dig into it, but bundle branch block, we will just quickly revise. Now, the AV blocks are a frequently asked question, ECG questions, apart from the electrolyte abnormalities, the hyperkalemia, hypocalcemia, hypokalemia, and AV blocks. So when it comes to the AV blocks, we know that there is a first degree, second degree has two types, the Mobitz type 1 or Wenckebach, Mobitz type 2, and we have a third degree AV block. So in first degree AV block, we only have prolonged PR interval and no missed QRS. Prolonged PR interval, but no missed QRS. Then that is your first degree AV block. In second degree, we have two types, Mobitz type 1 and you have Mobitz type 2. In Mobitz type 2, you have constant PR interval. PR interval may be increase or decrease, but it is constant. You have constant PR interval, but intermittent missed QRS. Intermittent missed QRS. On the other hand, in Mobitz type 1, you have serially increasing PR interval, till you encounter a missed QRS, And third degree AV block, you clearly have a AV dissociation. Atria and ventricles, they don't have any relationship, they are beating on their own. You have AV dissociation, is third degree AV block. So on the ECG, how do I recognize first degree AV block? In first degree AV block, because there is no missed QRS, every P will be followed by a QRS. When every P is followed by a QRS, you have to just look at the PR interval. If the PR interval appears to be normal, that means you don't have any AV block. But if I see PR interval which is prolonged, then it is first degree. The normal PR interval is 120 to 200 milliseconds. That means it is supposed to occupy 3 to 5 small squares. On the ECG. Anything less than 3 is short PR interval, more than 5 is prolonged PR interval. So in this ECG, it is certainly more than 5. Like 1, 2, 3, 4, 5, 6, 7. Right? Almost, sorry, PR interval we are talking about 7, 8, 9. Almost 9 small squares. So here PR interval is 9 into 40. One small square is 40 milliseconds. So it is 360 milliseconds. PR interval in this particular ECG is 360 milliseconds. There is no missed QRS, so that becomes first degree. Second degree, you will always have a missed QRS. If I have a missed QRS, then I should think about second degree. So here I have a missed QRS. Here I have a missed QRS. So then which one is it? Is it Mobitz type 1 or Mobitz type 2? All I have to do is first see whether there is a missed QRS. If missed QRS, it is second degree. And once I conclude that this is second degree, I should see what is happening to the PR interval before the missed QRS. Is it remaining constant or is it serially prolonging? So in the first strip of ECG, we notice that it is serially prolonging. Look at it. I'm not even measuring. Visually itself, I'm able to see that it is serially increasing. So serially increasing PR interval with a missed QRS is your Mobitz type 1 or Wenckebach phenomenon. Here also I have a missed QRS. But when I look at the PR interval in the complexes before this, I don't see any serial prolongation. I have constant PR interval, but still a missed QRS. This is Mobitz type 2. Mobitz type 1, missed QRS. Behind the missed QRS, from each beat to next beat, the PR interval was prolonging. Now, the last one is third degree AV block. There is complete AV dissociation. So, when there is complete AV dissociation, you lose the relationship between atria and ventricle. Normally, a P wave will be followed by a QRS. In first degree, every P is followed by QRS, no missed QRS at all. In second degree, some QRS get missed. Otherwise, in all other complexes where there is no missed QRS, you will have a P following the QRS. But when there is AV dissociation, this relationship of P followed by QRS is lost. P appears randomly on the ECG, QRS appear randomly according to their whims and mercy. So here the P appears before QRS, but here P is appearing right after QRS. Here the P is appearing after T. So there is no relationship between P and QRS. P is appearing whenever it wants, QRS is appearing whenever it wants. When we encounter that, we call it as AV dissociation, and AV dissociation would be third degree AV block. So in terms of management of these AV blocks, the initial management of AV blocks is focused on getting the higher heart rate. And if they ask you definitive management, it's different. The initial management is going to be through IV atropine, which can help you get better heart rate, increase the heart rate. The definitive management is going to be pacemaker. Should I treat all AV blocks? No, the first degree AV block does not require treatment. First degree AV block, no treatment needed. Mobitz type 2 and third degree AV block, treatment absolutely necessary. And Mobitz type 1, treat if symptomatic. Means first degree AV block, just reassurance. Second degree Mobitz type 1, if patient is symptomatic, treat. If not, you can ignore. Mobitz type 2 and third degree AV block need to be treated. Treatment usually, initially we give atropine, but the definitive treatment is to put them on the pacemaker. So we'll conclude cardio here, and now let us step into the neurology. Okay, now when we talk about neuro, what are the important diseases from neuro? Plenty of MCQs on myasthenia gravis, plenty of MCQs on the GB syndrome, MCQs on the stroke management, MCQs on the multiple sclerosis, right? So that's what we'll try to address. And headache invariably you will expect one question. So when it comes to neuro, let's talk about myasthenia gravis. What is myasthenia gravis? It's a neuromuscular junction disorder affecting postsynaptic membrane, because it is the antibody against the acetylcholine receptor. So it is a postsynaptic NMJ disorder. Lambert-Eaton is a presynaptic NMJ disorder. This is a postsynaptic NMJ disorder. It is an autoimmune disorder, and if it is an autoimmune disorder, there will be antibodies. The most common antibody seen in these patients is anti-acetylcholine receptor antibody. Apart from that, we can also have another antibody which is second most common, called as anti-musk antibody. And some patients, not as common as the anti-acetylcholine receptor or anti-musk, we have an anti-lipoprotein 4 receptor antibody. These are common antibodies. The antigen for this anti-acetylcholine receptor antibody, now we know where is it. It is the myoepithelial cells of thymus gland. So that's why thymus gland abnormalities are a contributory factor for the pathogenesis of myasthenia gravis. If you have thymoma or thymus gland hyperplasia, then there is increased proliferation of myoepithelial cells, so more antigens available for the immune system to build antibodies against. So chances of developing myasthenia gravis increases. So when these patients develop, they develop something called as fatigable weakness. They have fatigable weakness, or the weakness that has diurnal variation. The weakness worsens as the day progresses. That's a classical finding of NMJ disorders like myasthenia gravis, and this is what we try to prove when someone presents with the symptoms. The most common symptom of these patients is ptosis, followed by diplopia. Apart from that, they can also have the proximal muscle weakness. They can also have the facial weakness, right? So they can develop this facial weakness, which is called as myasthenic facies or snarling face. When you ask the patient of myasthenia gravis to give a smile, they can't give a bright smile because they're not able to lift the lateral edge of the lip. Face is weak and drooped, so they can only lift the lips, showing the teeth, looking like the snarling of a dog. That's why it is called as snarling face. So when I have to make a diagnosis of myasthenia gravis, we have various investigations available, but in terms of diagnosis, the most sensitive investigation and most specific investigation they often ask. Most sensitive investigation is single fiber electromyography. Most specific investigation is going to be finding the antibody against acetylcholine receptor antibody. This is most specific investigation. We also have a test called as edrophonium test or tensilon test. Edrophonium or tensilon test, where you notice ptosis improving after edrophonium. Edrophonium is an acetylcholine esterase inhibitor. So if I administer it, acetylcholine increases and ptosis gets better. But this test is not routinely performed due to risk of cholinergic crisis, because when we give adrophonium, acetylcholine increases everywhere, not just at the neuromuscular junction, so it can lead to problems. So not routinely performed due to risk of cholinergic crisis. Another MCQ with diagnosis they can ask is bedside test. What we can do in the bedside itself, or bedside screening test, and that is ice pack test. That is ice pack test. So if it is myasthenia gravis, ptosis improves on applying ice pack to the eyes. Now they will ask you to interpret this single fiber electromyography to decide whether it is myasthenia gravis or not. That is the emerging single fiber electromyography or repetitive nerve stimulation test. So if on repetitive stimulation, if the muscle's force of contraction action potential goes on increasing, we will call it as incremental response. If it goes on decreasing, we will call it as decremental response. In myasthenia gravis, because you have this so-called fatigable weakness, the more the muscle is used, the more weaker it becomes. So if I go on repetitively stimulating it, the force of contraction goes on decreasing. Right? Instead of contracting, muscle just starts showing a jitter. That we will call it as decremental response or increasing jitter. Decreasing force of contraction or muscle action potential, or increasing jitteriness or failed contraction, or increasing jitter. This is typically seen in myasthenia gravis. But if I get incremental response where the muscle's action potential goes on increasing, or force of contraction gets better, or the jitter decreases, decreasing jitter, then it is suggestive of either Lambert-Eaton syndrome or botulism. This is a emerging area of interest, so please keep this as well in mind. Okay, so that's about myasthenia gravis. We did not address the management. So management of myasthenia gravis primarily depends on whether it is a stable case or it is the case of myasthenic crisis. So if it is a stable case, we treat them with pyridostigmine, which is the drug of choice. Pyridostigmine is an acetylcholine esterase inhibitor that will block the acetylcholine esterase and increase the acetylcholine. Pyridostigmine is the drug of choice. It is drug of choice because it is long acting. I don't have to administer it very frequently. Plus, we also consider steroids or immunosuppressants to reduce the antibodies. And we have to make a note here that thymectomy, because antigen stimulating the anti-acetylcholine receptor antibody is there in the thymus gland. So thymectomy may be useful for acetylcholine receptor antibody positive myasthenia gravis, which is also called as seropositive myasthenia gravis. In negative patients, thymectomy is not useful. You can also do thymectomy if there is a visible thymoma. So thymoma is anyway an indication for thymectomy. Even when you don't have a visible thymoma, if this anti-acetylcholine receptor antibody is positive in a young patient, we can go for thymectomy. If it is in a crisis situation where patient is having respiratory failure, crisis means respiratory failure. Sorry. So their treatment should focus on putting them on mechanical ventilator so that at least for now the breathing is taken care, and we will try to get rid of those antibodies which are blocking the receptors with plasma exchange or IB immunoglobulins. So this is the management of myasthenia gravis. Next disease we have is the Guillain-Barré syndrome or GB syndrome. What is GB syndrome? GB syndrome is a infection induced or infection triggered autoimmune, autoimmune polyradiculoneuropathy, infection triggered autoimmune polyradiculoneuropathy. Then if infection is a trigger, of course there is a question, what is the infection? There are plenty of infection known to cause. The most common infection or well documented infection is infection of the gut by Campylobacter jejuni. Campylobacter jejuni. These patients present with rapidly progressive, because it's polyradiculoneuropathy, you are talking about peripheral nerves being affected, so they will have rapidly progressive flaccid, because peripheral nerve which contains lower motor neuron. So once the lower motor neuron is affected, you will have hypotonia. So flaccidity is a very, very important point. Flaccid ascending paralysis, flaccid ascending paralysis, rapidly progressing flaccid ascending paralysis. And because LMN is affected, you will have hypo or absent reflexes, areflexia, hyporeflexia or areflexia. Distal to proximal progression of the weakness, flaccidity or hypotonia, and hypo or areflexia. Okay, now point to note here, progression in GB syndrome usually lasts for less than 4 weeks. If I have progression of paralysis beyond more than or equal to 9 weeks, it is suggestive of another disease called as CIDP, chronic inflammatory demyelinating polyneuropathy. So think about CIDP if the progression continues beyond 4 weeks, and if it is 9 or higher week, it's clearly a case of CIDP. It is not GB syndrome. Okay, now we have types of GB syndrome that we should be aware. So the first type of GB syndrome is AIDP, acute inflammatory demyelinating polyneuropathy. This is the most common type worldwide, and as the name suggests, it is due to demyelination, not the axonal injury. It is due to demyelination, not axonal injury. And in these patients, the antibody responsible for demyelination is anti-GM1 antibodies. Then in India, we generally tend to see Aman more common. We have Aman and Amsan, which are axonal injury type of GB syndrome, and these are more common in India. These are more common in India. And here you have axonal injury. Axonal injury is because of the antibody, which is anti-GD1A antibody. Then we have one more variant, which is called as Miller-Fisher syndrome, or MFS, Miller-Fisher syndrome. So in Miller-Fisher syndrome, correct me if the spelling is wrong, but pronunciation is right, the Miller-Fisher syndrome. So in Miller-Fisher syndrome, you have a sensory predominant. So you are here also you predominantly have demyelination, and to some extent there may be axonal injury, but predominantly demyelination. But this demyelination is affecting the sensory neurons more. It is affecting sensory more than motor. So that's why these patients don't have this motor weakness. They only have sensory symptoms. Others will have predominantly motor weakness. And this is because of this antibody called as anti-GQ1B antibodies. So what happens in Miller-Fisher syndrome? Because you're having the sensory loss due to the demyelination, you will have sensory ataxia. You will have sensory ataxia. Now, apart from that, you will also have a or hyporeflexia, because the stimulus is not taken to the spinal cord by the sensory nerve, because you have sensory nerves demyelinated. So you will have A or hyporeflexia. And in addition to that, you will have ophthalmoplegia. Ophthalmoplegia. So this combination is what we call as the triad of Miller-Fisher syndrome. So in terms of prognosis, AIDP is considered to have good prognosis because we just have demyelination. Remyelination does occur pretty comfortably, but this condition is said to have poor prognosis because axonal injury is not easy to heal, right? Miller-Fisher syndrome is also considered to have good prognosis because here we have predominantly involvement of sensory neurons, and the risk of death is less if I lose sensation. Risk of death is more if the motor involvement is there and respiratory muscles get affected, right? Now, when it comes to the management of GB syndrome, I forgot to mention, when it comes to diagnosis of GB syndrome, you can follow something called as Brighton's criteria. Brighton's criteria. So there are 5 components in the Brighton's criteria that I want you to remember. The first, you need rapidly progressing ascending paralysis. Second, because it's a peripheral nerve disorder, tone is expected to be low, so you need to have flaccidity. Third, you need to have hypo or areflexia. Then fourth, CSF analysis should show something called as albuminocytological dissociation, means increased CSF protein, because these antibodies are all proteins. Right? Antibodies are immunoglobulins. Immunoglobulins are globulin type of proteins. So increased CSF protein and minimal or almost no increase in cell count, pretty close to normal cell count. This phenomenon where only protein is increased, cell count is not increased, we call it as albuminocytological dissociation. Albuminocytological dissociation. Okay, so if I get this, according to the Brighton's criteria, it is a case of GB syndrome. And when it comes to the management of GB syndrome, the key focus is on preventing death. Why do a patient of GBS die? If the ascending paralysis eventually catches up with respiratory muscles, then they can die. So the most common cause of death is respiratory failure. So how do I minimize this risk of respiratory failure? Well, we can't, but we can try to get rid of the antibodies which are causing the nerve damage so that the disease progression halts and hopefully the respiratory muscles doesn't get involved. So for that, we use IVIG or plasma exchange or plasma pheresis. IVIG, according to study, is slightly superior to plasma exchange in terms of giving the results. But to also see if this patient is likely to get the respiratory muscle involved. If respiratory muscle gets involved, I need to put them on ventilator. So can I predict it? Yes. We can predict by monitoring the forced vital capacity. We will regularly monitor FVC, and if FVC drops to less than 15 ml per kg, that calls for putting the patient on ventilator. Intubate and ventilate. As long as FVC is 15 plus, maybe you can hold on, but if it is below 15, you need to intubate. So this is a potential MCQ this time. What is the parameter used to assess the impending respiratory failure in GBS? It is the forced vital capacity. And when do we consider preventive intubation or prophylactic intubation? When the FVC drops below 15 ml per kg, right? So that completes our discussion on GB syndrome as well. Next, just few important updates on stroke. If you have time, I would recommend you to go through a detailed stroke update that's available on the YouTube. For now, just an important update on the stroke, because we have 2026 stroke management guidelines, right? So first thing is the window for thrombolysis. What is the window for thrombolysis? Earlier we used to have 4.5 hours window for thrombolysis. In some of my lectures you might have heard 6 hours, because Harrison and some guidelines had started pushing it to 6. Now what is the current recommendation? The American Stroke Association 2026 guideline recommendation. We can do thrombolysis up to 9 hours. So we have an extended window, right? So you have the standard window of less than up to 4.5 hours, standard window of up to 4.5 hours. So you can definitely do thrombolysis up to 4.5 hours without a hesitation if there is no contraindication in a ischemic stroke. But after 4.5 hours also you can consider thrombolysis up to 9 hours. You can consider thrombolysis, but with a caveat. What is the caveat? Actually, after 4.5 hours, we have to go through something called as perfusion imaging, MR or CT perfusion imaging, trying to identify if I still have sufficient brain tissue that can be saved by thrombolysis, right? That viable brain tissue, what you call as penumbra. If I have still penumbra present, I can go ahead and thrombolyze. If the penumbra is small or negligible or no penumbra, everything is become an infarct, then there is no point in trying to do thrombolysis. After 4.5 hours, you can do comfortably, but after 4.5 hours, if a large penumbra can be found, if large penumbra found on perfusion imaging, CT or MR perfusion imaging. So now tell me, what should I do if I get a patient with acute ischemic stroke within 4.5 hours and no contraindication to thrombolysis? Go ahead and do thrombolysis. But if he present after 4.5 hours up to 9 hours, I should do perfusion imaging first, and if I find a large penumbra, go ahead and do thrombolysis. If no large penumbra found, don't do thrombolysis, right? Simple. The second update is the drugs for thrombolysis. Earlier, though off-label, many doctors had started using tenecteplase. There was no official recommendation, right? Only alteplase was the standard drug which was FDA cleared for stroke. But now we have two drugs which are considered equivalent. What are those? As usual, the traditional alteplase, and now tenecteplase is also considered equivalent to alteplase. You can use whichever you want for thrombolysis if you are going ahead with thrombolysis. Point to note, alteplase need to be given as initial bolus dose followed by an infusion dose. Tenecteplase is a single dose bolus, so it becomes more convenient to administer. It is a single dose bolus of 0.25 milligrams per kg, 0.25 milligrams per kg with a max dose of 25 mg. Alteplase doses, as you know, the alteplase dose is 0.9 mg per kg. The max dose is 100 mg. And here, out of the total dose, 10% of the dose is given as initial bolus and 90% is given as infusion over 1 hour. So that is messy or cumbersome. Tenecteplase is more practical or convenient. So this is a new clearance or recommendation by the ASA. So please keep that in mind. It's a potential MCQ point. So two potential MCQ point. Now what is the extended window period? Up to 9 hours. And which drug is now made entry into the officially recommended drug list? It is tenecteplase. What is the advantage over the alteplase? Single dose bolus. What is the disadvantage over alteplase? Probably nothing, because the guidelines say they are equivalent, right? So that's from the neuro side. Okay, now we will get into the rheumatology. In the rheumatology, as you know, majority of the questions come from these 3 or 4 topics. SLE, and when a question comes on SLE, it's all about the interpretation of antibodies most of the times. Then rheumatoid arthritis, it's about image-based questions trying to identify the deformities. or scleroderma, trying to ask you to differentiate between limited cutaneous and diffuse cutaneous variants on clinical grounds or by interpretation of labs, or identification of some of the rare rheumatological disorders like mixed connective tissue disorder, right? So we will begin with the SLE first. SLE first. And as we know, SLE is a rheumatological disorder which is more common in females than males. More common in females than males, with a ratio of 9:1. Typically affects middle-aged women, and it's a multi-system autoimmune disorder. So multiple systems to get targeted, right? And here the organ injury is because of immune complex formation, and immune complex are formed by antigen antibody combination. So we have self antigens, our own body antigens. Own body is producing antibodies against them. They form the complexes. Complexes get deposited in organs like kidney, skin, and they cause the damage. So that begs the question: what are the common antibodies? Right? Antibodies in SLE. The most sensitive antibody that we get in SLE patients, that is seen almost in more than 90% of the patients with SLE, and that is ANA. ANA. The recommended method recommended for ANA estimation is indirect immunofluorescence. Indirect immunofluorescence. And we will consider it as positive or raised when the titer is more than or equal to 1:80. More than or equal to 1:80. Then most specific. The key point to note about ANA is that ANA titer does not correlate with disease severity. Titer does not correlate with disease activity. So that's why we don't keep repeatedly checking the ANA levels in a patient with SLE. For initial diagnosis, we do it. After that, we don't keep repeatedly checking whether the titer is going up or down. So all we have to do is, if you're suspecting SLE, get a ANA done, get a profile done. So in that, we are getting the ANA done using the indirect immunofluorescence, and if titer is more than or equal to 1:80, fair enough, sorted. After this, when the patient comes back for follow-up, we don't check whether the titer is increasing or decreasing, because it has no correlation with the disease activity. Okay, so if they ask you what is the most specific antibody, most specific is anti-Smith antibody. Anti-Smith antibody is the most specific. But you know what? The most interesting antibody is the anti-dsDNA, which is second most specific after the anti-Smith, and also the second most sensitive after ANA. Second most sensitive after ANA, and that is anti-dsDNA. Clinically, the most useful antibody in SLE because it correlates with disease activity. It predicts the risk of the lupus nephritis. So it is highly sensitive, highly specific, and also it correlates with disease activity, and it also correlates with risk of kidney involvement, or what you call as lupus nephritis. And because it correlates with disease activity, we can keep checking the anti-dsDNA titers to see whether patient is responding to treatment or not. If the titers are going up or not coming down with treatment, it means treatment response is poor. If it is going up, it is indirectly telling that the disease is flaring up, right? So that's a very useful investigation. Then antibody correlating with drug-induced SLE, that we all know, it is anti-histone antibodies, right? Anti-histone antibodies. Then we have this anti-SSA antibody, which is also called as anti-LA antibody. This correlates with development of Sjogren's syndrome in patients with SLE. When SLE patient develops Sjogren's syndrome, we call it as secondary Sjogren's syndrome. It also correlates with the risk of neonatal lupus. So if the mother has SLE, A pregnant woman has SLE and she has this anti-SSA antibody. The chances of the neonate developing passive disease, means the transfer of maternal antibodies, can cause a SLE-like manifestation in a newborn. We call it as neonatal lupus. That risk is high. And this antibody also correlates with, so it correlates with the risk of Sjogren's syndrome, correlates with neonatal lupus, and also correlates with subacute cutaneous lupus erythematosus, a form of skin rash. Then we have anti-SSB antibody, also called as anti-Rho antibody. It only correlates with risk of Sjogren's syndrome. It does not correlate with other risks that SSA was correlating with, like the neonatal lupus or SCLE. Just correlates with the risk of Sjogren's syndrome. Then we have this anti-ribosomal P antibodies. Anti-ribosomal P antibodies that correlates with neuro and psychiatric lupus. So these are some important antibody correlations that I want you to remember. If you ask me specifically, sir, what all you want me to remember, this is a basic thing that they keep asking. The most specific, most sensitive, which antibody correlates with the risk of lupus nephritis, which correlates with drug induced, especially neonatal lupus. It is anti-SSA or anti-La antibody. Dhanush Goda, yes. The neonatal lupus often presents with the AV blocks in the newborn because these antibodies can cause or induce inflammation of the conduction system and they can develop AV blocks. Good. If you want, you can definitely note that down. AV blocks in newborn. Okay, so that's about the antibody correlation. Beyond that, what they can ask, the clinical manifestations, mainly they will ask what is the most common manifestation of a particular organ involved in a particular rheumatological disorder. So in SLE, when we talk about skin, the most common dermatological manifestation is the butterfly rash or malar rash. Apart from that, yes, you do have chronic cutaneous lupus erythematosus, that is called discoid lupus erythematosus, and you also have subacute cutaneous lupus erythematosus. Skin. When it comes to the joints, you have bilateral, symmetric, small joint polyarthritis. Small joint polyarthritis, pretty similar to rheumatoid arthritis. Rheumatoid arthritis also affects small joints. Rheumatoid arthritis is also bilateral symmetric joint involvement. That is also polyarthritis. This is also polyarthritis. That's also inflammatory. This is also inflammatory. Only difference is this is non-erosive, so it doesn't cause joint erosion. So true deformities are unlikely. Rheumatoid arthritis is erosive. It causes true joint deformities. So when it comes to the CVS, it can affect all the layers of the heart, but the most common cardiovascular manifestation is pericarditis, either with or without pericardial effusion. Apart from that, it can cause endocarditis. When it is causing endocarditis, it is just the inflammation, no infection. So we don't call it as infective endocarditis. Rather, it's a sterile endocarditis. You can call it as Liebman-Sachs endocarditis. Liebman-Sachs endocarditis. Okay. It can also cause myocarditis. When it comes to the respiratory system, the patients of SLE, they can also develop, most commonly they develop pleuritis. Pleuritis is the most common respiratory manifestation. All these are itis are the most common. CVS, pericarditis. RS, pleuritis. Apart from that, it can also cause interstitial lung disease. When it causes ILD, it causes non-specific interstitial pneumonia type of ILD usually, which carries a decently good prognosis, not pretty bad. Then it also causes diffuse alveolar hemorrhage, and it is also known to produce a peculiar syndrome called as shrinking lung syndrome. Shrinking lung syndrome. What is a shrinking lung syndrome? Here there is no lung fibrosis. but still the lung volumes reduce. It is believed to be because of the fibrosis of the surrounding structures of the lung and not the problem in the lung itself. So we call it as shrinking lung syndrome. How do I identify it in an MCQ? The MCQ will mention that you have a restrictive PFT, means you have FEV1 by FVC ratio more than or equal to 0.7, but FVC is low, proportionately FEV1 is low, restrictive PFT, but normal lungs on imaging. So problem is, for this restriction, lungs are not the problem. Then if it is in a case of SLE, it is shrinking lung syndrome. A very important potential MCQ point. Okay. With respect to the renal, it causes lupus nephritis. Renal, it causes lupus nephritis. So these are the organ manifestations. Okay. Now, how do I manage a case of SLE? How do I manage a case of SLE? Well, I don't have to go through the detailed discussion on the management of SLE, but the key point that I want you to remember is the blanket treatment. What do I mean by blanket treatment? Means you give it for all SLE patients, regardless of the severity, organ involvement, whether kidney is affected or not, lung is affected or not, doesn't matter. You give it for all the SLE patients, that is hydroxychloroquine, if there is no contraindication. Hydroxychloroquine is the standard treatment for all SLE patients. It's like blanket, give it for everyone. Methotrexate is the same drug for rheumatoid arthritis. You give it for all patients if there is no contraindication. So what are the contraindications for hydroxychloroquine? If you have prolonged QT interval, hydroxychloroquine can prolong it further. And if you have retinopathy due to any other cause, because hydroxychloroquine itself is known to cause retinopathy. So after starting the drug, 5 years down the line, we need to start screening for retinopathy, because hydroxychloroquine can cause retinopathy. Okay. Apart from that, there are some newer drugs that I want you to remember. And when I'm talking about newer drugs, I want you to remember two drugs. One is belimumab, which is a monoclonal antibody. Yes, there is an autoimmune disorder. Along with the hydroxychloroquine, if required, you can add low dose steroids. You can use immunosuppressants as well. Belimumab and anifrolumab. Belimumab is a monoclonal antibody against B lymphocyte stimulant. It's a monoclonal antibody against B-LYS. B-LYS stands for B lymphocyte stimulant, which is also known as, B-LYS is also known as BAF, B cell activating factor. So anti-BAF or anti-B lymphocyte stimulant is belimumab. And anifrolumab is a monoclonal antibody against interferon 1. Interferon 1. So please remember, the principal cytokine involved in the pathogenesis of SLE is interferon 1. In case of rheumatoid arthritis, it is TNF alpha. So that's why we try to target TNF alpha when we treat rheumatoid arthritis. Here I have to target interferon 1. It's there in the name. Interferon 1. Interferon 1. Monoclonal antibody against it. Okay, so that that completes the key update on SLE. Rheumatoid arthritis, my dear ortho faculty will address about rheumatoid arthritis and all of those deformities that you need to know. I'm pretty much expecting an image-based question there, so certainly go through that as well. Okay, next we will talk about scleroderma. Scleroderma. What is scleroderma? One more autoimmune rheumatological disorder, and as the name suggests, there is fibrosis or sclerosis of the skin, right? So that's why it is called as scleroderma. So there are two subtypes in scleroderma: limited cutaneous and diffuse cutaneous. Usually we abbreviate it as systemic sclerosis, scleroderma, or systemic sclerosis. There are two subgroups of systemic sclerosis or scleroderma. Number one, limited cutaneous, where the skin fibrosis or thickness is restricted to the distal body parts. And then you have diffuse cutaneous, where the skin fibrosis or thickness extends to the proximal body parts. When do I call it as restricted to the distal body parts? When the skin thickening is only restricted to the elbow joints and distal in the upper limb, and the skin fibrosis is restricted to the knee joints and distal in the lower limb. So if the fibrosis is not extending beyond these points, then we will call it as limited cutaneous. So in limited cutaneous, this is a line of demarcation. The skin fibrosis doesn't extend beyond this, beyond the elbow in the upper limb and beyond the knee in the lower limb. That's your classical limited cutaneous. In case of the diffuse cutaneous, there is extension beyond this line of demarcation, that is beyond the distal body parts. The involvement extends to the proximal body parts. Face is involved in both the cases, be it limited cutaneous or diffuse cutaneous. So is it only about the different extension of the skin fibrosis? No, the disease behaves totally different. The limited cutaneous patients are at increased risk of developing fingertip ulcers. These patients are at increased risk of developing pulmonary arterial hypertension, at increased risk of developing esophageal dysmotility, increased risk of developing calcification of the skin, what you call as calcinosis cutis, right? So that's why you can say that limited cutaneous is associated with what you call as crest syndrome. It is associated with crest syndrome, where C stands for calcinosis cutis, R for Raynaud's phenomenon, esophageal dysmotility, T is telangiectasia, S is sclerodactyly. So that's typical of the limited cutaneous. So what am I really worried about in these patients is development of pulmonary arterial hypertension. On the other hand, diffuse cutaneous patients are at increased risk of, these people are at increased risk of developing interstitial lung disease and something called as scleroderma renal crisis. Scleroderma renal crisis. So once I know which type it is, I know they are prone for some complications, so I can monitor accordingly and treat accordingly. So that's why understanding these types is important. But is it only based on the extent of fibrosis that I can judge, or I can also judge based on the labs? Yes, we can also judge based on the labs. So in limited cutaneous, the antibody that we get is mainly anti-centromere antibody. Anti-centromere antibody is the classical antibody of limited cutaneous. In case of diffuse cutaneous, we get this anti-DNA topoisomerase, antibody, which is also called as anti-SCL70, anti-scleroderma 70 antibody. And some of these patients may also have anti-RNA polymerase 3 antibody. So if I have a patient with scleroderma with anti-centromere positive antibody, it is limited cutaneous. This patient is more prone to develop pulmonary arterial hypertension. If I have systemic sclerosis patient with anti-SCL70 or anti-DNA topoisomerase antibody positive case, then it is diffuse cutaneous. This patient is more likely to develop ILD and scleroderma renal crisis. Okay. So then some extra points here. The anti-RNA polymerase 3 enzyme, anti-RNA polymerase 3 antibody correlates with risk of scleroderma renal crisis. Scleroderma renal crisis. Okay. And what is this scleroderma renal crisis then? It is a high renin malignant hypertension. So sudden shoot up in BP to the point that it can threaten the organs because of high renin is what scleroderma renal crisis is all about. Right. It was once upon a time the most common cause for death in patients with systemic sclerosis, but now that we know it is a high renin malignant hypertension, we treat efficiently. How do we treat? High renin is responsible, so the treatment of choice is mainly ACE inhibitors or ARBs. ACE inhibitors or ARBs. So I hope the points are clear. We are looking at anti-SCL70 for diffuse cutaneous. That means they are prone to develop ILD and scleroderma renal crisis. If I have anti-centromere antibody, that patient is prone to develop pulmonary arterial hypertension. How do I remember which antibody is seen in limited cutaneous and which is seen in diffuse cutaneous? I keep telling this simple hack every time. Please remember, centromeres in a cell have limited presence. I can find centromeres only inside the nucleus, right, where chromosomes exist. But DNA has more diffuse presence. I can find DNA outside the cell also, where mitochondria is there. So DNA is there in the nucleus as well as in the mitochondria. Outside the nucleus, outside the nucleus. So it is diffuse. Centromere only inside the nucleus, so it is limited. So if you have anti-centromere, limited cutaneous. If you have anti-DNA topoisomerase, diffuse cutaneous. Okay. Now on this scleroderma, they do ask you some image-based questions. So just be aware of them. So what all images they can ask? They can give you this fingertip ulcers. Fingertip ulcers are more common in limited cutaneous type of patients. Then you can have these all calcific plaques visible. That is calcinosis cutis. Apart from that, I forgot to mention, these patients tend to develop. If you ask me the clinical features of scleroderma, the most common complaint of these patients, most common complaint is going to be development of Raynaud's phenomenon. Raynaud's phenomenon. Okay. Apart from that, they can develop, because there is inflammation of the skin of the fingers, you will get sausage shaped fingers. Can anybody tell me where do we get this sausage shaped pancreas? Sausage shaped pancreas. You can develop ILD, you can develop pulmonary arterial hypertension, you can develop renal crisis, you can develop esophageal dysmotility, right? These are the common symptoms we are expecting. This sclerodactyly is nothing but dactylitis or inflammation of the skin of the fingers. Good. So the classification criteria that we follow. The sausage shaped pancreas I was asking you, right? It is seen in patients with autoimmune pancreatitis. Autoimmune pancreatitis, which is most commonly IgG4 related pancreatitis. You get the same sausage shaped pancreas. The classification criteria says there is something called as sufficient criteria. Sufficient criteria. So if there is skin thickening of both hands extending proximal to or extending beyond metacarpophalangeal joint, that's enough to diagnose the case as scleroderma. You don't need anything else. Okay, but if you don't have the skin thickening extending proximal to MCP, then you have to look at other parameters and see if I get sufficient points or not. If you get more than or equal to 9 points, then you can classify the case as systemic sclerosis, and you get 9 points if I have skin thickness extending proximal to the metacarpophalangeal joint, means all the fingers are affected. Beyond proximal metacarpophalangeal joint, beyond the metacarpophalangeal joint, there is involvement of skin thickening. That itself gives 9 points. Another important point I want you to remember is the nail fold capillaroscopy can be a useful tool, which also is involved in the classification criteria for scoring. So nail fold capillaroscopy will show normal nail fold capillaries if I have Raynaud's disease. But if I have Raynaud's phenomenon due to the systemic sclerosis, then I will have abnormal nail fold capillaries. What abnormalities we expect? I'll tell you. Abnormal nail fold capillaries, if you have, it is suggestive of secondary Raynaud's, like due to scleroderma or systemic sclerosis. So what abnormal nail fold capillaries we can see? Giant capillary loops, avascular zones, and hemorrhagic spots in the nail fold capillaries. Hemorrhagic spots, if you see them, it is abnormal. Abnormal NFC indicates secondary Raynaud's. It could be secondary to scleroderma. If it is normal, no giant capillary loops, no avascular zones, no hemorrhagic spots, then it is Raynaud's disease, which is just a physiologically exaggerated response to cold. When it comes to management of scleroderma, there is nothing specific that we can do. Rheumatoid arthritis, we have methotrexate and other disease modifying anti-rheumatoid drugs. SLE, we have hydroxychloroquine, immunosuppressants, and newer target specific agents like belimumab and anifrolumab. Unfortunately, here we don't have anything, because the main cytokine involved in causing the pathogenesis for SLE, it was interferon 1. Interferon 1 is the principal cytokine in SLE. This is the main cytokine which is causing all the inflammation. The principal cytokine here is transforming growth factor beta, TGF beta, which is inducing the fibroblast to cause the fibrosis. That's why we are getting this scleroderma, skin thickening, skin fibrosis. But we cannot easily block this transforming growth factor beta without causing major side effects. So that's why we don't have any specific treatment. So treatment of scleroderma primarily focuses on treating complications. If I develop esophageal dysmotility or GERD, you can give me prokinetics. If I have pulmonary arterial hypertension, you can treat the pulmonary arterial hypertension, right? You can treat the Raynaud's phenomenon by giving the calcium channel blockers so that I can get vasodilatation. So it is just treating the complications. So it is more of a symptomatic treatment. So SLE and scleroderma done. Please don't miss out on covering the rheumatoid arthritis, especially deformities from the ortho. Okay. So before I move to the next section, let me tell you another important thing here. Mixed connective tissue disorder, MCTD. What is mixed connective tissue disorder? Mixed connective tissue disorder is an overlap syndrome. It's a overlap syndrome. So then comes the question, what is overlap syndrome? Overlap syndrome refers to more than or equal to two rheumatological disorders in same patient. More than or equal to two rheumatological diseases in same patient, then we will call it as overlap syndrome. So like if I have SLE features plus rheumatoid arthritis patient features, then it is a overlap syndrome. A classical example is lupus, where you have SLE features plus rheumatoid arthritis patient. You can call it as lupus. But a patient with overlap, where more than one rheumatological disorder exists in a patient, if you have this antibody called anti-U1 RNP antibody, then we will call it as MCTD. So MCTD is an overlap syndrome with this specific antibody positivity. If I have SLE Sjogren syndrome and rheumatoid arthritis features in a one patient, it is an overlap syndrome. And in that patient, if anti-U1 RNP antibody is positive, then it becomes mixed connective tissue disorder. If this antibody is negative, but I still have overlap of many rheumatological diseases in a patient, we will simply call it as overlap syndrome. Overlap syndrome with this antibody positivity is mixed connective tissue disorder. So often they give this antibody and then ask you to diagnose it. So if you see anti-U1 RNP antibody positivity, it is a mixed connective tissue disorder. Okay. So now from there, we'll go to the nephrology. So in nephro, there's nothing much to update per se. 2 or 3 important MCQ zones that I'm expecting is AKI versus ATN, the pre-renal AKI versus ATN, CKD complication related some questions, or dialysis indication related questions. Beyond that, majority of the questions in nephrology you're expecting are going to be path oriented. Like all these glomerulonephritic disorders, they will give you some symptoms from which you can identify that it is a glomerular disorder that the question is talking about, but eventually it will land up in pathology, asking you to consider whether this is a case of PSGN, whether this is a case of IgA nephropathy based on the deposits, right? Immunofluorescence interpretation, the biopsy changes. So I will not get into that because Dr. Ranjit will address that. We will only focus on some CKD updates and the AKI versus ATN debate. So first let me start with the pre-renal AKI versus pre-renal AKI versus acute tubular necrosis. Pre-renal AKI versus acute tubular necrosis. So basically, what is this acute tubular necrosis? So when you look at the kidney, the structural and functional unit is a nephron. So we have this glomeruli, then we have this PCT, then loop of Henle, DCT, and collecting ducts. So here, this tuft of capillary and this is my glomerulus. These are my tubules. So sometimes kidneys can lose the function because of reduced perfusion, that is pre-renal AKI. Commonly occurs when I have hypotension or if there is renal artery stenosis. And ATN refers to acute tubular necrosis. If the tubules become necrosed, the cells die here, it becomes ATN. Right? How do I differentiate? So first thing is the urine specific gravity. So remember, if the blood flow to the kidney comes down, there will be activation of RAS because we sense that there is hypoperfusion of the glomeruli. There will be activation of RAS. So in pre-renal AKI, we have RAS activated. And when RAS gets activated, what will happen to the water absorption and sodium absorption? RAS will increase the absorption of water and sodium from the renal tubules. So the amount of sodium we excrete and the amount of water we excrete will be less. So in that case, we will have decreased urine sodium because RAS is absorbing it back, and we will also have decreased like now we are absorbing a lot of water, right? So what will happen to the urine? It becomes concentrated. So you will have increased urine osmolality, and you will also have increased urine specific gravity because you are only reabsorbing sodium, which is a solute, but there are so many other solutes which you are not reabsorbing under the influence of RAS. You are only absorbing sodium and water. So when I absorb water, the urine that is going out becomes more and more concentrated. So basically you're excreting concentrated urine. We experience it day in and out, right? If I don't drink sufficient water, by evening when I go to pee, I notice it has become dark because we are excreting concentrated urine. So when renal perfusion decreases, of course, RAS is activated, I am reabsorbing a lot. So I am excreting concentrated urine. So just think about concentrated urine in pre-renal AKI. Only thing is, I am reabsorbing sodium, so I find less sodium in urine, right? But when tubules are damaged or necrosed, even if I have RAS activation, I will not be able to reabsorb the sodium and water. Why? Because the reabsorption is the function of tubules, right? Like for example, I create a glomerular filtrate, Then I start reabsorption from PCT. There are different locations where different substances are reabsorbed. Like 90% water gets reabsorbed in the PCT. Most of the glucose gets reabsorbed in the PCT. But once I cause the injury to the tubules, that is ATN, the reabsorption gets affected. So I don't reabsorb, I excrete all. So acute tubular necrosis may have increased urine sodium because I'm not able to reabsorb, right? And because I'm excreting a lot of water without reabsorption, right, I might have decreased urine osmolality and I might have decreased urine specific gravity. But you know what is the best method of identifying whether I have pre-renal AKI or the acute tubular necrosis? It is the fractional excretion of sodium. There are other potential clues we get in an MCQ. When we have pre-renal AKI, we will have these normal casts in the urine, which may be increased in number. Those are hyaline casts, which may be increased. These are normal casts. But in patients with acute tubular necrosis, the tubular epithelial cells which are dead and shed into the tubules, they take the shape of the tubule, form what you call as renal tubular epithelial cell casts. You can have renal tubular epithelial cell casts. Some of these cells die and lipofuscin pigment gets released, creating a brown color. So you may also get muddy brown casts. Those casts are not encountered in a patient with pre-renal AKI. You get epithelial cell cast and muddy brown cast if there is ATN. But the best investigation to differentiate between the two is going to be fractional excretion of sodium. Fractional excretion of sodium. FENA. So in case of pre-renal AKI, because RAS is activated and tubules are fine, we will reabsorb a lot of sodium. Excretion is less, right? That's what we just discussed. We will excrete less sodium. So FENA will be less than 1%. So less than 1% of the filtered sodium gets excreted, right? Most of it is reabsorbed. But when I have acute tubular necrosis, tubules are the place where we absorb, but tubules are damaged or necro, so I cannot reabsorb. So I excrete a lot of sodium in urine. So FENA will be more than 1%. Often it is more than 2%. So FENA is the most important investigation to differentiate between acute tubular necrosis and pre-renal AKI. Okay, so that's about the pre-renal AKI versus ATN. Then few updates on CKD. Nothing much has changed with respect to CKD staging, with respect to how we manage a case of CKD, when to initiate dialysis, all those remain same. So then what is the update that I want to talk about? Let's talk about anemia of CKD, right? How do we treat a case of anemia of CKD? What are the choices we have? Anemia of CKD, the main cause for anemia in a patient with CKD is, what is the main cause? It is the erythropoietin deficiency. Erythropoietin deficiency. Apart from that, there are other contributory factors, but EPO deficiency is the main cause. So you're not able to produce sufficient hemoglobin under the lack of erythropoietin. So a classical case of anemia of CKD is supposed to be normocytic normochromic anemia. But in reality, what we get is most often hypochromic anemia. Why hypochromic microcytic? Because inherently CKD is associated with uremia. High urea means impaired appetite, so nutritional intake gets compromised. They develop iron deficiency anemia. Though it is a main cause, you do have contributory causes, and among the contributory causes, iron deficiency is an important cause. So whenever you have anemia of CKD, what is the first thing we do? Assess the iron stores, and if there is deficiency, replace first. So when it comes to the management of anemia of CKD, So as I already told you, if there is no iron deficiency, an ideal anemia of CKD is supposed to be normocytic normochromic, because you have erythropoietin deficiency, you're not making sufficient RBCs. Okay, but what we get is hypochromic, because iron deficiency is a contributory factor. So that's why when it comes to the management, first thing we should do is iron replacement if deficiency is present, and then we go with the erythropoietin or darbepoietin injection. Darbepoetin is preferred over erythropoietin because of its longer duration of action, lesser frequent administration. Right? Without, don't give erythropoietin or darbepoetin without replacing the iron deficit, because I try to stimulate for increased RBC, cell turnover, and hemoglobin production, but raw material iron is not there. You don't get the response you want, right? But if the patients are not responding to, or you're not achieving the desired hemoglobin level despite adequate iron replacement and erythropoietin or darbepoetin, now we have a new class of drugs. This is what I wanted to give you an update, because it is new and they might ask you questions about it. What are these new class of drugs? You have something called as hypoxia inducible factors, prolylyl inhibitors. Prolylyl inhibitors. Prolylyl hydroxylase inhibitors. You can add prolylyl hydroxylase inhibitors. It's a new category of drugs. Inhibitors. Can anybody name few examples which have been recently cleared? Because it's a potential MCQ zone. They all end with do stat. They end with do stat, like daprodustat. Dhanush Gowda, absolutely right. Iron replacement and darbepoetin or erythropoietin. But yeah, we still had challenges. A lot of patients were not able to achieve a good improvement in hemoglobin, and that is where we are using these drugs. Daprodustat is one drug. Then we have vadadustat. Vadadustat. There are other candidate trial drugs like the decidustat, so they would be probably coming to the market in the near future, right? So this is a potential MCQ from the CKD side. So that's it from me today. So we have covered some important high yield topics. What other topics I would recommend you to do from your proper source is approach to arrhythmia. I cannot cover the whole arrhythmias in half an hour or 45 minutes. It would require many hours to understand the diagnosis, drug of choice, management, and all. But if you have already done, don't miss out on revising the arrhythmias. Don't miss out on addressing the questions on ABG. You're certainly expecting one question on ABG, one question on arrhythmia, one question on the interpretation of the CSF analysis for diagnosis of the meningitis, that will be covered in microbiology. So these are some standard questions we are anticipating. That's it from me today. I'll see you with another session covering some more important topics. Till then, have a good time. Dhanush Gowda,
Please check my voice. Hi Sanjay. Yes. So today we will discuss important topic of an of for INI-CET examination. Just wait. The very important topics for INI-CET examination. This mainly includes the vitamins, minerals. ये जो topic है INI-CET में generally कौन से topic पूछे जाते हैं? See, these are the topics frequently asked in the INI-CET examination. Vitamins, minerals means clinical aspect. क्योंकि ये जो topics है vitamin, minerals, this topic uh, the repeat will be there in the pediatric, in the medicine, in the community medicine. So these are the frequently asked topic: vitamins, minerals. Okay, then metabolic pathways and inborn errors related with that metabolic pathway, specifically these inborn errors, glycogen storage disorder. Each year, each alternate year or each year there is question on glycogen storage disorder. So glycogen storage disorders, mucopolysaccharidosis, lysosomal storage disorder, specifically Gaucher's disease, the hyperlipoproteinemias, specifically type 1 and type 2. These are the frequently asked topic. Then starvations and the diabetic ketoacidosis is more frequently asked. Diabetic ketoacidosis, whether it is diagnostic criteria, whether it is electrolyte imbalance related with the diabetic ketoacidosis, whether it is metabolic acidosis or high causes of high and gap metabolic acidosis. Then glycogen phosphorylase regulation, specifically the direct regulation of glycogen phosphorylase and indirect regulation with the help of AMP, adenosine monophosphate in the muscle, and the calcium. These are the activators of glycogen phosphorylase, and how it is activated by the cascade mechanism via the glucagon and epinephrine is very important. Then epigenetic modification, specifically the acetylation of histone and methylation of the CG rich promoter region. These are the important topics: epigenetic modification, reversible heritable chemical modification above the genome without altering the nucleotide sequence, that is known as epigenetic modification. Then post transcriptional modification, specifically the splicing mechanism. उसकी डायग्राम पूछते हैं या तो अल्टरनेटिव स्प्लाइसिंग पे क्वेश्चन आता है. Then PCR के steps, blotting technique, match the pair in the blotting technique, and the FISH, the fluorescence in situ hybridization technique for the detection or the for the means. ये जो टेक्निक है ये क्रोमोसोम का स्पेशल पार्ट डिटेक्शन के लिए यूज की जाती है. दिस टेक्निक इट इज मेनली यूज इन द ट्रांसलोकेशन, एम्पलीफिकेशन, ऐसी चीजों में यूज होती है. द डिसएडवांटेज बोलो या लिमिटेशन इज द पॉइंट म्यूटेशन. फिश कैन नॉट डिटेक्ट द पॉइंट म्यूटेशन, एंड दिस इज very important MCQ for INI-CET examination. Then KM and VMAX, वैक्यूटेनर्स इंटर्नशिप हुई है काफी लोगों की. तो वैक्यूटेनर्स देयर यूजेस, कौन से कलर टॉप, कौन से मतलब कलर का टॉप जो है वो कौन से एनालाइट के लिए यूज किया जाता है, एंड ऑर्डर ऑफ ड्रॉ फॉर द कलेक्शन ऑफ ब्लड सैंपल. दिस इज very important. द special parameter is HbA1c, glycated hemoglobin, the non-enzymatic attachment of glucose to N-terminal valine of the beta globin chain, and the vacutainer which is used is EDTA, that is EDTA tube is used, that is पर्पल कैप. सीबीसी के लिए जो ट्यूब यूज होती है दैट इज यूज फॉर द HbA1c estimation, and the best method is the HPLC with ion exchange resins. Ion exchange chromatography is the best technique for detection of the glycated hemoglobin. Then amino acid and derivatives, for example tyrosine derivatives, tryptophan derivatives from the glycine, cysteine derivatives. These are the important topics recently. Glutes, the all-time favorite, glutes type 1, type 2, type 3, type 4, and type 5. Specifically first 5 types of the glutes, they are important. 2,3-BPG, the synthesis in the Rappaport Lubering cycle and role of 2,3-BPG is the important. And the STR, short tandem repeats in the DNA profiling. It is very important MCQ nowadays. Short tandem repeats, that is VNTR. nahi, short tandem repeats, it is a gold technique. Also the previously used technique is the VNTR and RFLP in the diagnosis of paternity, criminal, thieves, rapist, and the identity of the individual. So this DNA profiling techniques, this is very important for INI-CET examination. So this is gold rated topic. दिस इज 5 स्टार टॉपिक्स फॉर द INI-CET एग्जामिनेशन. ये जो यहाँ पे मेंशन है, ये फ्रिक्वेंटली इस पे क्वेश्चन किसी ना किसी एग्जाम में, INI-CET रहो, नीट पीजी रहो या FMGE रहो, ये तीनों एग्जाम में ये टॉपिक रिपीट होते हैं, बार बार रिपीट होते हैं. दीज आर द वेरी इंपॉर्टेंट टॉपिक फॉर INI-CET एग्जामिनेशन. नाउ लेट्स डिस्कस वन बाय वन अकॉर्डिंग टू अवर वर्कबुक. विल गो अकॉर्डिंग टू द वर्कबुक. We'll start with this. Read each deficiency manifestation carefully and write the name of the disease caused by deficiency of corresponding vitamins. So vitamins important है, mineral important है. Vitamin A, D, E, K, these are the fat soluble vitamin. Vitamin A. So see, deficiency manifestation, night blindness means nyctalopia, and the xerosis, that is, it is xerosis of conjunctival xerosis. This is vision impairment. This is vision impairment which is there in the vision impairment which is there in the xerophthalma, grading of the xerophthalmia, grading of the xerophthalmia, vision impairment, grading of the xerophthalmia. The X1, it is night blindness. X1 that is known as XN. XN is the night blindness. XN is known as night blindness. X1A, it is the conjunctival xerosis. X1B is the beat-out spot, triangular white spot on the conjunctiva because of increased keratin debris, because of the vitamin A deficiency. This vitamin involved is the vitamin A. Vitamin A. What are the important points related with the vitamin A? Vitamin A, it is important. With different forms of the vitamin A includes the retinol, retinoic acid, and beta carotene. These are the vitamins. Okay, then the vision के लिए कौन सा important है? 11-cis retinol, which is there in the rhodopsin. कौन सा form important है vision के लिए? The 11-cis retinol, the aldehyde form is important. The antioxidant property किसमें रहती है? Antioxidant property is there in the beta carotene. It is there in the beta carotene. So it is having the role in Wald's visual cycle. The deficiency of vitamin A causes the different manifestation. कौन से manifestations होते हैं विटामिन ए के deficiency में? See, vitamin A deficiency manifestation, that is vision impairment. Vitamin A deficiency causes the vision impairment. Also it causes the phrinoderma along with the multi-nutrient, मतलब essential fatty acid deficiency. Vitamin A deficiency also causes the phrinoderma, but this is vision impairment grading. Vision impairment, vision problem or vision involvement is there. That includes XN means night blindness. This is night blindness. X1A means the conjunctival xerosis. X1B means beat-out spot. X2 means corneal xerosis. X3A means involvement of the cornea, less than 1/3 part of the cornea is involved. And X3B means more than 1/3 of the cornea is involved. The corneal ulceration is there. So this is night blindness, that is known as nyctalopia. Night blindness. This is conjunctival xerosis. Vitamin A is very important. Each and every point related with the vitamin A is important. This is beat-out spot, triangular white spot on the foamy spot on the conjunctiva, beat-out spot because of the increased keratin debris. X2 means corneal xerosis. X3A means less than 1/3 of the cornea is involved. This is corneal ulcer involving less than 1/3 of the cornea. And this is X3B means corneal ulcer involving more than 1/3 of the cornea. This is X3B. Then XS, it is corneal scarring. This is scarring. And XF means xerophthalmic fundus. This is xerophthalmic fundus. So this is vision impairment grading of WHO in the vitamin A deficiency. Vitamin A deficiency also causes Phrynoderma, it is a skin condition where toad-like skin is there. Toad skin is there. This is because of the deficiency of vitamin A mainly, and also it is deficiency of essential fatty acid deficiency causes the phrynoderma. This is typically seen in the formula feed infant and also in the IV nutrition पे जो रहता है parenteral patient on parenteral nutrition affected with this toad skin appearance, horny eruptions on the extensor aspect of the arm and forearm. The involvement of back and buttock is there. Back, buttock and thighs, these areas are involved. There is blockage of the adnexal gland that gives the toad-like appearance. There is hyperkeratosis and acanthosis of the skin in the vitamin A deficiency. So phrynoderma is also a feature of vitamin A deficiency. Vitamin A, RDA of vitamin A, it is RDA. See, remember, this is also important, RDA. So vitamin A in the main, it is 1000 microgram. In women, it is 840 microgram. In pregnancy, it is 900 microgram, and in lactation, it is 950 microgram. This is very, very important. RDA, according to the updated summary of RDA in December 2024 by the NIN, National Institute of Nutrition, along with the ICMR and MOHFW. So this is very, very important. RDA, recent RDA about the vitamin A. And vitamin A excess causes the raised intracranial tension, that is known as pseudo tumor cerebri. Increase vitamin A, that is toxicity of vitamin A. Toxicity of vitamin A, it causes the increased intracranial tension, that is known as pseudo tumor cerebri. The symptoms like the space occupying lesion. So increased vitamin A damages the lysosome. It affects the liver. Hepatomegaly is there. It affects the lipid level. Dyslipidemia is there. Bone involvement is there, and there is increased intracranial tension, that is pseudo tumor cerebri in the vitamin A toxicity. So these are the important points related with the vitamin A. Second, see, bleeding gums, delayed wound healing, perifollicular hemorrhages, and corkscrew hairs. This is deficiency manifestation of scurvy. These are the deficiency manifestation of scurvy. Scurvy, it is due to vitamin C deficiency. Vitamin C deficiency, RDA of vitamin C, it is 65 to 80 milligram per day. 65 to 80 milligram per day, it is there in the citrus fruits. Okay, deficiency causes the bleeding gums, delayed wound healing, perifollicular hemorrhages, subperiosteal hemorrhage, joint hemorrhage, corkscrew hairs, that is white line of the Frankel in the radiological feature. The bleeding gums and delayed wound healing, these are related with the maximum features of vitamin C deficiency, scurvy. Vitamin C deficiency, these are related with the defective collagen synthesis because of the defect in hydroxylation of proline and the lysine. So vitamin C discuss karte hain, just wait. So this is vitamin A. Now vitamin C. See, vitamin C, it is specifically involved in the hydroxylation reaction. This is important. Hydroxylation reaction, it is important. Hydroxylation of proline and hydroxylation of lysine, it is important. So hydroxylation of proline, this proline is converted into hydroxylation of proline. This proline is converted into, just wait. Proline is converted into hydroxyproline, lysine is converted into hydroxylysine. This is hydroxyproline. This is hydroxylysine. This is very, very important step. Frequently asked in the your NEET PG INI-CET examination. This is prolyl hydroxylase. This is lysyl hydroxylase enzyme. Hydroxylase. So these are vitamin C dependent reaction. It requires hydroxylation reaction, requires vitamin C. So there is role of vitamin C and there is role of copper in the collagen synthesis. When these two are affected, there is defective collagen synthesis occurs. Specifically, the rigidity of the collagen, strength of the collagen is affected when vitamin C is not there. So vitamin C deficiency causes the delayed wound healing. It causes the gum bleeding because of the fragile blood vessels, bleedings in the the petechial rash, ecchymosis, hematomas are there. This is because of the increased capillary fragility because of the decrease in the vitamin C level and defective collagen synthesis. So vitamin C is related with the collagen synthesis. This is very, very important point in the scurvy to remember for the INICET examination. Okay, so this is scurvy. Then bone deformity in children and osteomalacia in adult, means it is rickets actually in children. It is known as rickets. Rickets, there are various types of rickets, and it is due to vitamin D deficiency. It is due to vitamin D deficiency. Now see the different forms of the rickets. Rickets to easy hai. All of you know that craniotabes, delayed closure of the fontanelle, frontal bossing, पिंग पोंग स्कल उसको बोलते हैं क्रेनियोटेबिस, द widened wrist, bowing of the legs, kyphosis, scoliosis, lordosis. These are the features of the rickets. Along with this, Harrison sulcus, the rachitic rosary is there in the rickets. So these are the features of rickets because of the decreased calcium level, decreased mineralization of bone due to the vitamin D deficiency. Vitamin D regulate the serum calcium level. So vitamin D deficiency causes the calcium deficiency. So decreased mineralization of bone is there in the rickets. So what are the different types of rickets? This is very, very important for the INI-CET examination. Now see, this is vitamin C. Now vitamin D. Vitamin D, it is synthesized. It is mainly synthesized. The precursor molecule is 7-dehydrocholesterol. 7-dehydrocholesterol. This is on exposure to the UVB rays. This 7-dehydrocholesterol in the stratum corneum layer of epidermis. In the stratum corneum layer of the epidermis, this 7-dehydrocholesterol, it is converted into cholecalciferol. It is known as cholecalciferol. This is known as vitamin D3. This is known as vitamin D3. This is activated in the liver and kidneys. This is activated in the liver and kidneys. It is converted into, in liver, it is converted into 25-hydroxy cholecalciferol. And this 25-hydroxy cholecalciferol, it is converted by the 1-alpha hydroxylase. It is converted into 125-dihydroxy cholecalciferol. Dihydroxy cholecalciferol. That's it. That is known as calcitriol. This is active form of the vitamin D. This is active form of the vitamin D. Calcitriol, it is active form of the vitamin D. It is produced in the kidneys by the 1-alpha hydroxylase. 1-alpha hydroxylase. This is controlled by the parathyroid hormone. 1-alpha hydroxylase in the kidneys. And this is 25-hydroxylase in the liver. Hydroxylase in the liver. So cholecalciferol, it is converted into 25-hydroxy cholecalciferol. Then this is in the skin, epidermis layer, stratum corneum layer of epidermis. It is converted into epidermis on exposure to the UVB rays. On exposure to the sunlight, this is converted into cholecalciferol. This is a storage form of the vitamin D. And this is a calcitriol, active form of the vitamin D. Whenever there is nutritional ricket, there is decrease in the 25-hydroxy cholecalciferol occur. There are number of types of rickets. कौन-कौन से rickets के type है? See, the types of rickets, it includes, so vitamin D dependent ricket. First is the vitamin D dependent ricket. This is type 1. It is 1. See, 1. It is 1. It is because of the 1-alpha hydroxylase defect. 1-alpha hydroxylase defect. This is first. Vitamin D dependent ricket type 1. 1-alpha hydroxylase defect. इसका डिफेक्ट रहा तो क्या होगा? ये बराबर रहेगा, ये नॉर्मल रहेगा, लेकिन इसकी लेवल कम रहेंगी. So remember this. So 1-alpha hydroxylase defect. Vitamin D dependent ricket type 2. Type 2, it is because of the receptor defect. Vitamin D receptor defects. So रिसेप्टर डिफेक्ट अगर रहा तो कैल्सिट्रॉयल की लेवल बढ़ जाती है. सो इंक्रीज इन द कैल्सिट्रॉयल लेवल ऑकर्स, क्योंकि रिसेप्टर रिस्पॉन्ड नहीं कर रहे, उसके वजह से. जैसे हमने किसी को आवाज दिया, वो रिस्पॉन्ड नहीं कर रहा, तो हमारा आवाज बढ़ जाता है, लाइक दैट. सो इट इज विटामिन डी डिपेंडेंट रिकेट टाइप 2 बिकॉज ऑफ द vitamin D receptor defect. This is second. Third, the hypophosphatemic ricket is there. Hypophosphatemic ricket. Hypophosphatemic ricket. In this, there is increase FGF23. So there is increase FG, fibroblast growth factor 23, which causes the renal wasting of the phosphorus. Renal wasting of the phosphorus. Renal wasting of the phosphorus. So there is decreased phosphate and normal calcium level. Normal calcium level is there. Decreased phosphate and normal calcium level. Also the normal parathyroid hormone. This is a फीचर नॉर्मल पैराथायरॉयड हार्मोन, क्योंकि बाकी इसमें कैल्शियम लो टू नॉर्मल रहता है या लो रहता है, लेकिन पैराथायरॉयड हार्मोन इंक्रीज रहता है. देयर इज हाइपर पैराथायरॉयडिज्म इन ईच एंड एवरी केस. सो देयर इज इंक्रीज इन द अल्कलाइन फॉस्फेटेज लेवल, देयर इज इंक्रीज इन द पैराथायरॉयड हार्मोन लेवल. सो इसमें पैराथायरॉयड नॉर्मल रहता है, हाइपोफॉस्फेटेमिक रिकेट में पैराथायरॉयड नॉर्मल रहता है. एंड द क्रोनिक रीनल फेल्यूर, रीनल रिकेट बोलते हैं जिसको, क्रोनिक रीनल फेल्यूर, there is in this the phosphorus level increases, the phosphate retention occur, for phosphorus levels are high in the chronic renal failure. So remember, the nutritional ricket is the first. Nutritional rickets जिसमें कैल्शियम एक तो नॉर्मल रहेगा. न्यूट्रिशनल रिकेट कैल्शियम क्या रहेगा, सी न्यूट्रिशनल रिकेट में कैल्शियम एक तो लो रहेगा या तो नॉर्मल रहेगा, लेकिन पैराथायरॉयड हार्मोन बढ़ा हुआ रहेगा. विटामिन डी डिपेंडेंट रिकेट टाइप 1 में 1 अल्फा हाइड्रोक्सिल इसका डिफेक्ट है, ये नॉर्मल रहेगा, ये डिक्रीज हो जाएगा. ठीक है, कैल्शियम फॉस्फोरस लो रहेंगे, इसमें भी कैल्शियम फॉस्फोरस लो रहेंगे, लेकिन यहाँ पे कैल्सिट्रॉल लेवल बढ़ा हुआ रहेगा. इसमें विटामिन डी डिपेंडेंट रिकेट टाइप 2. हाइपोफॉस्फेटेमिक रिकेट में फॉस्फेट की वेस्टिंग होती है बिकॉज ऑफ इंक्रीज प्रोडक्शन ऑफ फाइब्रोब्लास्ट ग्रोथ फैक्टर 23 दैट कॉजेज द रीनल वेस्टिंग ऑफ द फॉस्फोरस. कैल्शियम नॉर्मल है, पैराथायरॉयड नॉर्मल है इन हाइपोफॉस्फेटेमिक रिकेट. एंड क्रोनिक रीनल फेल्योर, देर इज एक्सक्रीशन ऑफ द देर इज इंक्रीज रिटेंशन ऑफ द फॉस्फेट ऑकर, सो फॉस्फेट लेवल इंक्रीजेस इन द सीरम in the chronic renal failure. These are the important features. So remember, in the nutritional ricket, see, this is nutritional ricket. Nutritional ricket, कैल्शियम लेवल जो रहेगा, सो कैल्शियम लेवल जो रहेगा एक तो नॉर्मल रहेगा या तो लो रहेगा, लो कैल्शियम रहेगा. phosphorus level, there is decrease in the phosphorus level. Parathyroid hormone, there is secondary parathyroidism, so parathyroid level increase in the nutritional ricket. Alkaline phosphatase level, ALP लेवल सभी में बढ़ा हुआ रहता, सभी टाइप्स ऑफ रिकेट्स में ALP लेवल बढ़ा हुआ रहता. और एक एडिशनल फीचर हम इधर लिखते जाएंगे, न्यूट्रिशनल रिकेट, देयर इज डिक्रीज इन द 25 हाइड्रोक्सी कोलेकैल्सिफेरॉल. कोलेकैल्सिफेरॉल डिक्रीज, दिस इज सेंसिटिव पैरामीटर, डिक्रीज 25 हाइड्रोक्सी कोलेकैल्सिफेरॉल, ये होगा न्यूट्रिशनल रिकेट. देन विटामिन डी डिपेंडेंट रिकेट टाइप 1, 1 अल्फा हाइड्रोक्सिलेज डिफेक्ट. सो 1 अल्फा हाइड्रोक्सिलेज डिफेक्ट, देर इज लो इन द कैल्शियम, लो इन द phosphorus, increase in the PTH hormone, increase in the alkaline phosphatase. But here the 25 hydroxy cholecalciferol, it is normal, but there is calcitriol level, calcitriol deficiency is there, calcitriol low, क्योंकि 1 alpha hydroxylase defect है. So vitamin D dependent ricket type 2, in the type 2 there is receptor problem, so calcium levels are low, phosphorus levels are low, parathyroid hormones are high, ALP levels are high, and vitamin D dependent ricket, it is type 2, so there is increased calcitriol level. Calcitriol level increases, in this calcitriol level increases. Then hypophosphatemic ricket, there is normal calcium level, the phosphate levels are low, this is a classical feature, phosphate levels are low, PTH level normal, alkaline phosphate level increases, and the vitamin D levels means normal to low vitamin D levels are there, but hypophosphatemic ricket is there. There is FGF 23, which causes the renal wasting of the phosphorus, and the phosphate levels are low. Then renal ricket का important feature है renal ricket का, the phosphorus levels, these phosphorus levels are high in the retention of phosphate occurs in the renal ricket. So these are the important points related with the rickets, different types of the rickets. ठीक है. So bone deformities in the children, that is craniotabes, frontal bossing, wide open fontanelle, then widening of the wrist, bowing of the legs, bowing of the legs, kyphosis, scoliosis, lordosis is there in the vitamin D deficiency. So it is rickets, vitamin D deficiency. ठीक है. Now see, peripheral neuropathy, muscle weakness, cardiac failure, and Wernicke-Korsakoff syndrome. These are the features related with the vitamin B1. Beriberi related symptoms are these. These are the symptoms. ये जो symptoms है, these are related with the beriberi. So इसके जो पहले दो symptoms है, कौन से? Peripheral neuropathy and muscle weakness. These are related with the dry beriberi. Cardiac failure, edema, accumulation of fluid in the various spaces. This related to the wet beriberi. And this Wernicke-Korsakoff syndrome, it is a manifestation in the chronic condition whenever there is deficiency of the vitamin B1, thiamine deficiency in chronic alcoholic, all in the malnutrition, malabsorption. There is chronic deficiency of vitamin B1 that causes the Wernicke-Korsakoff syndrome. So B1, it is frequently asked vitamin in the INI-CET examination. Thiamine. So thiamine, it is vitamin B1. Active form is thiamine pyrophosphate. It is required for the, this is required for the ATP generation. Vitamin B1, it is required for the ATP generation. It is very, very important. It is important for the pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, branch chain keto acid dehydrogenase, also the ketolase activity, and ATP generation. It is very, very important. So deficiency causes the neuropathy. Involvement of the heart is there, cardiomegaly is there in the wet beriberi, and this is a manifestation chronic for the longer duration of time. If it is deficient, it causes Korsakoff psychosis mainly, which is irreversible and because of the chronic deficiency of vitamin B1. So beriberi, this is thiamine deficiency, vitamin B1 deficiency, विटामिन B1 deficiency, thiamine. The polished rice consumption history अगर दी है, polished rice consumption, because vitamin B1 is there in the outer alluron layer of the whole grains. अगर पॉलिशिंग करते हैं हम राइस को, दैट रिमूव्स द 80% ऑफ द थायमिन एक्टिविटी एंड दैट कॉजेज द बेरीबेरी लाइक सिम्टम्स. बेरीबेरी का लिटरल मीनिंग होता है वीकनेस. बेरीबेरी, थायमिन डेफिशिएंसी causes dry beriberi, wet beriberi, infantile beriberi, and Wernicke-Korsakoff syndrome in the, just wait, this is vitamin B1, that is thiamine. Thiamine deficiency causes beriberi, deficiency causes dry beriberi, that involves the calf muscle mainly, dry beriberi. Neuropathy is there and the calf muscle tenderness is there, dry beriberi. Then second is the wet beriberi. The important word to remember here is high output cardiac failure. Remember this word, high output cardiac failure. There is marked peripheral vasodilation in the absence of vitamin B1. So it causes high output cardiac failure, low blood pressure, and there is edema and accumulation of fluid in all spaces, pericardial, peritoneal, pleural spaces. There is accumulation of fluid occur. That's why it is known as wet beriberi. Dry beriberi, it is neuropathy. It is neuropathy in the dry beriberi. Calf muscle tenderness is there. Calf muscle tenderness is there. The history should be tenderness. Polished rice consumption history अगर है, so go with the beriberi. Polished rice consumption, because it is there in the outer alluron layer of the whole grains. Then third one is the infantile beriberi, जिसमें serious manifestation रहते हैं. Infantile beriberi, there are serious manifestation. And fourth, chronic deficiency for longer duration of time. It causes the Wernicke-Korsakoff syndrome. This is again very, very important feature, chronic deficiency. Also malnutrition भी रहा तो भी chronic deficiency. Actually acute deficiency causes the Wernicke's encephalopathy and chronic deficiency causes the Korsakoff syndrome. Okay, Korsakoff syndrome is irreversible condition, condition related with the chronic deficiency. Severe deficiency बोलो, severe deficiency causes the Wernicke's Korsakoff syndrome. So Wernicke's, it includes Wernicke's encephalopathy, and Korsakoff psychosis is there. Korsakoff psychosis is there. So there are features. So it is, remember this by this mnemonic GOA MP. See, it is global confusion, ophthalmoplegia, paralysis of the ocular muscle, ophthalmoplegia, ataxia, memory loss, psychosis, confabulation is there, false creation, fabrication of memory is there. अगर आपको आपने पेशेंट को पूछा कि सुबह आपने क्या किया, वो कहीं पे भी नहीं गया होगा, रूम पे बैठा होगा, तो भी वो बोलेगा कि मैं जाके मार्केट में सब्जी सब्जी लेके आया, ऐसा बताएगा. सो फैब्रिकेशन ऑफ मेमोरी इज देयर, false creation of memory is there. So confabulation is the feature of Korsakoff psychosis. For checking the vitamin B1, we check the RBC transketolase activity. Diagnosis, it is by the RBC transketolase activity. RBC transketolase activity. So remember this for the B1. B1 is very, very important vitamin. ठीक है. Then dermatitis, diarrhea, dementia, all of you know that the typical Castle's necklace dermatitis involving the sun exposed part of the body, the glow and stalking appearance of the hand and feet, and the Castle's necklace dermatitis is there in the niacin deficiency, that is pellagra. Niacin deficiency pellagra. So niacin, it is connected with the tryptophan, इसलिए इस पे क्वेश्चन आता है. 60 milligram of tryptophan will give you 1 milligram of niacin. 1 milligram of niacin. So niacin, it is connected with the tryptophan pathway. So those diseases जो ट्रिप्टोफैन पाथवे को अफेक्ट करते हैं, जैसे कि कार्सिनाइड सिंड्रोम हो गया, या हार्ट नर्व्स डिसीज हो गया, डिफेक्टिव एब्सॉर्प्शन ऑफ ट्रिप्टोफैन इज देयर. देन हाई जवार कंजम्पशन दैट इनहिबिट द QPRTase enzyme of the tryptophan to niacin conversion. Then vitamin B6 deficiency also causes the niacin deficiency. So these are the causes of niacin deficiency. Then this is very rare syndrome, that is burning feet syndrome, that is feeling of hotness in the leg, leg. It is because of the vitamin B5, that is pantothenic acid deficiency. Very rare, because B5 is there in the most of the food stuff. So there is burning sensation and pain and heat in the feet. Only feet is involved, so that is burning feet syndrome. No other manifestations will be there. Okay. Then microcytic anemia, seizures and neuropathy, it is there in the vitamin B6 deficiency. Vitamin B6 is important for the generation of or synthesis of neurotransmitter, specifically by the decarboxylation reaction, and it is important in the heme synthesis. That's why it is very, very important vitamin B6. Pyridoxine is important vitamin. Pyridoxine, it is important for the decarboxylation and synthesis of neurotransmitter. It is important in the transamination reaction, transsulfuration reaction, heme synthesis reaction. That's why vitamin B6 deficiency causes the anemia. It causes the microcytic anemia and the seizure and neurological features because its involvement in the synthesis of the neurotransmitter. So vitamin B6 deficiency, pyridoxine. Okay, so microcytic anemia, seizures and neuropathy is there in the vitamin B6 deficiency. Then megaloblastic anemia, neural tube defect. It is related with the folate deficiency. This is folate deficiency anemia, folate deficiency megaloblastic anemia बोलते हैं इसको, megaloblastic anemia. Okay, and if there is chronic deficiency in the pregnancy, it can cause the neural tube defect in the child. This is in the child, neural tube defect in the child if the pregnancy. इसीलिए हम ANC visit को आती है तो folic acid के tablet देते हैं. Folic acid, the requirement in pregnancy, folic acid is 570 microgram per day, RDA of folic acid in the pregnancy. अभी ये दोनों देखेंगे हम एक साथ, just wait. This is folate, related with the folate. And megaloblastic anemia with neurological, if there is neurological manifestation, it is because of the B12 deficiency. So it is megaloblastic anemia with subacute combined degeneration of spinal cord, subacute combined degeneration of spinal cord with megaloblastic anemia, degeneration of spinal cord with megaloblastic anemia is there. It is in the B12 deficiency. It is there in the B12 deficiency. ठीक है. As such, folate is not as such B12 is not related with the RBC maturation. Folate is related with the RBC maturation, but there is one common link to this, that is the methionine synthase reaction. Methionine synthase वाली जो reaction है वो common link है B12 और folic acid के बीच की. So see, this is folate trap बोलते हैं वो reaction को. ये वाली reaction है वो. So there is homocysteine. It is converted into, this homocysteine is converted into methionine. This is converted into methionine. This is with the help of enzyme methionine synthase. Methionine synthase. This is a reaction important, catalyzed by the B12. This is B12 dependent reaction. B12 dependent reaction. In this reaction, the methyl B12, methyl tetrahydrofolate, it is converted into tetrahydrofolate. ठीक है. सो यहाँ पे दोनों विटामिन लग रहे हैं, B12 भी लग रहा है और फोलिक एसिड भी लग रहा है. सो इफ देर इज ब्लॉक इन दिस रिएक्शन, अगर यहाँ पे ब्लॉक होता है, इफ देर इज विटामिन B12 डेफिशिएंसी, अगर इसकी डेफिशिएंसी हो गई, तो दिस फोलेट इज ट्रैप्ड एज मिथिल टेट्राहाइड्रोफोलेट एंड देर इज नो अदर यूज ऑफ दिस methyl tetrahydrofolate. Folate is there, but there is functional folate deficiency, and this is known as folate trap. In B12 deficiency, folate is trapped as methyl tetrahydrofolate. Folate is trapped as methyl tetrahydrofolate, और इसका कुछ काम नहीं है. यहाँ पे मैं आपको 1 कार्बन मेटाबॉलिज्म भी बता देता हूँ फोलिक एसिड से रिलेटेड. सी, फोलिक एसिड मेटाबॉलिज्म में 1 कार्बन मेटाबॉलिज्म इज देयर. 1 कार्बन मेटाबॉलिज्म, इट इज वेरी वेरी इंपॉर्टेंट. रिमेंबर, दिस इज लाइक दिस, Y, E and F. Okay, so see, this is methylene tetrahydrofolate. This is methenyl tetrahydrofolate. इसलिए बीच वाले बताया मैंने. सो देयर इज मिथाइलिन टेट्राहाइड्रोफोलेट, मिथेलिन टेट्राहाइड्रोफोलेट, मिथेनिल टेट्राहाइड्रोफोलेट एंड फॉर्मिल टेट्राहाइड्रोफोलेट. ये फोलेट का मेटाबॉलिज्म है, फॉर्मिल टेट्राहाइड्रोफोलेट. ओके, सो नाउ दिस फॉर्मिल टेट्राहाइड्रोफोलेट, इट इज कन्वर्टेड इनटू मिथेनिल टेट्राहाइड्रोफोलेट. It is converted into methylene tetrahydrofolate. These are the reversible reactions, but only this is irreversible reaction. It is converted into methyl tetrahydrofolate. Okay, so ये जो है, this methyl tetrahydrofolate, it is required for conversion of homocysteine into methionine. जो अभी हमने रिएक्शन देखी, ये रिएक्शन को ये लगता है, ये एक ही रिएक्शन को ये लगता है, ये इरिवर्सिबल रिएक्शन है, बाकी ये इंटरकन्वर्टेबल है. ये मिथिल टेट्राहाइड्रोफोलेट होमोसिस्टीन टू मिथ्योनिन कन्वर्शन में लगता है. ठीक है. मिथाइलिन टेट्राहाइड्रोफोलेट जो है, ये जो है, दिस इज रिक्वायर्ड फॉर कन्वर्शन ऑफ ग्लाइसिन इनटू सीरीन. This is required. Also, this is required for synthesis of the that is deoxy UMP, uridine monophosphate. It is converted into deoxy TMP, thymidine monophosphate, means pyrimidine nucleotide synthesis. के लिए लगता है. और ये जो है मिथिनिल टेट्राहाइड्रोफोलेट, it is required for the C8 of the purine synthesis. This is required for the C8 of the purine, and this is required for the C2 of the purine synthesis, purine nucleotide synthesis. तो ये फोलेट का मेटाबॉलिज्म है. फोलेट का ये है. ठीक है, 1 कार्बन मेटाबॉलिज्म बोलते हैं इसको. सो दिस इज रिक्वायर्ड फॉर द C2 of the purine. It is mainly from the glycine and the tryptophan. You will get formyl tetrahydrofolate. From histidine, you will get methenyl tetrahydrofolate. From serine, from glycine, from the choline, you will get methylene tetrahydrofolate. These are the sources, and this is utilization. This is how utilization. तो फोलेट के 5 यूजेस है इंपॉर्टेंट. कितने यूजेस है? फोलिक एसिड के 5 यूजेस है इंपॉर्टेंट है. B12 के दोनों रिएक्शन और फोलेट के 5 रिएक्शन सभी इंपॉर्टेंट है. सी, सो दिस इज फर्स्ट conversion of glycine into serine, conversion of thymidylate, that is the pyrimidine nucleotide synthesis. This is homocysteine to methionine conversion. This is C8 of the purine and C2 of the purine synthesis. This is required. This folic acid is required. Okay, if B12 deficiency is there, folate deficiency is there, folate deficiency affect the purine and pyrimidine nucleotide synthesis. प्यूरिन एंड पायरिमिडिन न्यूक्लियोटाइड सिंथेसिस अफेक्ट होने की वजह से डीएनए का साइज छोटा हो जाता है, न्यूक्लियस का साइज छोटा रहता है, सेल ग्रोज विदाउट ए सेल डिवीजन, दैट्स व्हाई देयर इज megaloblastosis, there is macrocytosis, cell grows without cell division, so that's why there is macrocytosis in the folate deficiency mainly, but it is connected with the B12 in this step. It is connected with B12 in this step. That's why B12 deficiency also causes the megaloblastic anemia. Then again B12 deficiency, B12 catalyzes one more reaction. ये एक हो गई B12 की रिएक्शन, दूसरी ये रिएक्शन है, दिस इज प्रोपियोनिल कोएंजाइम A. This is propionyl coenzyme A, which is converted into methyl malonyl coenzyme A. This is converted into methyl malonyl coenzyme A. This is gluconeogenesis from odd chain fatty acid, 3 carbon odd chain fatty acid, and this methyl malonyl coenzyme A, D-methyl malonyl coenzyme A is converted into L-methyl malonyl coenzyme A, and this methyl malonyl coenzyme A is converted into succinyl coenzyme A. Succinyl coenzyme A. तो ये जो रिएक्शन है दैट इज मिथिल मैलोनिल कोएंजाइम ए म्यूटेज, मिथिल मैलोनिल कोएंजाइम ए म्यूटेज, दिस इज अ B12 डिपेंडेंट रिएक्शन. ये B12 डिपेंडेंट रिएक्शन है. B12 एडिनोसिल B12 इज रिक्वायर्ड फॉर दिस स्टेप, मिथिल मैलोनिल कोएंजाइम ए म्यूटेज. अगर ये ब्लॉक है, ये रिएक्शन अगर ब्लॉक है, तो there is elevated level of methyl malonic acid, so methyl malonyl acid increases, methyl malonic acidemia is there, methyl malonic acidemia is there, so methyl malonate increases and it affect the fatty acid synthesis, it affect the myelin synthesis, it affect the myelin synthesis, myelin synthesis, it interferes with the myelin synthesis, and there is subacute combined degeneration of spinal cord occurs, subacute combined degeneration of spinal cord occur. So the features are, there is involvement of the posterior column, so posterior column is involved, also the lateral corticospinal tracts, lateral posterior column and lateral corticospinal tracts, they are involved, corticospinal tract, they are involved. So there is loss of these are the features: loss of vibratory sense, loss of vibration, loss of position sense is there. So Romberg sign is positive, so positive Romberg sign is there in the subacute combined degeneration of spinal cord. So this is neurological feature अगर है और megaloblastic anemia है, मिथिल मैलोनिक एसिड लेवल अगर बढ़ा हुआ है, मिथिल मैलोनिक एसिड लेवल बढ़ा हुआ बताया है, और वेजिटेरियन डाइट है, वेजिटेरियन अगर डाइट है, so that indicates the B12 deficiency, if there is Figlu excretion of urine on the histidine load test, that is farm immunoglutamic acid excretion in the urine, in the folate, so there is folate is required for this step. So folic acid, it is histidine load test, folate is histidine is converted into farm immunoglutamic acid, and it is converted into L-glutamate, by the tetrahydrofolate, it is converted into with the help of this tetrahydrofolate is converted into farm immunotetrahydrofolate. So tetrahydrofolate is required. If there is deficiency of this, there is excretion in the urine, Figlu excreted in the urine in the folate deficiency. So in the folate deficiency, Figlu excretion in the urine, in the B12 deficiency, methyl malonic acid excreted in the urine. Neurological features are there in the B12 deficiency. Vitamin B9 folate deficiency, if there is in the pregnancy, it is neural tube defect, folate deficiency in the pregnancy. RDA कितना है दोनों के RDA अच्छे से करो और दोनों के sources. See B12 it is there in the food of non-veg, मतलब non-vegetarian food, it is produced by the intestinal bacteria, it is there in the non-veg food, and folic acid is there in the vegetables, remember this, it is there in the vegetables. The requirement of folic acid requirement, it is for men it is 300 microgram, for women it is 220 microgram, in pregnancy it is 570 microgram, see the change, 570 microgram, and in lactation it is 330 microgram. This is folic acid. विटामिन B12 का कैसा है? विटामिन B12 इन द मेन इट इज 2.2 microgram. Women it is 2.2 microgram. In pregnancy it is 2.4 microgram, and in lactation it is 3.2 microgram per day. So this is RDA, folic acid, and the B12. Remember this RDA 570 microgram in the pregnancy, folic acid 570 microgram in the pregnancy. So this is about the B12 and the folic acid. उसके बाद में क्या था? ये तो वेल नोन इमेज है, इमेज बेस्ड क्वेश्चन रिलेटेड विद द यस पेलाग्रा, नियासिन deficiency, Castle's necklace dermatitis. See, 34-year-old male was on maize as a staple diet. maize में जो नियासिन रहता वो बाउंड फॉर्म में रहता, वो it is unavailable for the absorption. So as a staple diet for prolonged period, he presented with diarrhea and lesion over his neck as shown in the image below. The condition occurs due to deficiency of niacin. The condition is known as pellagra. Maize diet में क्या है? The niacin, it is present in bound form. This is Castle's necklace dermatitis. Also there is glove and stocking appearance of hand and feet in the niacin deficiency. Niacin तो tryptophan to niacin जो भी disorder है, जैसे कि carcinoid syndrome is there, Hartnup disease is there, then the jawar with high leucine content is there in the jawar, which inhibit the QPR-tase. The vitamin B6 deficiency is there that causes the niacin deficiency. Which vitamin is deficient? Triangular white opaque spot on conjunctiva. This is Bitot spot. Vitamin A deficiency. This is Bitot spots. Increased keratinization. Bitot spot. Vitamin A deficiency. ठीक है, ये हमारा विटामिन्स हो गया. जस्ट वेट. हाय एवरीवन. जस्ट वेट. चलो अभी मिनरल्स पे जाते हैं. Read each deficiency manifestation carefully and write the name of disease and the mineral involved. Microcytic hypochromic anemia, fatigue, pallor, increased total iron binding capacity, decreased ferritin level. Ferritin is a sensitive indicator for the iron. This is known as iron deficiency anemia. Iron deficiency anemia. Mineral involved, iron. What is RDA of the iron? Main it is 19 milligram. Women it is 29 milligram. Pregnancy it is 27, and lactation it is 23 milligram. Lactation it is 23 milligram. This is requirement of the iron. It is present in the green leafy vegetable and the food of animal origin. The iron is there. The jaggery, dry fruits, the beetroot, these are the sources of the iron. How iron is absorbed? It is known as one-way element. There is mucosal block theory. Very less amount of iron is excreted from the body. So it is absorbed through the intestine. It is absorbed through the intestine via the divalent metal ion transporter. Remember this DMT1. DMT1 helps in the absorption of iron. Divalent metal ion transporter 1. It absorbs the iron and it is out of the intestinal cell through the ferroportin. Through a ferroportin. And which protein regulate the iron level? It is hepcidin, which is a peptide synthesized from the liver in response to the high iron level. So it decreases the absorption of the iron by degradation of this ferroportin and divalent metal ion transporter. So hepcidin regulates the iron level. Iron deficiency anemia. These are the features. Laboratory picture: microcytic hypochromic anemia, fatigue, pallor, increased total iron binding capacity, decreased ferritin level is there. Then goiter, cretinism, hypothyroidism. This is actually goiter. It is endemic goiter. Cretinism is when in the pregnancy the deficiency is there. Deficiency causes chronic deficiency in the pregnancy causes affect the child affect the child, that is known as cretinism. Mental retardation is there, developmental delay is there, the enlarged tongue and the precocious puberty, these are the features of the cretinism. Very matlab severe deficiency of iodine in the pregnancy. So it is related with the iodine. The requirement of iodine, it is 140 microgram per day. Pregnancy may it is 220 microgram per day, 220 microgram per day in the pregnancy. So there is enlargement of thyroid gland to trap the iodine. So iodine deficiency goiter, it is related with the iodine. So goiter, hypothyroidism, cretinism related with the iodine. Iodine, it is very, very important mineral. It is important for the synthesis of T3 and T4. And which amino acid is required for the synthesis of T3 and T4? It is iodine. It is important for synthesis of the T3 and T4 from the tyrosine. Tyrosine से बनाता है, from tyrosine. Amino acid which is involved in the T3 and T4 synthesis, it is tyrosine. Then cardiomyopathy, hair loss and nail brittleness. Cardiomyopathy, this is found particularly in certain regions of the China. The soil is having the low levels of the selenium, so it is known as Cation disease. This is known as Cation disease. Cation disease, and it is related with the selenium. Selenium, this is an important antioxidant mineral. Selenium, antioxidant mineral. It is mainly required for the three important enzyme. कौन से तीन एंजाइम के लिए लगता है सेलेनियम? एक ग्लूटाथियोन पेरोक्सीडेज, deiodenase and thioredoxin reductase. So it is having the glutathione peroxidase is having the antioxidant function. So important antioxidant mineral, works synergistically with the vitamin E. So selenium deficiency causes the Cation disease, that is cardiomyopathy. Cation disease, cardiomyopathy. Impaired glucose tolerance, सी यहाँ पे जिंक के साथ आपको confusion हो सकता है. Impaired glucose tolerance, it is seen in the chromium deficiency. Remember chromium, it causes glucose intolerance, and the metal which is important for the impaired glucose tolerance, that is seen in diabetes, it is due to the chromium deficiency. Chromium is a part of glucose tolerance factor. It is a part of glucose tolerance factor which is composed of chromium plus niacin plus three amino acid, that is glutamate, glycine and the cysteine. This is known as glucose tolerance factor. This chromium enhances the action of insulin, potentiates the action of insulin by acting on the tyrosine kinase activity of the insulin receptor. It enhances the tyrosine kinase activity of insulin receptors. Remember, this is action of the chromium. It enhances the tyrosine kinase activity of insulin receptors, so it potentiates the action of the insulin. Chromium potentiates the action of the insulin. Zinc क्या करता है? Zinc causes the release and storage of insulin. Zinc is required, but chromium is required for the potentiation of action of the insulin. It causes it increases the tyrosine kinase activity of the enhances the tyrosine kinase activity of the insulin receptor. So this is important function related with the chromium. Periorificial rash, delayed wound healing, loss of taste sensation, impaired spermatogenesis, decrease wound healing, मतलब decrease vitamin A level in the serum. See, periorificial rash, delayed wound healing, loss of taste sensation, impaired spermatogenesis, the frequent diarrhea, and vitamin A level, drop down in the vitamin A level, circulating vitamin A level in the serum. These are the features of the, this is actually feature of the zinc deficiency. This is related with the zinc. If it is in the child, the transporter defect, the autosomal recessive transporter defect in the child, that is known as acrodermatitis enteropathica. Acro मतलब acral part of the body, finger, nose, toes, mouth. Dermatitis, that is specifically the Periorifacial dermatitis, around the mouth, around the anal area, the finger, nose, toes, mouth, these are the areas involved in the zinc deficiency. Acrodermatitis enteropathica, entero matlab intestine, enteropathica, there is decreased absorption from the intestine because of the affected transporter. Acrodermatitis enteropathica, zinc deficiency. Zinc is related with the number of enzymes, specifically carbonic anhydrase, superoxide dismutase, various dehydrogenase, RNA polymerase. So this is involved. The ALA dehydratase, these are the enzymes related with the zinc. So zinc deficiency causes lot of manifestation. Zinc is required for the immunity. So zinc deficiency causes the diarrhea. Zinc is required for the metalloprotein synthesis, metalloproteinase synthesis. So connective tissue synthesis, zinc is required. So deficiency causes the defective wound healing. It is there in the test buds, that is gustin, which is the protein there in the test bud which is having the zinc. So deficiency causes loss of taste sensation. It is required for maintaining the vitamin A level in the serum. So deficiency also causes the decrease in the vitamin A activity. So zinc deficiency is connected with the night blindness. Remember, the vitamin A का level maintain करने के लिए zinc लगता है. So that's why night blindness sometimes can be mentioned in the, so read the question carefully. So these are the manifestations related with the zinc deficiency. Then carpopodal spasm, tremor, stridor, convulsion. This is the cats of hypocalcemia: convulsion, tremor, spasm, stridor. This is and that is tremor and tetany. That is carpopedal spasm. It is seen in the hypocalcemia when the serum calcium level goes below 6 milligram per deciliter. This is unopposed action of the sodium which causes the carpopedal spasm. There is decreased threshold of depolarization. Unopposed, जो ब्रेक लगाया हुआ रहता है कैल्शियम में, that is lost because of the hypocalcemia, and there is carpopedal spasm in the tetany, carpopedal, cats of hypocalcemia, convulsion, arrhythmias, tremor, tetany, spasm, stridor. These are the symptoms of hypocalcemia. So this is related with the calcium. So the calcium requirement in men, women and pregnancy, it is 1000 milligram. Lactation, it is 1200. So men, women, pregnancy, lactation. So for this it is 1000 milligram, and for lactation it is 1200 milligram per day. It is present in milk product. It is present in the milk product. So ये था डिस्कशन हमारा पूरा विटामिन्स और मिनरल्स पे. विटामिन्स और विटामिन मिनरल का ईच एंड एवरी पॉइंट इज इंपॉर्टेंट. Now coming to the another topic. C, fill in the blanks with specific enzyme markers for each cell membrane organelles. So these cell membrane organelles, they are separated. They are separated by the density gradient. That is sucrose density gradient is used. Sucrose density gradient is used, and in the ultracentrifuge. Gradient in ultracentrifuge. In ultracentrifuge, it is used to separate the different subcellular organelles. So plasma membrane, the marker for the plasma membrane is the adenylyl cyclase or sodium potassium ATPase or 5' nucleotidase. Adenylyl cyclase, sodium potassium ATPase, and 5' nucleotidase. These are the marker for the plasma membrane. Okay. After the separation in the sucrose density gradient in the ultracentrifuge tube, it is confirmed with the help of this enzymatic marker. Endoplasmic reticulum, it is glucose 6-phosphatase. Endoplasmic reticulum. Inner mitochondrial membrane, it is ATP synthase, inner mitochondrial membrane marker. Golgi apparatus, it is galactosyl transferase for the Golgi apparatus, galactosyl transferase. For the cytoplasm, it is lactate dehydrogenase. Then lysosome, it is cathepsin or acid phosphatase. Also acid phosphatase. phosphatase, this is for the lysosome, and peroxisome it is catalase. So these are the different markers for the subcellular organelles. इस पे क्वेश्चन आके गया है इसलिए हमने ये लिया है. Okay, these are the different markers for different subcellular organelles. They are separated in the ultracentrifuge in the sucrose density gradient. Across the sucrose density gradient they get separated, and after separation they are confirmed by measuring these markers. So they measuring these marker levels. So these are the markers for identification of the subcellular organelles. Now see, this is very important table. Fill in the blanks with the correct substrate or function of each ABC, means ATP binding cassette transporter. ABC मतलब ATP binding cassette transporter. These are the types of active transport. So here the transport protein is mentioned. This is their function, and this is the disease related with this transporter. So this is very important. This is in the pediatric, very important, and also in the biochemistry it is important topic. So see, ABC-A1, ATP binding cassette transporter A1, it is defective. See, it is required for the transport of cholesterol. It is required for transport of cholesterol from tissues to the HDL. It is important to convert the discoidal HDL into spherical HDL. The deficiency of this ABC-A1 causes the Tanger's disease. Yellow orange colored tonsil, the hepatosplenomegaly is there, and the neuropathy is there. Yellow orange color tonsil, this is a pathognomic, matlab it is an important feature of the Tanger's disease. Alpha lipoprotein deficiency, HDL levels are low to 0, means 0 to low HDL levels are there. 0 to low HDL level, 0 to low HDL is there, and orange color tonsils, orange tonsils. This is a feature, tonsils. This is a feature of Tanger's disease. Then ABC-C2, ATP binding cassette transporter C2, या तो मल्टी ड्रग रेजिस्टेंट प्रोटीन टू MRP2 या मल्टी स्पेसिफिक ऑर्गेनिक एनायन ट्रांसपोर्टर MOAT, ABC-C2. This is required for secretion of bilirubin into bile. This is active process, rate limiting process. This is required for secretion of bilirubin into bile canaliculi. This is active transport. This is active transport, and this is a rate limiting step in the bilirubin metabolism. Rate limiting step in the bilirubin metabolism. Step in bilirubin metabolism की rate limiting step है this one. So this is secretion of bilirubin into bile canaliculi. If there is defect in this ABC-C2 or MRP2, it causes Dubin-Johnson syndrome. There is increase in the direct bilirubin. So direct bilirubin increases, direct bilirubin increases. There is mild bilirubinemia. माइल्ड बिलिरुबिनेमिया, 2 से 5 तक बिलिरुबिन बढ़ता है, 2 से 5 तक माइल्ड बिलिरुबिनेमिया, डायरेक्ट बिलिरुबिन. ऑल्सो दिस इज नोन एज ब्लैक लिवर जॉन्डिस. Black staining of liver is there in the Dubin-Johnson syndrome. ATP7A, 7B mutation. All of you know that this is required for the copper transport. ATP7A mutation, this is affect the absorption of the copper, and ATP7B mutation affect the excretion of the copper. So absorption of the copper from the intestine, ATP7A is needed. The deficiency causes the Menkes disease. आगे जाके हम इसको देखने वाले हैं. And the ATP7B, it is important for excretion of the copper, excretion and incorporation of copper into ceruloplasmin, excretion into a bile. It is important. This is copper excess. ATP7B mutation causes the Wilson's disease. So this is very important. Menkes disease, Wilson's disease. This is neurodegenerative disorder. Menkes disease, mental retardation, hypopigmented patches. Lysyl oxidase enzyme is affected here. Lysyl oxidase in the Menkes disease. Wilson's disease, there is hepatolenticular degeneration. There is KF ring in the cornea, and there is because of accumulation of copper in the lens, it causes the sunflower cataract. CFTR mutation, it affects the chloride channel. It is there in the cystic fibrosis. Recently एक movie आया, the हाई पापा नाम की एक 65 रोजेस बोलती है वो बच्ची, सिस्टिक फाइब्रोसिस को 65 रोजेस बोलती है. सो वो एक मूवी है, और 5 फीट अपार्ट करके एक हॉलीवुड की भी मूवी है. दे कैच द रिकरेंट इन्फेक्शन बिकॉज ऑफ द प्लगिंग ऑफ द ऑल ग्लैंड्स एंड द विस्कस, मतलब थोड़े से सॉलिड सेमी सॉलिड सिक्रीशंस हो जाते हैं, उसके वजह से ऑब्स्ट्रक्टिव लंग डिसीज इज देयर इन द सिस्टिक फाइब्रोसिस. सो क्लोराइड ट्रांसपोर्टर and there is sweat chloride level, increase in the sweat chloride level occur in the cystic fibrosis. MDR1 drug efflux, this causes, this is responsible for pumping out the chemotherapeutic cancer agent out of the cells. So this is responsible for the resistance to the cancer agent. So MDR1, multi-drug resistance in the cancer. So these are the ABC transport protein. These are their functions, and these are the diseases related with this ABC transport protein. फिल इन द ब्लैंक विद द करेक्ट रेट लिमिटिंग एंजाइम ऑफ द मेटाबॉलिक पाथवे. इसके साथ साथ ना ये थोड़ा सा मतलब ये अभी तक तो आपको याद हो गया होगा जो लोग प्रिपेयर कर रहे हैं आईएनआईसीटी के लिए, लेकिन कुछ कुछ जो एंजाइम्स है उनका ये भी करना है आपको, रेगुलेशन भी करना है. जैसे कि फैटी एसिड सिंथेसिस, द रेट लिमिटिंग एंजाइम इज एसिटिल कोएंजाइम ए कार्बोक्सिलेज. Acetyl coenzyme A carboxylase. This is a rate limiting enzyme. How it is regulated? It is regulated by CID. Remember this CID, citrate insulin and dephosphorylated state promotes this acetyl coenzyme A carboxylase. Remember citrate, insulin, and this enzyme is active in the dephosphorylated state. Phosphorylated state, dephosphorylated. So size, just wait. So it is citrate, insulin, and dephosphorylated state of the enzyme which regulates this enzyme, that is fatty acid synthase complex. Important enzyme in the fatty acid synthesis which causes the conversion of acetyl coenzyme A into malonyl coenzyme. Just wait. तो कौन सी रिएक्शन कैटालाइज करता है? जस्ट वेट, ये कहाँ से आया? ये वाली रिएक्शन कैटालाइज करता है एसिटिल कोएंजाइम ए. ये 2 कार्बन वाला कंपाउंड है. इट इज कन्वर्टेड इनटू मैलोनिल कोएंजाइम है. रेट लिमिटिंग स्टेप है, बायफंक्शनल या मल्टीफंक्शनल एंजाइम है. मल्टीफंक्शनल एंजाइम है. ओके ये रिएक्शन को 3 चीजें लगती, एबीसी, एटीपी, बायोटिन एंड CO2. ATP, biotin, ABC, ATP, biotin, and CO2 it is required for this reaction. So remember acetyl coenzyme carboxylase, it is activated in presence of citrate insulin and it is active in the dephosphorylated state. Then glycolysis phosphofructokinase, it is a bottleneck of glycolysis. It is a rate limiting enzyme of glycolysis phosphofructokinase. It is activated by ये दोनों का तो एटलीस्ट करो, कम से कम ये दोनों का करो. इट इज एक्टिवेटेड बाय दिस फॉस्फोफ्रुक्टोकाइनेज. इट इज एक्टिवेटेड बाय two important molecule and it is inhibited by citrate and ATP. It is activated by AMP in the muscle. Activated by AMP in the muscle. It is activated by AMP and it is activated by fructose 2,6 bisphosphate. Fructose 2,6 bisphosphate. It is inhibited by citrate and ATP. Also cyclic AMP inhibit this phosphofructokinase, bottleneck of the glycolysis. Then beta oxidation of fatty acid, carnitine acyl transferase is the rate limiting enzyme. It is inhibited by the malonyl coenzyme A. Then gluconeogenesis, rate limiting enzyme is fructose 1,6 bisphosphatase. Ketone body synthesis, HMG coenzyme A synthase is the rate limiting enzyme. Ketone body synthesis, HMG coenzyme A synthase. Cholesterol synthesis, the HMG coenzyme A reductase. Hydroxymethyl glutaryl coenzyme A reductase, this is the rate limiting enzyme. Insulin promote this and dephosphorylated state promote this enzyme. It is under the feedback regulation. Glycogen synthesis, the glycogen synthesis is the rate limiting enzyme. Glycogen degradation, glycogen phosphorylase. Remember the AMP in the muscle is the direct activator. AMP in muscle, it is direct activator of this glycogen phosphorylase. This is direct activator, while the calcium is the indirect activator. Remember this, calcium is the indirect activator of this ग्लाइकोजन फॉस्फोराइलेज, इस पे एमसीक्यू आके गया है। एएमपी इन द लो मिस एएमपी इन द मसल इज द डायरेक्ट एक्टिवेटर ऑफ ग्लाइकोजन फॉस्फोराइलेज, व्हाइल द कैल्शियम इज द इनडायरेक्ट एक्टिवेटर। कैल्शियम एक्चुअली इसके पहले वाले स्टेप को एक्टिवेट करता है, ग्लाइकोजन फॉस्फोराइलेज को नहीं, उसके फॉस्फोराइलेज काइनेज को एक्टिवेट करता है वाया द काल्मोडुलिन, कैल्शियम काल्मोडुलिन डिपेंडेंट काइनेजेस वो एक्टिव करता है। एएमपी डायरेक्टली ग्लाइकोजन फॉस्फोराइलेज को एक्टिवेट करता है। ये एमसीक्यू आके गया है, ये याद रखना। एएमपी अगर ऑप्शन में, गो विद द एएमपी। Triacyl glycerol degradation lipolysis, it is there in the it is activated by the hormone sensitive lipase. It is active in presence of the glucagon और फास्टिंग कंडीशन में हार्मोन सेंसिटिव लाइपेज जो है वो एक्टिव रहता है। हार्मोन सेंसिटिव टीजी का डिग्रेडेशन करता है इनटू ग्लिसरॉल एंड फ्री फैटी एसिड। देन हीम सिंथेसिस, just wait, heme synthesis, heme synthesis, the ALA synthase, amino levulinic acid synthase is the rate limiting enzyme of the heme synthesis. It requires pyridoxal phosphate. Urea cycle CPS1, the N-acetyl glutamate is the activator. N-acetyl glutamate is the allosteric activator of CPS1, and purine nucleotide synthesis PRPP glutamyl amidotransferase is the rate limiting enzyme. तो ये थोड़े बहुत जो रेगुलेटर्स है ये अच्छे से करो, जितने मैंने बताए एटलीस्ट इतने तो भी करो, ये इंपॉर्टेंट है। स्पेसिफिकली ग्लाइकोजन फॉस्फोराइलेज वाला ये तो बिल्कुल याद ही रखो, क्योंकि एएमपी इन द मसल इज द डायरेक्ट एक्टिवेटर ऑफ ग्लाइकोजन phosphorylase, and calcium activates the phosphorylase kinase via the calmodulin dependent kinases. So remember this AMP and calcium. There is the cascade mechanism by which this glycogen phosphorylase is active. So this is why the cyclic AMP glycogen phosphorylase is active. Okay, cyclic AMP, via the cyclic AMP, how it is activated? This glycogen phosphorylase via the glucagon and epinephrine. So it is glucagon, epinephrine via the G protein coupled receptor via the adenylyl cyclase and increasing the cyclic AMP and the protein kinase, this becomes active via the cascade mechanism. Amplification of signal is there, glycogen phosphorylase. So glycogen degradation will maintain your blood glucose level. Glycogen phosphorylase, glycogen in between the meal, the blood glucose level, it is maintained by the glycogen degradation, specifically from 4 hours after the exhaustion of the dietary glucose, from 4 hours to लगभग मतलब 12 to 16 आवर तक ग्लाइकोजन आपका ग्लूकोज मेंटेन करता है, स्पेसिफिकली द लीवर ग्लाइकोजन, दैट इज लीवर ग्लाइकोजिनोलाइसिस, ग्लाइकोजन का ब्रेकडाउन। ठीक है, फिल इन द ब्लैंक विथ करेक्ट नंबर ऑफ एटीपी प्रोड्यूस्ड इन द पाथवे। ये सबसे इंपॉर्टेंट है, याद रखो। रैपापोर्ट ल्यूबरिंग साइकिल और एचएमपी शंट में 0 एटीपी प्रोडक्शन होता है। रैपापोर्ट ल्यूबरिंग साइकिल एंड एचएमपी शंट, हेक्सोज मोनोफॉस्फेट शंट, ये दोनों पाथवे जो है यहाँ पे 0 एटीपी प्रोडक्शन होता है, ये याद रखो, 0 एटीपी प्रोडक्शन। इनका रोल ही अलग है। रैपापोर्ट ल्यूबरिंग साइकिल इज फॉर द 2,3 बीपीजी जनरेशन एंड एचएमपी शंट इज स्पेसिफिकली फॉर द जनरेशन ऑफ एनएडीपीएच एंड राइबोज, स्पेसिफिकली फॉर द एनएडीपीएच, नॉट एनएडीएच, एनएडीपीएच एंड राइबोज के सिंथेसिस के लिए एचएमपी शंट लगता है। सी अनएरोबिक ग्लाइकोलिसिस विल गिव यू 2 ATP. Aerobic glycolysis will give you 7 ATP. Complete oxidation of one glucose molecule will give you 32 ATPs. Oxidation of palmitic acid, 16 carbon will give you 106 ATP. And oxidation of stearic acid, 18 carbon will give you 120 ATPs. Rapoport lubering cycle, HMP shunt, 0 ATP. Glycolysis in RBCs or cancer cells, that is the anaerobic glycolysis, will give you 2 ATP. So this is energetics of important metabolic pathways. Now coming to the inborn error and enzyme deficiency, ये भी आप लोगों को काफी हद तक याद हो गया होगा। inborn errors and enzyme deficiency, see, फेनाइल कीटोन यूरिया, मेरे साथ साथ याद करके देखो। फेनाइल कीटोन यूरिया एंजाइम डेफिशिएंसी इज फेनिलएलानिन हाइड्रोक्सिलेज। अल्कैप्टोन यूरिया, इट इज होमोजेंटिसेट ऑक्सीडेज। अल्बिनिज्म, टायरोसिनेज डिफेक्ट। homocystinuria, cystathionin beta synthase defect. Maple syrup urine disease, it is branch chain keto acid dehydrogenase defect. Tyrosinemia type 1, 1 है तो first F से चालू होता है, fumaryl acetoacetate hydrolase. And cystinuria, it is a renal tubular absorption defect of the cola, that is cysteine, ornithine, lysine and arginine. cystinuria, तो यहाँ पे क्या नहीं लिखा है? Alkaptonuria, it is due to homogentisate oxidase defect. Homogentisate oxidase defect. Black urine on standing, homocystinuria. Tendency to develop arthritis in the latter age because of deposition of alkaptone in the various मतलब in the cartilage tendon. The cartilage of the nose, ear cartilage, there is deposition of the black pigment occur. Homogentisate oxidase, alkaptonuria. Maple syrup urine disease, it is branch chain keto acid dehydrogenase. Branch chain keto acid dehydrogenase. Tyrosinemia type 1, fumaryl acetoacetate hydrolase. Cystinuria, defect in renal tubular reabsorption of cysteine, ornithine, lysine and arginine. Cola, COLA. Heart nerves disease, it is defective absorption of tryptophan and other neutral amino acid. Galactosemia, it is galactose 1-phosphate uridyl transferase. Galactose 1-phosphate uridyl transferase defect. Transferase defect. Galactosemia, there is hypoglycemia, there is neurological manifestations because of the hypoglycemia, there is decreased bilirubin uptake, so there is jaundice, the unconjugated bilirubin level increases, there is congenital cataract because of the deposition of dulcitol or galactitol in the lens, galactosemia. Hereditary fructose intolerance, aldolase B defect. Essential pentosuria, it is xylulose reductase or xylitol dehydrogenase defect. More specific is L-xylulose reductase defect or xylitol dehydrogenase defect. Benign condition, there is excretion of pentose sugar, xylulose in the urine occur. Von Ger's type 1, it is glucose 6-phosphatase defect. Glucose 6-phosphatase defect. See, glucose 6-phosphate dehydrogenase defect in the drug-induced hemolytic anemia. This is glucose 6-phosphatase defect in the von Ger's disease. ठीक है. Myocardial disease, muscle glycogen phosphorylase defect. Leishman syndrome, HGPRTase, hypoxanthine guanine phosphoribosyl transferase defect. Leishman syndrome, self-mutilating activity is there, behavioral problem is there, mental retardation is there, purine salvage pathway is affected, there is hyperuricemia in the HGPRTase deficiency. Hypoxanthine guanine phosphoribosyl transferase, purine salvage pathway defect. Orotic aciduria, it is UMP synthase. UMP सिंथेज बोलते हैं ये एंजाइम को. इसके दो पार्ट रहते, दो एंजाइम्स रहते इसमें, एक OMP डिकार्बोक्सिलेज एंड दूसरा OPRTase एंड OMP डिकार्बोक्सिलेज. ओरोटिक एसिड्यूरिया, देर इज मैक्रोसाइटिक एनीमिया, मेगेलोब्लास्टिक RBCs होती है, मैक्रोसाइटिक एनीमिया इज देयर, फेल्योर टू थ्राइव, बिकॉज फेल्योर टू थ्राइव इज देयर, macrocytic anemia is there, and there is orotic acid excretion in the urine occur because of UMP synthase defect, which is composed of two enzymes, OPRTase, orotate phosphoribosyl transferase, and OMP decarboxylase. So this is known as orotic aciduria. Then severe combined immunodeficiency, this was the disease on which the gene therapy was tried for the first time. It is due to ADA deficiency. Also, this is due to the defect in homologous recombination. Defect in non-homologous end joining. Just wait. Defect in non-homologous end joining. DNA repair डिफेक्ट एंड जॉइनिंग, ये दोनों रीजन के वजह से SCID होता है, सीवियर कंबाइन इम्यूनोडेफिशिएंसी. बोथ B cell and T cells are affected and there is recurrent infection in the severe combined immunodeficiency. G6PD deficiency, अभी मैंने बोला ग्लूकोज 6 फॉस्फेट डिहाइड्रोजनेस डेफिशिएंसी HMP शंट के साथ रिलेटेड है. अगर डेफिशिएंसी अगर होती है जनरली असिम्प्टोमेटिक रहता है, बट व्हेन ऑक्सीडेंट ड्रग प्राइमैक्विन जैसा, प्राइमैक्विन, सल्फोनामाइड या तो फैवाबिन कंजम्पशन या तो सीवियर इन्फेक्शन जब रहता है इट अफेक्ट, सो बिकॉज ऑफ द NADH लेवल्स आर लो, देर इज ऑक्सीडेंट मतलब रिएक्टिव ऑक्सीजन स्पेसिस कॉजेज डैमेज टू द RBC and there is hemolytic anemia that is known as drug induced hemolytic anemia, glucose 6 phosphate dehydrogenase deficiency related with the HMP shunt, hexose monophosphate shunt and NADPH production के साथ related है NADPH production. Primary hyperoxaluria, this is a protein targeting defect of the enzyme alanine glyoxylate aminotransferase. So there is formation of oxalate stone, so there is kidney damage or bladder damage can occur. Nephrolithiasis, nephrocalcinosis, renal failure can be there in the primary hyperoxaluria. Alanine glyoxylate aminotransferase का protein targeting defect है primary hyperoxaluria. Lactose intolerance, lactase deficiency, Wilson's disease, ATP7B mutation in the Wilson's disease, Menkes disease, ATP7A mutation, Zellweger syndrome, this is a peroxisomal biogenesis disorder, disorder due to PEX gene mutation. Repsom's disease, it is phytanyl coenzyme hydroxylase defect, block in the alpha oxidation, this is alpha oxidation defect. Phytanic acid accumulates 20 carbon, branch fatty acid accumulates and that causes the symptom neuropathy, ataxia and retinitis pigmentosa. These are the features of the Repsom's disease. Gaucher disease, it is well known lysosomal storage disorder because of the defect in the enzyme beta glucocerebrosidase. ग्लूकोसिल सेरामाइड या ग्लूकोसेरेब्रोसाइड एक्यूमुलेट होता है. द क्रम्पल टिश्यू पेपर अपीयरेंस, wrinkled paper appearance is the macrophages is there in the Gaucher's disease. There is affected liver, spleen and bone marrow. There is refractory anemia, leukopenia, thrombocytopenia, bleeding tendency is there. Erlenmeyer flask deformity is there and crumpled tissue paper macrophages are there in the Gaucher's disease. Niemann-Pick disease, it is due to the defect in the sphingomyelinase. There is cherry red spot on the macula and the foam cell macrophages are there in the Niemann-Pick disease. So cherry red macula and the hepatosplenomegaly is there in the Niemann-Pick disease. So these are the some inborn errors, some diseases with the enzyme defect or protein targeting defect or the transporter defects. Tay-Sachs disease, hexosaminidase A defect. Pompe's disease, it is the lysosomal acid maltase, that is lysosomal alpha 1,4 glucosidase defect. Pump failure is there, cardiac involvement is there in the Pompe's disease. The Krabbe's disease, it is beta galactocerebrosidase defect. Metachromatic leukodystrophy, it is aryl sulfatase A defect. And the eye cell disease, it is failure of mannose 6 phosphate tagging in the Golgi apparatus. This is the enzyme defect is N-acetylglucosamine phosphotransferase. This is enzyme which is defective. Because of this, the tagging of the mannose 6 phosphate tagging does not occur, and as the mannose 6 phosphate, the protein is not tagged with the mannose 6 phosphate, वो लाइसोसोम में नहीं जाएगा. So this is lysosomal protein targeting defect. Okay, so this is eye cell disease, failure of mannose 6 phosphate tagging in the Golgi apparatus. So तो उसके वजह से वो जो एंजाइम, वो जो प्रोटीन है वो लाइसोसोम में नहीं जाएंगे. This is because of the defect in the enzyme decrease activity of N-acetyl glucosamine phosphotransferase. Remember this N-acetyl glucosamine phosphotransferase. Okay, this is a defect. तो ये पूरा आपको रिवाइज करना है. साथ साथ में आपको इसके फीचर्स भी देखने हैं. इसके फीचर भी आपको याद करके देखने हैं. एक साथ ये रिवाइज करना है. फेनाइल कीटोन्यूरिया, अल्केप्टोन्यूरिया, अल्बिनिज्म, होमोसिस्टीन यूरिया, मैपल साइरप यूरिन डिसीज, टायरोसिनेमिया टाइप 1, सिस्टीन यूरिया, Hartnupp's disease, galactosemia, hereditary fructose intolerance, essential pentosuria, von Gogh disease, McArdle disease, Leishman syndrome, orotic aciduria. थोड़ा बहुत रिवाइज तो मैंने कर दिया. सीवियर कंबाइन इम्यूनोडेफिशिएंसी, ग्लूकोज 6 फॉस्फेट डिहाइड्रोजनेज डेफिशिएंसी, प्राइमरी हाइपरऑक्सोल्यूरिया, लैक्टोज इंटॉलरेंस, विल्सन्स, मेंकेज, ज़ेल्वेगर सिंड्रोम, रेप्सम्स डिसीज, गाउचर्स डिसीज, Niemann-Pick disease, Tay-Sachs disease, Pompe's disease, Krabbe's disease, metachromatic leukodystrophy, eye cell disease. ये सब एंजाइम डिफेक्ट आपको याद करने हैं. इसकी थोड़ी सी राइटिंग प्रैक्टिस करो, बहुत इंपॉर्टेंट है ये सब, सभी के सभी. इसमें से कुछ इंपॉर्टेंट हम डिस्कस करने वाले हैं आगे, जो कॉमनली पूछे जाते हैं वो डिस्कस करने वाले हैं. ठीक है, अभी टॉपिक पे आते हैं. एंजाइम टॉपिक. एंजाइम में क्लियर है, एक्स शेप ग्राफ, द वी शेप ग्राफ एंड द पैरेलल लाइन। अगर एक्स शेप ग्राफ दिखा आपको, एक्स शेप अगर है तो इट इज कॉम्पिटिटिव इनिबिशन, इट इज competitive inhibition, competitive inhibition. In the competitive inhibition, remember there is competition between the substrate and inhibitor, competition between the substrate and inhibitor, and this type of inhibition can be overcome by increasing the substrate concentration. Substrate concentration को increase करके इसको overcome किया जा सकता है. And what do you mean by Km value? Km is the substrate concentration to produce the half of the maximum velocity. Substrate concentration to produce half of the maximum velocity. तो ये जो है इसमें Km increase होता है without affecting the Vmax. So high substrate concentration is needed to reach the Vmax level. So this is in this competitive inhibition, Km increases and no change in the Vmax occur. Km increases and no change in the Vmax occur. Okay, non-competitive inhibition, this is V-shaped graph. This is non-competitive inhibition. Non-competitive inhibition. There is no competitive inhibition. So there is no competition between substrate and inhibitor. Even if you increase the substrate concentration, if you increase the substrate concentration, will not affect the velocity of the reaction. क्योंकि दोनों में कुछ यही नहीं है, दोनों में कुछ भी इनिबिटर और सबस्ट्रेट के बीच में कोई कंपटीशन नहीं है, तो सबस्ट्रेट को कंसंट्रेशन बढ़ा के भी आपका कुछ फायदा होने वाला नहीं है. सो इन दिस टाइप ऑफ इनिबिशन, नॉन कॉम्पिटिटिव इनिबिशन, Km remains same and Vmax get lowered. Vmax get lowered. Remember, ये मैक्सिमम वेलोसिटी है, ये कभी भी बढ़ेगी नहीं, ये तो एक तो सेम रहेगी नहीं तो कम हो जाएगी. एंड these are the parallel lines. It is in the uncompetitive inhibition. It is in the uncompetitive inhibition. Uncompetitive inhibition, here the both Vmax और Km दोनों डिक्रीज हो जाएंगे, दोनों डिक्रीज हो जाएंगे. एग्जाम्पल इसका है, very less examples and very rare type of inhibition is this. So in this inhibition, the lithium inhibit inosine monophosphatase, inosine monophosphatase. And second one is the that is phenylalanine, high level of phenylalanine inhibit the placental alkaline phosphatase. So these are the examples of uncompetitive inhibition. Both parallel lines are there. Vmax, Km दोनों decrease हो जाता है. ठीक है. So these are the graphs related with the inhibition in the enzyme action. Now see this kinetic, enzyme जैसे ही kinetic दिख रही है. See this is hyperbolic curve is there. This is like enzyme and this is the straight line. This is passive diffusion. This is carrier mediated diffusion. एग्जाम में क्या करेंगे, इसमें से कुछ तो भी ये गायब कर देंगे. Carrier mediated diffusion. Now see this is kinetic of carrier mediated diffusion with passive diffusion. In passive diffusion it is directly proportional. This is directly proportional. So increase in the solute concentration will not affect the velocity of this, velocity of the reaction. मतलब एब्सॉर्प्शन अफेक्ट नहीं होगा, कितना भी सोल्यूट इंक्रीज होगा. तो पैसिव डिफ्यूजन, क्योंकि वो कैरियर मेडिएटेड रहता ही नहीं है, वो प्रोटीन को सैचुरेट होता ही नहीं है. ये जो कैरियर मेडिएटेड है, जैसे कि फैसिलिटेटेड डिफ्यूजन है, एक्टिव ट्रांसपोर्ट है, प्राइमरी एक्टिव ट्रांसपोर्ट, सेकेंडरी एक्टिव ट्रांसपोर्ट, ये कैरियर मेडिएटेड है. ये जो है ये अफेक्ट होते हैं. दिस विल शो यू द हाइपरबोलिक कर्व. गिव द इंटरप्रिटेशन ऑफ रेड लाइन या ग्रीन लाइन, ऐसा पूछ सकते हैं ये ग्राफ दिखा के. ठीक है. सो इट इज डायरेक्टली प्रोपोर्शनल इन द पैसिव डिफ्यूजन एंड द कैरियर मेडिएटेड, जहां पे प्रोटीन लगता है, जहां पे फैक्टर लगता है, जहां पे ट्रांसपोर्टर लगता है, वहां पे इट इज द सैचुरेशन इज देयर. सो काइनेटिक मतलब एंजाइम जैसा काइनेटिक दिखता है. सो जहाँ पे कैरियर मेडिएटेड ट्रांसपोर्ट है, जहाँ पे ट्रांसपोर्टर प्रोटीन है, वहाँ पे हमें ये टाइप ऑफ ग्राफ दिखेगा एंड इट इज डायरेक्टली प्रोपोर्शनल इन द पैसिव डिफ्यूजन. ओके, ये ग्राफ का इंटरप्रिटेशन पूछते हैं. नाउ सी मैच द पेयर एंजाइम्स एंड इनिबिटर्स. ये अभी हमने कॉम्पिटिटिव इनिबिशन, नॉन कॉम्पिटिटिव और अनकॉम्पिटिटिव इनिबिशन के एग्जांपल देखे. सी एंजाइम xanthine oxidase, it is inhibited by this is allopurinol enzyme. It is xanthine oxidase allopurinol. It is used in the treatment of gout के treatment में इसको use करते हैं. gout. It inhibit the enzyme xanthine oxidase by competitive as well as the suicide inhibition. Xanthine oxidase, remember this is molybdenum dependent enzyme. अगर molybdenum की deficiency हो गई तो there is excretion of xanthine in the urine occur, that is known as xanthine urea. तो ये xanthine oxidase से related जितनी भी चीजें सारी important है. Okay, it causes the conversion of hypoxanthine to xanthine, xanthine to uric acid. So this is allopurinol is a drug which is a competitive inhibitor of this xanthine oxidase. It is structurally similar to that of the hypoxanthine. Also, it is a suicide inhibitor of xanthine oxidase used in the treatment of gout. Dihydrofolate reductase, it is used in the cancer therapy. It is inhibited by the that is methotrexate. It is inhibited by the methotrexate. Inhibited by the methotrexate. Vitamin K epoxide reductase, this is dicumarol and the warfarin. Dicumarol and warfarin. This affect the vitamin K epoxide reductase, and they are oral anticoagulant. Oral anticoagulant drugs. And the statins, lovastatin, simvastatin, atorvastatin inhibit the HMG coenzyme reductase enzyme. So match the pair करके question आ सकता है. So these are the examples of the competitive inhibition. Competitive inhibition के example है. Match the investigation and vacuum tenor of choice for blood collection. This is very, very important nowadays. The high rated, toply rated topic. This is very, very important topic. Vacuum tenors and the order of draw. Vacuum tenor and order of draw. See, HbA1c estimation. We collect the sample in the for the HbA1c estimation, we collect the sample in the purple top EDTA tube. EDTA tube में collect करते हैं. इलेक्ट्रोलाइट के लिए जनरली हम रेड टॉप में कलेक्ट करते हैं. रेड टॉप जो प्लेन बल्ब रहता, बायोकेमिस्ट्री में मेनली प्लेन बल्ब यूज होता है, और ग्लूकोज के लिए फ्लोराइड बल्ब यूज होता है, और HbA1c के लिए EDTA ट्यूब यूज होती है. HbA1c एस्टिमेशन के लिए EDTA ट्यूब होती है. ABG एनालिसिस के लिए ग्रीन कलर का टॉप रहता है, उसको हिपेरिनाइज ट्यूब बोलते हैं. ग्रीन टॉप रहता है. अभी ये जो ग्रीन टॉप में आप इलेक्ट्रोलाइट भी कर सकते हो, इमीडिएट पैरामीटर अगर इमीडिएटली चाहिए अलॉन्ग विद द ABG, you can do it in the green top tube also. इलेक्ट्रोलाइट कर सकते हो, बट मेनली इट इज डन इन द रेड और येलो टॉप ट्यूब जिसमें कोई एडिटिव ऐड किया हुआ नहीं रहता है. प्लाज्मा ग्लूकोज, इट इज ग्रे ट्यूब बिकॉज इट इनिबिट द दिस फ्लूराइड इनिबिट द इनोलेज एंजाइम ऑफ द ग्लाइकोलिसिस बाय नॉन कॉम्पिटिटिव इरिवर्सिबल इनिबिशन. नॉन कॉम्पिटिटिव इरिवर्सिबल इनिबिशन. Fluoride ion inhibit the inolase enzyme by non-competitive irreversible inhibition. So HbA1c, remember HbA1c important है. HbA1c will tell you about the average blood glucose level. Average blood glucose level. Glucose level for preceding, for past 8 to 12 weeks. It depends on RBC lifespan. The best method for HbA1c estimation is the HPLC with column. कौन सा column? The ion exchange resin. Ion exchange chromatography. This is the best, the standard reference method for the glycated hemoglobin estimation. It is non-enzymatic attachment of glucose. This is hemoglobin. Glycated hemoglobin is non-enzymatic attachment of glucose to N-terminal valine of the beta globin chain. N-terminal valine of the beta globin chain. Okay, so this is HbA1c, very very important parameter. इलेक्ट्रोलाइट आप रेड बल्ब में, येलो बल्ब में, या तो ग्रीन बल्ब में भी कर सकते हो. सो रेड एंड द येलो इट इज कॉमनली यूज फॉर द इलेक्ट्रोलाइट एस्टिमेशन. ABG के लिए हिपेरिनाइज सिरिंज या ग्रीन टॉप वाले ट्यूब यूज करते हैं. प्लाज्मा ग्लूकोज के लिए ग्रे टॉप वाला फ्लूराइड बल्ब यूज करते हैं. ठीक है, सी दिस इज ऑर्डर ऑफ ड्रॉ. रिमेंबर दिस. इसका एक न्यूमोनिक है, bunny rabbit get pregnant food. See, bunny rabbit get pregnant food. This is mnemonic for the order of draw. सबसे पहले ब्लड कल्चर ट्यूब, इसका कोई ये नहीं रहता. ब्लड कल्चर ट्यूब, दिस इज ब्लड कल्चर ट्यूब फॉलोड बाय द ब्लू. बनी मीन्स ब्लू. सो ब्लू, इट इज ब्लू. This is blue. It is citrate tube. It is used for coagulation studies. Blue citrate tube for the coagulation study. Red or yellow, remember these are used simultaneously, or these are used मतलब जहाँ पे रेड अवेलेबल है वहाँ पे रेड यूज करते हैं। येलो थोड़े से महंगे आते हैं, प्राइवेट सेक्टर में येलो वाले यूज होते हैं, गवर्नमेंट सेक्टर में जनरली रेड वाले यूज होते हैं। रेड और येलो, गोल्डन येलो बोलते हैं इसको, गोल्डन येलो। दीज आर विदाउट एनी एंटी कोएगुलेंट, कुछ भी नहीं रहता इसमें, प्लेन ट्यूब रहती है। दीज आर द प्लेन ट्यूब्स, प्लेन ट्यूब, नो एडिटिव्स आर देयर, नो एनी एंटी, देर इज नथिंग इन दिस टू ट्यूब्स। इसमें क्लॉट एक्टिवेटर रहता है जनरली। सो दिस इज रेड और गोल्डन येलो ट्यूब, प्लेन, नो एडिटिव्स, मतलब यहाँ पे कोई एंटी कोएगुलेंट या कुछ रहता नहीं है। दीज आर मेनली, दीज आर यूज्ड in the these are plain tube used in the biochemistry, serum biochemistry parameter, बायोकेमिस्ट्री। मोस्ट ऑफ द इन्वेस्टिगेशंस जो है मेनली, जैसे कि एलएफटी है, लिवर फंक्शन टेस्ट के, मतलब बिलीरुबिन हो गया, टोटल प्रोटीन हो गया, अल्बुमिन हो गया, एसजीओटी, एसजीपीटी, अल्कलाइन फॉस्फेट, जितने भी पैरामीटर है, या तो केएफटी हो गया, यूरिया, क्रिएटिनिन, इलेक्ट्रोलाइट भी हो गया, इलेक्ट्रोलाइट्स, इट इज डन, इलेक्ट्रोलाइट्स इट इज डन ऑन दिस ट्यूब्स। ये दोनों ट्यूब में एलएफटी, केएफटी, इलेक्ट्रो, ये इधर चला गया, जस्ट वेट, हाँ ये दोनों में, रेड और गोल्डन येलो में, दिस इज प्लेन, प्लेन ट्यूब, सीरम पैरामीटर्स इस पे करते हैं। दिस इज ग्रीन, दिस इज एबीजी एनालिसिस, दिस इज हिपेरिनाइज ट्यूब, दिस इज यूज फॉर एबीजी, आर्टेरियल blood gas analysis. Also immediate biochemistry parameter can be done on the heparin tube, green top, green top. Okay, this is green top, green top, this is abg analysis. EDTA tube, purple top, it is for the cbc, सीबीसी के लिए यूज होता है, एच बी एवन सी के लिए यूज होता है, एच बी एवन सी एस्टिमेशन के लिए ईडीटीए ट्यूब यूज होता है। फ्लूराइड ट्यूब, ग्रे कैप, दिस इज पर्पल, पर्पल एंड दिस इज ग्रे। फ्लूराइड ट्यूब, फ्लूराइड, फ्लूराइड ट्यूब, ग्रे ट्यूब, ग्रे कैप, it is there, it is having the sodium fluoride potassium oxalate in the 1 is to potassium oxalate into 1 is to 3 ratio. It is used, it inhibit the enolase enzyme of the glycolysis. It is used to collect the glucose level, glucose estimation के लिए ये use होता है fluoride tube. So see, so gray, it is bunny, blood culture followed by the blue, the red is there, then green, then the purple, and then the फ्लूराइड बल्ब, सबसे आखिरी में फ्लूराइड बल्ब। दिस इज ऑर्डर ऑफ ड्रा, ब्लड कलेक्ट करने के बाद पहले ये सीक्वेंस वाइज ये ट्यूब में जाना चाहिए वो, ठीक है। ब्लड कल्चर बॉटल सबसे पहले स्टार्टिंग में आएगी, ठीक है। सो दिस इज ऑर्डर ऑफ ड्रॉ। तो यहाँ पे 2 मिनट रुकते हैं हम, 2 नहीं 5 मिनट रुकते हैं और फिर से स्टार्ट करेंगे, ठीक है। तब तक ये ऐसे ही डिस्प्ले करके रखता हूँ। दिस इज 5 मिनट ब्रेक। हेलो हेलो हेलो। हेलो हेलो। So this was about the order of draw. Now we'll discuss the next part. See, glutes, the important part, glutes, ग्लूकोज ट्रांसपोर्टर। पहले 5 ग्लूकोज ट्रांसपोर्टर याद रखो, और दूसरी चीज याद रखो ग्लूकोज ट्रांसपोर्टर में कि इंसुलिन सेंसिटिव ग्लूकोज ट्रांसपोर्टर, दिस इंक्लूड ग्लूट 4, 8 एंड 12, ग्लूट 4, ग्लूट 8 एंड ग्लूट 12। ग्लूट 4 इज इंसुलिन डिपेंडेंट ग्लूकोज ट्रांसपोर्टर प्रेजेंट इन द, कहाँ पे प्रेजेंट रहता है ग्लूट 4? इट इज देयर इन द skeletal muscle, heart and adipose tissue. Okay, basolateral surface of intestinal mucosal cell, liver, beta cells of pancreas, it is glut 2. It is glut 2. Placenta, kidney, RBCs, colon and brain, specifically brain means blood brain barrier. Blood brain barrier, this is glut 1, most abundantly present glut 1. Small intestine, it is glut 5, glut 2, glut 5, glut 2. Glut 5 is there in the small intestine. So this is distribution of glucose transporter, skeletal muscle, heart and adipose tissue. It is glut 4. It is insulin sensitive glucose transporter. Glut 2 is there in the basolateral surface of the intestinal mucosal cell, liver, beta cells of the pancreas. It is particularly important in the blood glucose regulation. Most widely distributed, it is glut 1. It is there present in the, remember Kohli plays for RCB. So it is kidney, placenta, आरबीसी, कोलॉन एंड द ब्लड ब्रेन बैरियर, एंड ब्रेन में जो रहता है न्यूरॉन्स में, दैट इज ग्लूट 3, दैट इज ग्लूट 3. ग्लूट 5, इट इज फॉर द फ्रुक्टोज 5 फॉर द फ्रुक्टोज ट्रांसपोर्ट. फ्रुक्टोज फैसिलिटेटेड डिफ्यूजन से ट्रांसपोर्ट होता है. फ्रुक्टोज, ये ग्लूट्स जो है, दिस आर द टाइप्स ऑफ द फैसिलिटेटेड डिफ्यूजन. इट इज देयर इन द इंटेस्टाइन. ग्लूट 5, फ्रुक्टोज ट्रांसपोर्ट एंड द फैसिलिटेटेड डिफ्यूजन, एफ. ओके, सी ग्लूट 1, अभी मैंने बताया कोहली प्लेस फॉर आरसीबी. सो किडनीज, प्लासेंटा, कोलॉन, आरबीसीज and the blood brain barrier. Brain means blood brain barrier. There is glut 1, most abundantly present glucose transporter. ग्लूट 2, इट इज ऑन द बेसोलेटरल सरफेस. बेसोलेटरल सरफेस मतलब ये इंटेस्टाइन का ल्यूमेन हो गया, ये लुमिनल सरफेस हो गया इंटेस्टिनल सेल का, और ये जो दूसरा साइड है, देयर इज ग्लूट 2. बेसोलेटरल सरफेस ऑफ द intestinal mucosal cell, basolateral surface of the proximal convoluted tubular cell, it is there in the pancreas, it is there in the sinusoidal surface of the liver, that is glut 2, mainly related with the glucose regulation. It is related with the glucose regulation. Then glut 3, it is there in the neuron. Just remember the neuron here. Just remember neuron. Glut 3, it is there in the neuron. Glut 4, it is insulin sensitive glucose transporter. Glut 4, 8 and 12, insulin dependent. It is there in the skeletal muscle, heart and adipose tissue. Skeletal muscle, heart and adipose tissues. It is glut 4. Glut 5, it is there in small intestine, testes and the sperm. It is fructose transport. It is important for the fructose transport. Fructose specific, not for the glucose. This is glut 5. Okay. Then glut 7 is there in the liver. It is particularly important in the endoplasmic reticulum. It is for the transport of glucose in the endoplasmic reticulum. It is important, glut 7. Transport of glucose in the endoplasmic reticulum. It is glut 7. So remember first 5 glucose transporter, very, very important glucose transporters. Okay. देन मैच द पेयर ग्लाइकोसमिनोग्लाइकॉन. हर बार ग्लाइकोसमिनोग्लाइकॉन या म्यूकोपॉलीसैकेराइडोसिस पे क्वेश्चन आता है. ग्लाइकोसमिनोग्लाइकॉन, सी द फीचर. मैं आपको आप तब तक आंसर डालो, मैं तब तक आपको सबके फीचर जस्ट रैपिड रिवीजन में ये करता हूँ. Hyaluronic acid, shock absorbent, lubricant. It is present in synovial fluid, vitreous humor of the eye. it is important in the cell migration, it is important in the wound repair. Chondroitin sulfate, it is there in the cartilage, bone and tendon. It is important for shape and structure of this tissue. Along with the hyaluronic acid, chondroitin sulfate, it is important in the weight bearing joint, compressibility of cartilage in the weight bearing joint. Heparin, it is anticoagulant, also required for release of lipoprotein lipase from the capillary endothelium. Keratin sulfate, it is there in the cornea, it is there in the cartilage. Corneal transparency, keratin sulfate is important. Heparin sulfate, it is there in the glomerular basement membrane, responsible for charge selectiveness of glomerular basement membrane. It is there on the cell surfaces and act as a cell surface receptor. It is important in cell adhesion and cell-cell interaction. It will act as a receptor on the membrane, and it is required, it is having the anchoring role, it is having the anchoring role to the lipoprotein lipase in the capillary endothelium. Dermatan sulfate, it is there in the skin, it is there in the blood vessels, in the heart walls. It is for the maintenance, shape and structure of the स्किन, ब्लड वेसल एंड हार्ट वॉल्स. अभी आप लोगों ने मैच द पेयर अगर किया होगा, थोड़ा डिफिकल्ट है मैच द पेयर इतने कम समय में करना और इसका आंसर डालना. सो कितने लोगों ने किया देखते हैं, जस्ट वेट. हाय नंदिनी. 4E, चलो देखते हैं 4E. केराटिन सल्फेट, ट्रांसपेरेंसी ऑफ कॉर्निया, गुड, ट्रांसपेरेंसी ऑफ कॉर्निया. 5F, heparin sulfate, charge selectiveness of the glomerular basement membrane. Yes, correct. Charge selectiveness of glomerular basement membrane. 2A, chondroitin sulfate provides compressibility to cartilage. Yes, correct. Then 6D, dermatan sulfate, shape and structure of skin, heart walls and blood vessel. Heparin acts as an oral anticoagulant and the hyaluronic acid serves as a lubricant in the joint. So हर एक के फंक्शन अच्छे से हमको करके रखना है. See, these are the very very important. Remember, अगर heparin sulfate accumulate हो गया, it causes CNS प्रॉब्लम. CNS प्रॉब्लम कब होते हैं? जब हिपेरन सल्फेट एक्यूमुलेट होता है. आपने देखा होगा मार्क्यूओ और मोरोटिलैमी, ये जो दो म्यूकोपॉलीसैकेराइडोसिस है, इसमें इंटेलिजेंस नॉर्मल रहता है. ठीक है. सी, इसमें एक्यूमुलेटेड जीएजीज दिए हैं. एमपीएस, रिमेंबर एमपीएस 1, 2 एंड 7. 1, 2 एंड 7 देयर इज dermatan sulfate, heparin sulfate accumulation. See, dermatan sulfate, heparin sulfate accumulation is there in the 1, 2 and 7. 1, Hurler syndrome, 2, Hunter syndrome, and the 7, Sly disease, dermatan sulfate, heparin sulfate accumulation is there. Sanfilippo, it is heparin sulfate accumulation. There is CNS problem in the Sanfilippo. Severe mental retardation is there. Aggressive behavior is there in the Sanfilippo. ABCD, 4 type है इसके. There is accumulation of heparin sulfate. Morquio, there is keratin sulfate and chondroitin sulfate accumulation in the Morquio. And the मोरोटिलैमी, there is accumulation of dermatan sulfate. नाटोविक syndrome, लास्ट ईयर या उसके पहले वाले INI-CET में नाटोविक्स पूछा था. नाटोविक्स, it is the MPS type 9, mucopolysaccharidosis type 9, because of the defect in the hyaluronidase defect. There is affected joints are involved in the Natovic syndrome. So Natovic syndrome, it is hyaluronic acid accumulation. Remember, hyaluronic acid accumulation. So remember, dermatan sulfate, heparin sulfate, heparin sulfate, it is there in the type 1, it is type 2, type 7. Type 1, type 2, type 7, dermatan and heparin sulfate. Heparin sulfate is there in the type 3, that is Sanfilippo, severe mental retardation. Severe mental retardation is there in the type that is Sanfilippo ABCD. Severe mental retardation is there. जहाँ पे heparin sulfate accumulate होता है, in that disease there is severe mental retardation or CNS involvement is there. Now match the pair. See the match the pair. Hurler syndrome, the defective enzyme. ये तो बेसिक है, ये तो आना ही चाहिए हमको, ये हमारा गलत नहीं होना चाहिए. ये तो हमारे हाथ वाले MCQs है, हार्ड है, डिफिकल्ट है, इसलिए छोड़ना नहीं है इनको. सो हर्लर सिंड्रोम, द डिफेक्ट इज यल आइडुरोनिडेज इन द हर्लर सिंड्रोम. अरे यहाँ पे मैच करना है क्या? नहीं है, यहाँ पे तो ऑलरेडी दिया है. ओके, मैच द पेयर लिखा भी नहीं है. सी, हर्लर सिंड्रोम, द डिफेक्ट इज यल आइडुरोनिडेज, शायर सिंड्रोम, इट इज पार्शियल डेफिशिएंसी ऑफ यल आइडोरोनिडेज, इसका ही वेरिएंट है। हंटर सिंड्रोम, इट इज आइडोरोनेट सल्फेटेज डेफिशिएंसी। स्लाई सिंड्रोम, एमपीएस टाइप 7 स्लाई सिंड्रोम, इट इज बीटा ग्लूकोरोनिडेज। और Natovic syndrome, MPS 9, it is defect in the hyaluronidase. It is hyaluronic acid accumulation occurs and there is joint involvement in the Natovic syndrome. Remember this. Sly syndrome, beta glucuronidase defect. Okay. मार्क्यू जो रहता है, मार्क्यू के दो टाइप है, ए एंड बी। ए में गैलेक्टोसल्फेटेज इज डेफिशिएंट एंड बी इज द बीटा गैलेक्टोसाइडेज डिफेक्ट। मार्क्यो बी इज द बीटा गैलेक्टोसाइडेज डिफेक्ट। सैन फिलिप्पो ए बी सी डी टाइप 3 है, सैन फिलिप्पो सी। मार्क्यो, ये जो है मार्क्यो ए एंड बी, ए इज galactose sulfatase and B is beta galactosidase, B is beta galactosidase। ओके, बी मार्क्यो बी। मेंटल रिटार्डेशन नहीं रहता, दोनों भी जो एम से चालू होते हैं ना, मार्क्यो और मारोटिलैमी, इसमें मेंटल रिटार्डेशन नहीं रहता, ध्यान में रखो। और इसमें हिपेरन सल्फेट एक्यूमुलेट नहीं होता है, इसमें केराटिन सल्फेट और कॉन्ड्राटिन सल्फेट, इसमें केराटिन सल्फेट एक्यूमुलेट होता है। दूसरा मारोटिलैमी, इसमें इसमें जो है, इसमें भी मेंटल रिटार्डेशन नहीं रहता है, इट इज नो मेंटल रिटार्डेशन इज देयर, इट इज अराइल सल्फेटेज डिफेक्ट, मारोटिलैमी। ओके, सी मैच द फॉलोइंग। ये तो वोन, मतलब ये जो ग्लाइकोजन स्टोरेज डिसऑर्डर है, इस पे हर साल क्वेश्चन रहता है, या तो रेगुलेशन पे रहेगा या तो डिसऑर्डर पे रहेगा। वोन गर्ग्स डिसीज, मैच द पेयर। सी ब्रांच स्ट्रक्चर इन द लीवर बायोप्सी, ग्लाइकोजन डिपोजिशन इन लाइसोसोम, तो मैक्सिमम इसमें ग्लाइकोजन डिपोजिशन रहता है। हाइपोग्लाइसीमिया विथ लैक्टिक एसिडोसिस, सो दिस इज अ फीचर ऑफ हाइपोग्लाइसीमिया विथ लैक्टिक एसिडोसिस इज a feature of von Gerg disease, glucose 6 phosphatase defect। Pompe's disease, it is glycogen, हाँ glycogen deposition in lysosome पूछा है, तो it is Pompe's disease। Macardal disease, it is exercise intolerance, second wind phenomenon, myoglobin urea is there। And Cory's disease, there is branch structure in liver biopsy, branch structure in the liver biopsy, limit dextrin accumulation occur in the Cory's disease। एक फीचर बताता हूं आपको, इंपॉर्टेंट है, याद रखो। when you give glucose administration will increase the glucose, generally glucose administration will increase your glucose level, ठीक है। it is not there in the von Gerg disease में ग्लूकोज, अगर आप ग्लूकागॉन एडमिनिस्ट्रेट करोगे तो भी ग्लूकोज नहीं बढ़ेगा, क्योंकि ग्लूकोज 6 फॉस्फेटेज अब्सेंट है। वोन गर्ग डिसीज में अगर आप फास्टिंग में दोगे या पोस्ट मील भी दोगे तो भी ग्लूकोज नहीं बढ़ेगा इन द वोन गर्ग डिसीज। लेकिन कोरीज डिसीज ऐसा है, कोरीज डिसीज में अगर आप पोस्ट मील दोगे तो ग्लूकोज बढ़ेगा थोड़ा सा, और फास्टिंग में दोगे तो ग्लूकोज नहीं बढ़ेगा, क्योंकि जो ग्लूकोज अवेलेबल था, जो भी ज्यादा लीनियर चेन थे, वो सब यूटिलाइज हो गया, ब्रांचिंग पॉइंट पे आके उसका एक्शन रुक जाता है। कोरिज डिसीज इज द डी ब्रांचिंग एंजाइम डिफेक्ट, कोरिज डिसीज। तो याद रखना, अगर ग्लूकोज बिल्कुल भी नहीं बढ़ता है इन फास्टिंग, इन पोस्ट मील, तो वोन गर्ग डिसीज, अगर वो बाकी सारे फीचर्स मेंशन है। अगर ग्लूकोज पोस्ट मील थोड़ा सा बढ़ता है और फास्टिंग में नहीं बढ़ता है, तो इट इज कोरीज डिसीज आफ्टर ग्लूकागॉन एडमिनिस्ट्रेशन। रिमेंबर दिस, आफ्टर ग्लूकागॉन एडमिनिस्ट्रेशन। अभी इसमें रिसेंटली कोई तो भी एग्जाम में ये आके गया है क्वेश्चन। सो बोन गर्ग डिसीज, हाइपोग्लाइसेमिया विथ लैक्टिक एसिडोसिस, हाइपरयूरेसिमिया, हाइपरलिपिडेमिया इज देयर। पॉम्पेज डिसीज, देयर इज पम्प फेल्यूर, लाइसोसोमल एसिड माल्टेज डिफेक्ट। फ्लॉपी इन्फेंट, पम्प फेल्यूर, कार्डियोमेगाली is there in the Pompe's disease, life expectancy is 18 month to 2 year, lysosomal acid maltase। infant में, children में, the some amount of glycogen is degraded in the lysosome, if it is defective it causes the Pompe's disease। McArdle disease में muscle glycogen phosphorylase is involved, the exercise intolerance, second wind phenomenon, if you take rest for some time you can resume your activity। अगर आप ग्लूकोज लेते हो तो आपका एक्टिविटी बढ़ेगा इन मैकार्डल डिसीज। लेकिन यही सेम फीचर के साथ अगर हिमोलिसिस है, मतलब माइल्ड एनीमिया इज देयर, और ग्लूकोज देने के बाद भी सिम्टम्स इंप्रूव नहीं होते हैं, सो दैट कैन बी ए तारोइज डिसीज। रिमेंबर, मसल फॉस्फोफ्रुक्टोकाइनेज डिफेक्ट। ओके, सो कोरिज डिसीज, इट इज डिब्रांचिंग एंजाइम डिफेक्ट, ब्रांच स्ट्रक्चर, लिमिट डेक्स्ट्रिन एक्यूमुलेशन occurs in the tissues. Okay, now see, type 0 glycogen storage disorder, type 0, it is glycogen synthesis defect. There is no hepatomegaly, hypoglycemia between the meal is there, and there is early death occur in the glycogen synthesis defect. Von Gogh disease, this is type 1A. It is due to glucose 6 phosphatase defect. It is due to glucose 6 phosphatase defect. Remember, glucose 6 phosphatase is already absent in the muscle, so muscles are not involved in this. No muscle involvement. No muscle involvement. Also, there is no spleen involvement. No muscle involvement, no spleen involvement. There is hepatosrenomegaly. ग्लूकोनियोजेनेसिस कहाँ पे होता है? लीवर में होता है और किडनीज में होता है. सो लीवर एंड किडनीज आर इन्वॉल्व इन द वोन गर्ग डिसीज. नो मसल इन्वॉल्वमेंट, नो स्प्लीन इन्वॉल्वमेंट. देयर इज हिपैटोरीनोमेगाली. Fasting hypoglycemia, hyperlipidemia, lactic acidosis, uric acid levels are raised in the Von-Gogh disease. यूरिक एसिड लेवल बढ़ता है क्योंकि लैक्टिक एसिड जो है ना वो यूरेट का थ्रेशोल्ड बढ़ा देता है, तो यूरिक एसिड रिटेंशन होता है. सो बिकॉज ऑफ द लैक्टिक एसिडोसिस, दिस इज द प्राइमरी रीजन. इन द Von-Gogh disease there is hyperuricemia, increase in the uric acid level occur. और मैंने आपको बोला ग्लूकागॉन एडमिनिस्ट्रेशन, अगर ग्लूकागॉन दोगे फास्टिंग में दो या खाना खाने के 2 घंटे बाद दो, ग्लूकोज नहीं बढ़ेगा, मतलब नहीं बढ़ेगा, क्योंकि ग्लूकोज 6 फॉस्फेटेज ये एंजाइम जो ग्लूकोज 6 फॉस्फेट को ग्लूकोज में कन्वर्ट करता है वो अब्सेंट है इन द वोन गॉग डिजीज. टाइप 1B इज ऑल्सो देयर. टाइप 1B इज ऑल्सो देयर. इट इज देयर एडिशनल फीचर. ये सारे फीचर्स रहते हैं. प्लस न्यूट्रोपेनिया इज देयर. प्लस न्यूट्रोपेनिया, जस्ट वेट, न्यूट्रोपेनिया इज देयर. Neutropenia, and second feature is the recurrent infection. Recurrent infection is there. Neutropenia and recurrent infection is there. Additional feature, this is due to the defect in transporter defect. Transporter of glucose 6 phosphate. Transporter of glucose 6 phosphate या glucose 6 phosphate translocase defect is there. Von Gogh disease नहीं, टाइप 1B बोलते हैं इसको, टाइप 1B. न्यूट्रोपेनिया और रिकरेंट इन्फेक्शन, अगर ये वर्ड रहा, गो विद द टाइप 1B along with these features. doll like faces, protuberant abdomen, thin extremities, hepatomegaly, renomegaly, hyperlipidemia, hyperuricemia, these are the features of the Von Gogh disease. Pompey's disease, acid maltase defect, lysosomal acid maltase defect, lysosomal acid maltase defect, that is glucosidase defect. So there is glycogen accumulation in the lysosome occurs, there is pump failure, there is cardiac failure occurs. So floppy infant, muscle involvement is there, hepatomegaly is also there, and the cardiac involvement is there. So pump failure, Pompey's disease, pump failure, remember this. And life expectancy is 18 month to 2 year. Cory's disease, remember this, ABCD, this is ABCD. Anderson disease, branching enzyme, and Cory's disease, debranching enzyme. This is debranching enzyme, Cory's disease, debranching enzyme. So there is limit dextrin accumulation in the Cory's disease. Anderson disease, branching enzyme defect. एंडरसन डिसीज इज द सीवियर सिरोसिस ऑफ लीवर इज देयर. दोनों में सिरोसिस ऑफ लीवर रहता है, दोनों में ट्रांसअमाइनेज लेवल एसजीओटी एसजीपीटी बढ़ता है. कोरिस डिसीज में लिमिट डेक्स्ट्रिन एक्यूमुलेशन होता है. दिस इज ड्यू टू द डिब्रांचिंग एंजाइम डिफेक्ट. एंड एंडरसन डिसीज इट इज ब्रांचिंग एंजाइम डिफेक्ट. रिमेंबर, कोरिस डिसीज में अगर खाना खाने के बाद आप ग्लूकागॉन देते हो तो ग्लूकोज लेवल इज रेज्ड, जो वॉन गर्ग में नहीं होता है, यहाँ पे होता है, क्योंकि कुछ हद तक ग्लाइकोजन फॉस्फोराइलेज एक्टिविटी इज देयर जो ब्रांचिंग पॉइंट पे आके रुक जाती है. सो देयर इज डिफेक्ट इन द डी ब्रांचिंग एंजाइम. कोरिस डिसीज इट इज ऑल्सो नोन एज फोर्ब्स डिसीज और लिमिटेड डेक्स्ट्रिनोसिस, लिमिट डेक्स्ट्रिन एक्यूमुलेशन होता है. एंडरसन डिसीज इट इज द ब्रांचिंग एंजाइम डिफेक्ट. देयर इज अमाइलोपेक्टिन एक्यूमुलेशन, अर्ली एज डेथ ऑकर, सीवियर प्रोग्रेशन टू द सिरोसिस ऑफ लिवर इन द दिस अमाइलोपेक्टिनोसिस और द एंडरसन डिसीज. ओके, एंडरसन डिसीज ये याद रखो, ABCD. ओके, इसका एक न्यूमोनिक है, ग्लाइकोजन स्टोरेज डिसऑर्डर. हर एक का अपना कुछ न्यूमोनिक रहता है। वर्सेटाइल प्लेयर कोरी एंडरसन मेड हिस्ट्री। वर्सेटाइल मतलब टाइप 1 वोनगर्ग डिसीज, प्लेयर पॉम्पेज डिसीज, कोरी एंडरसन कोरिस डिसीज एंडर कोरी एंडरसन यूएसए की तरफ से खेला था। जब इसके पहले वाला 2020 यूएसए में वर्ल्ड कप हुआ तब, न्यूजीलैंड का प्लेयर है एक्चुअल में वो। कोरी एंडरसन मेड मैककार्डल डिसीज एंड हिस्ट्री हर्स डिसीज, लीवर ग्लाइकोजन फॉस्फोराइलेज डिफेक्ट। सो दिस इज मसल ग्लाइकोजन फॉस्फोराइलेज डिफेक्ट, मसल ग्लाइकोजन phosphorylase defect, Her's disease, this is liver glycogen phosphorylase defect, and Thyroid disease type 7, it is RBC and muscle phosphofructokinase defect. इसमें RBC इन्वॉल्व रहती है, इसलिए इसमें माइल्ड हिमोलाइसिस इज देयर, माइल्ड हिमोलिटिक एनीमिया, माइल्ड एनीमिया इज देयर। सेम फीचर, इसी के जैसे फीचर रहते हैं, लेकिन ग्लूकोज देने के बाद ये इंप्रूव होता है, ये वर्सन होता है। इट इज वर्सन विद द ग्लूकोज, दिस कोरिस थायरॉइड डिसीज, एंड देर इज नो लैक्टेड राइस, इसमें भी लैक्टेट बढ़ता नहीं वैसे भी। दिस वर्सन्स विद द ग्लूकोज, दिस इंप्रूव्स विद द ग्लूकोज। रेस्ट किया तो ये रिज्यूम कर सकता है एक्टिविटी, ये ग्लूकोज देने के बाद वर्सन हो जाता है। फॉस्फोफ्रुक्टोकाइनेस का डिफेक्ट है, और इसमें एडिशनल एनीमिया फीचर है, एनीमिया, माइल्ड एनीमिया इज देयर इन द फॉस्फोफ्रुक्टोकाइनेस डिफेक्ट। ओके, सो दीज आर द ग्लाइकोजन स्टोरेज डिसऑर्डर्स, ग्लाइकोजन स्टोरेज डिसऑर्डर। ये है पीडीएच कॉम्प्लेक्स, पायरुवेट डिहाइड्रोजनेस कॉम्प्लेक्स। पायरुवेट डिहाइड्रोजनेस, ये तीन भाई है ऐसे, कितने भाई है? तीन भाई है। कौन कौन से? पायरुवेट डिहाइड्रोजनेस कॉम्प्लेक्स एक हो गया पहला, दूसरा अल्फा कीटोग्लूटारेट डिहाइड्रोजनेस, कीटोग्लूटारेट डिहाइड्रोजनेस, और तीसरा ब्रांचेन कीटो एसिड डिहाइड्रोजनेस। ये तीनों जो है, ये टीसीए साइकिल वाला है, टीसीए साइकिल में है, ये लिंक्ड रिएक्शन में है, जो नीचे वाली है लिंक्ड रिएक्शन, और ये ब्रांचेन अमाइनो एसिड मेटाबॉलिज्म में है, ब्रांच्ड अमाइनो एसिड मेटाबॉलिज्म, वैलिन आइसोल्यूसिन ल्यूसिन के मेटाबॉलिज्म में। ये तीनों भाइयों के E1 E2 E3 तीन एंजाइम, मल्टी एंजाइम कॉम्प्लेक्स है, तीन एंजाइम और 5 कोएंजाइम लगते हैं इनको। तीन एंजाइम कौन से? तीन एंजाइम कौन से? दिस इज फर्स्ट पायरुवेट डिहाइड्रोजनेस, दिस इज फर्स्ट पायरुवेट डिहाइड्रोजनेस। दूसरा डाइहाइड्रोलाइपोइल, डाइहाइड्रोलाइपोइल ट्रांसअसाइलेज, ट्रांसअसाइलेज, और तीसरा जो है इट इज डाइहाइड्रोलाइपोइल डिहाइड्रोजनेज। ऐसे तीन एंजाइम रहते हैं, E1 E2 E3। E1 पायरुवेट डिहाइड्रोजनेज, E2 डाइहाइड्रोलाइपोइल ट्रांसअसाइलेज या ट्रांसएसिटिलेज, एंड थर्ड वन इज द डाइहाइड्रोलाइपोइल डिहाइड्रोजनेज, तीसरा डाइहाइड्रोलाइपोइल डिहाइड्रोजनेज। ठीक है, तो ये जो है इसको लगता है थाइमिन पायरोफॉस्फेट, थाइमिन पायरोफॉस्फेट लगता। दूसरा इसको लगता है दैट इज कोएंजाइम ए, कोएंजाइम ए लगता है। तीसरा इसको लगता है लाइपोमाइड, लाइपोमाइड, देन FAD फ्लेविन एडेनिन डाइन्यूक्लियोटाइड, and the NAD, FAD and NAD, it is required. These 5 coenzymes are required for these 3 enzymes: pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex, and branch chain keto acid dehydrogenase complex. ये important है। This is deficient MSUD, maple syrup urine disease में branch chain keto acid dehydrogenase, इसमें keto acid बढ़ता है, that gives the burnt smell of the urine, that is maple syrup urine disease. So remember this E1 E2 E3 and the 5 coenzymes for this. Okay, now this is electron transport chain. This is actually chemiosmotic hypothesis. chemiosmotic hypothesis में क्या होता है? ये जो इनर माइटोकॉन्ड्रियल मेम्ब्रेन रहता है, ये इम्परमिएबल रहता, ये किसी को जाने नहीं देता है। लेकिन ये जो कॉम्प्लेक्सेस रहते हैं, दिस कॉम्प्लेक्सेस ऑफ इलेक्ट्रॉन ट्रांसपोर्ट चेन, कॉम्प्लेक्स 1, कॉम्प्लेक्स 3 एंड कॉम्प्लेक्स 4, ये प्रोटॉन ट्रांसपोर्ट करते हैं फ्रॉम मैट्रिक्स टू द इंटरमेम्ब्रेन स्पेस। क्या ट्रांसपोर्ट करते हैं? ड्यूरिंग द ट्रांसफर ऑफ इलेक्ट्रॉन, जैसे इलेक्ट्रॉन ट्रांसफर होता है, एट द सेम टाइम द प्रोटॉन्स आर पंप्ड इनटू द इंटरमेम्ब्रेन स्पेस। दिस इज नोन एज केमियोस्मोटिक हाइपोथेसिस। उसके वजह से बाहर के साइड में पॉजिटिव हो जाता बिकॉज ऑफ द प्रोटॉन्स, और अंदर के साइड में, मैट्रिक्स के साइड में निगेटिवली चार्ज। सो दिस इज नोन एज डेवलपमेंट ऑफ प्रोटॉन ग्रेडियंट अक्रॉस द मेम्ब्रेन, एंड एज दिस मेम्ब्रेन इज इम्परमिएबल, ये किसी को आने जाने नहीं देता, इनर माइटोकॉन्ड्रियल मेम्ब्रेन, द ओनली एंट्री पॉइंट इज थ्रू द FO यूनिट, FO यूनिट। ये एक ही एंट्री पॉइंट है जहां से ये प्रोटॉन्स, ये बाहर गए वाले प्रोटॉन अंदर आ सकते हैं। और लेकिन जब ये अंदर आते हैं, आते आते ये गैमा हैंडल को रोटेट करके ATP सिंथेसिस करते हैं इन द बीटा subunit of the that is ATP synthase. It causes, by the binding change mechanism, it causes ATP synthesis because of this rotation of the gamma handle due to the influx of this proton. ड्यू टू द इन्फ्लक्स ऑफ दिस प्रोटॉन, दिस इज नोन एज केमी ऑस्मोटिक हाइपोथेसिस। ओके, यहाँ से कॉम्प्लेक्स 1 से 4 प्रोटॉन पंप आउट होते, कॉम्प्लेक्स 3 से 4 पंप आउट होते, और कॉम्प्लेक्स 4 से 2, ऐसे टोटल 10 प्रोटॉन्स पंप आउट होते। एंड दिस प्रोटॉन्स आर इंपॉर्टेंट फॉर सिंथेसिस ऑफ 2.5 एटीपीज। 2.5 एटीपी एक्चुअली, एक एटीपी सिंथेसिस के लिए 4 प्रोटॉन लगते, एक्चुअल सिंथेसिस के लिए 3 लगते, और एक ट्रांसपोर्ट के लिए लगता। तो 4 प्रोटॉन एक एटीपी बनाता है, तो 10 प्रोटॉन पंप्ड आउट होते। एक एनएडीएच आपको, एक एनएडीएच जब इलेक्ट्रॉन ट्रांसपोर्ट चेन में इन्वॉल्व होता है तो 10 प्रोटॉन ट्रांसपोर्ट करता है, देयर इज सिंथेसिस ऑफ 2.5 एटीपी। एक एफएडीएच2 जब इन्वॉल्व होता है, देयर इज 6 प्रोटॉन्स ओनली, एंड देयर इज सिंथेसिस ऑफ 1.5 एटीपीज। क्योंकि ये जो पहला वाला कॉम्प्लेक्स है ये बाईपास हो जाता है जब इट इज फ्रॉम द कॉम्प्लेक्स 2। ओके, सो यहाँ पे क्या पूछा है, नेम द मोबाइल इलेक्ट्रॉन कैरियर्स ऑफ द इलेक्ट्रॉन ट्रांसपोर्ट चेन। तो ये पहला है कोएंजाइम क्यू, ये जो लिपिड है, ये लिपिड है, और ये इसी को बोलते हैं यूबिक्विनोन, इसी को यूबिक्विनोन बोलते हैं, यूबिक्विनोन। इसी को Q10 बोलते हैं, क्योंकि इसमें ना 10 आइसोप्रेनॉइड यूनिट रहता है, 10 आइसोप्रेनॉइड यूनिट रहता है। ओके, कोएंजाइम क्यू, लिपिड, यूबिक्विनोन बोलते हैं इसको, यूबिक्विटस इन नेचर। एंड दूसरा है साइटोक्रोम सी, ये प्रोटीन है, वाटर सोलुबल है, प्रोटीन है, सोलुबल इन वाटर। रिमेंबर, सोलुबल इन वाटर प्रोटीन पूछा तो साइटोक्रोम सी, मोबाइल कंपोनेंट ऑफ इलेक्ट्रॉन ट्रांसपोर्ट चेन। और अगर लिपिड पूछा, insoluble in water, तो it is coenzyme Q. Remember, these complexes are arranged in the increasing redox potential, increasing redox potential में अरेंज रहते हैं। तो सीक्वेंस कैसा रहता है, सीक्वेंस कैसा रहता है, सी फ्रॉम NADH, it is NADH, so from NADH it is coenzyme Q, from the NADH it is coenzyme Q, from coenzyme Q it is complex 3, that is the from coenzyme Q it is complex 3, from complex 3 it is cytochrome C, cytochrome C से cytochrome A, then A3, and finally it is accepted by the oxygen, and it is converted into water molecule. So this is how the electron transfer occur. The redox potential याद रखने की जरूरत नहीं है, सिर्फ it is in the increasing redox potential, it is in the increasing redox potential। मतलब कैसे रहता है increasing redox potential, मतलब सबसे ज्यादा रहता है NADH का, सबसे ज्यादा NADH ये जो पेयर है सबसे ज्यादा रहता। फिर FADH2 आता है, FADH2 वाला फिर इसके बाद आता है FMN, जस्ट वेट, FMN आता है, फिर आता है FADH2, मतलब FADH2 वाला पेयर। उसके बाद आता है कोएंजाइम क्यू, उसके बाद आता है कोएंजाइम क्यू के बाद आता है साइटोक्रोम बी, फिर आता है C1, फिर आता है साइटोक्रोम सी, फिर आता है साइटोक्रोम ए, फिर आता है साइटोक्रोम A3। दिस इज सीक्वेंस इन विच इलेक्ट्रॉन ट्रांसफर ऑकर, NADH, फिर FMN, फिर कोएंजाइम क्यू, फिर साइटोक्रोम बी, फिर C1, C, A3। और जब कॉम्प्लेक्स 2 से आता है, सो इट इज FADH2, कोएंजाइम क्यू, साइटोक्रोम बी, C1, C, A3। ये सीक्वेंस, आपको सीक्वेंस याद चाहिए, रेडॉक्स पोटेंशियल किसी का भी याद रखने की जरूरत नहीं है। इट इज अरेंज इन ए इंक्रीजिंग रेडॉक्स पोटेंशियल, Negative redox potential is having the tendency to lose electron, and positive redox potential is having the tendency to accept electron. Okay, now see, write the name of inhibitors of electron transport chain, complex 1, complex 2, complex 3, complex 4. Complex 1 inhibitors, it includes mainly the most important one, the insecticide, the fish poison, the rotenone. Most important one is the rotenone, then pericidin, gonithidine, also the barbiturate, gonithidine is there, also the amobarbital, secobarbital, secobarbital. So barbiturates are there. So these are the inhibitors of complex 1 of electron transport chain. Most important is the rotenone. Complex 2, it is inhibited by malonate. मैलोनेट इनहिबिट सक्सिनेट डिहाइड्रोजनेज बाय द कॉम्पिटिटिव इनिबिशन, ये अकेला छोड़ के बाकी सब नॉन कॉम्पिटिटिव इनिबिटर्स है. देन TTFA, that is thenoyl trifluoroacetone, and the carboxyl inhibit the complex 2 of electron transport chain. British anti-lewisite, anti-mycin, this inhibits the complex 3 of electron transport chain. And all gases, that is cyanide, carbon monoxide, azide, and hydrogen sulfide. These are the inhibitors of complex 4 of electron transport chain. So remember this rotenone. Rotenone is very, very important. Inhibit the complex 1 of electron transport chain. Inhibit this cyanide and carbon monoxide. This is very, very important to remember. Inhibit the complex 4 of electron transport chain. All gases inhibit the complex 4 of electron transport chain. Malonate, ये तो well known example है. It is a inhibitor, competitive inhibitor of succinate dehydrogenase enzyme complex 2 of electron transport chain. See, दिस इज अ टेबल. फिल इन द ब्लैंक करना है तो यहाँ पे फिजियोलॉजिकल अनकपलर है, ठीक है, हम भर देंगे. सो एटीपी एडीपी ट्रांसपोर्ट, इट इज इनिबिटेड बाय द अट्रैक्टिलोसाइट. रिमेंबर दिस FO, दिस इज O, दिस इज नॉट जीरो. दिस O इज फॉर ओलिगोमाइसिन. सो ओलिगोमाइसिन इनिबिट द complex oligomycin inhibit the FO unit of the ATP synthase. Venturicidin and the oligomycin inhibit the FO unit. F1 unit, it is inhibited by the orovertin, chemical uncouplers, 2,4-dinitrophenol, dinitrocresol, fluorochlorocarbonyl phenylhydrazine, and aspirin in high doses. These are the chemical uncoupler. Uncoupler क्या करता है? ये जो मैंने आपको डायग्राम दिखाया, ये डायग्राम दिखाया, मैंने क्या बोला है? द इनर माइटोकॉन्ड्रियल मेम्ब्रेन इज इम्परमिएबल, है ना. तो अनकपलर क्या करता है? इंक्रीजेस द परमिएबिलिटी ऑफ दिस इनर माइटोकॉन्ड्रियल मेम्ब्रेन एंड डिसरप्ट द ग्रेडियंट. ये ग्रेडियंट डेवलप ही नहीं होने देता अनकपलर, उसके वजह से ये इन्फ्लक्स भी नहीं होता प्रोटॉन का, उसके वजह से एटीपी सिंथेसिस नहीं होता है. अनकपलर डीलिंक्स द इलेक्ट्रॉन ट्रांसपोर्ट चेन फ्रॉम ऑक्सीडेटिव फॉस्फोराइलेशन, उसके वजह से एटीपी सिंथेसिस नहीं होता है. अनकपलर. सो ये क्या करते हैं? इंक्रीजेस द परमेबिलिटी ऑफ इनर माइटोकॉन्ड्रियल मेम्ब्रेन, अनकपलर्स, ठीक है. सी, सो अनकपलर्स, फिजियोलॉजिकल अनकपलर्स में आते हैं थर्मोजेनिन, विच इज देयर इन द न्यूबॉर्न. थर्मोजेनिन प्रोड्यूसेस द हीट, prevent the hypothermia in the newborn. It is there in the mitochondria. Thermogenin. It is also known as uncoupling protein 1, uncoupler protein 1, UCP1. It is there in the hibernating animal and the newborn, protect them from the hypothermia. Then unconjugated bilirubin is there, thyroxine is there, thermogenin, thyroxine, long chain free fatty acids, and the unconjugated bilirubin. These are the physiological uncoupler. These are the chemical uncoupler. 2,4-dinitrophenol, dinitrocresol, fluorochlorocarbonyl phenylhydrazine, aspirin in the high doses. Also, these ionophores act as a uncoupler. They causes the they परमिट द एंट्री ऑफ द अदर आयंस. मतलब जैसे ये पोटेशियम आयनोफोर्स है, दे अलाउ द पोटेशियम टू क्रॉस द इनर माइटोकॉन्ड्रियल मेम्ब्रेन, सो दे आर नोन एज पोटेशियम आयनोफोर्स. सो दे डिसरप्ट द ग्रेडियंट अक्रॉस द इनर माइटोकॉन्ड्रियल मेम्ब्रेन. वैलिनोमाइसिल, ग्रामिसिडिन एंड नाइग्रिसिन, these are the potassium ionophores. So these are related with the inhibitors, uncouplers of the electron transport chain. This is very, very important table from the Leininger biochemistry. So this is very important, very, very important. ठीक है. पॉर्फायरिया मैं आपको ब्लैंक इस पे बताता हूँ, जस्ट वेट. एक्यूट इंटरमिटेंट पॉर्फायरिया, इट इज ड्यू टू द पॉर्फोबिलिनोजेन डीअमाइनेज डिफेक्ट, डीअमाइनेज, या तो यूरोपोर्फायरिनोजेन वन सिंथेज डिफेक्ट, ठीक है. ये दोनों, इसके 3 नाम है, या तो हाइड्रोक्सी मिथिल बिलेन सिंथेज डिफेक्ट. ये तीनों इंपॉर्टेंट है, ये स्टेप ही इंपॉर्टेंट है. मैं आपको इसके बारे में बताता हूँ, जस्ट वेट, ठीक है. इसके बीच में लेते, जस्ट वेट. हाँ, ठीक है. तो साउंड आ रहा है मेरा? हाँ, ठीक है. तो ये देखो, ये याद रखो आप लोग, U1, U3 एंड UD, ये 3 चीजें याद रखो. U1, U3 एंड UD. U1 का मतलब यूरोपोर्फायरिनोजेन 1 सिंथेज, ठीक है. यूरोपोर्फायरिनोजेन 1 सिंथेज. U3 मतलब यूरोपोर्फायरिनोजेन 3 कोसिंथेज 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 एंड यूडी मतलब यूरोपोर्फायरिनोजेन डीकार्बोक्सिलेज ओके यूरोपोर्फायरिनोजेन 1 सिंथेज यूरोपोर्फायरिनोजेन 3 कोसिंथेज यूरोपोर्फायरिनोजेन डीकार्बोल ये तीन स्पेसिफिकली ये तीन पे फोकस करो ठीक है अगर इसका डिफेक्ट है यूरोपोर्फायरिनोजेन 1 सिंथेज का इट इज नोन एज एक्यूट इंटरमिटेंट पोर्फायरिया एक्यूट इंटरमिटेंट पोर्फायरिया इसको बोलते हैं एक्यूट इंटरमिटेंट पोर्फायरिया अगर इसका डिफेक्ट है यूरोपोर्फायरिनोजेन 3 कोसिंथेज इट इज नोन एज कंजेनाइटल इरिथ्रोपोएटिक पोर्फायरिया सीईपी कंजेनाइटल इरिथ्रोपोएटिक पोर्फायरिया जो कि ऑटोसोमल रेसेसिव है बाकी सारे डोमिनेंट है ओके और यूरोपोर्फायरिनोजेन डीकार्बोक्सिलेज अगर इसका डिफेक्ट है इसको बोलते हैं पोर्फायरिया क्यूटेनिया टार्डा द मोस्ट कॉमन पोर्फायरिया विथ क्यूटेनियस मैनिफेस्टेशंस आर देयर तो ये तीन इंपॉर्टेंट है एक्यूट इंटरमिटेंट पोर्फायरिया पोर्फायरिया कंजेनाइटल इरिथ्रोपोएटिक पोर्फायरिया एंड पोर्फायरिया क्यूटेनिया टार्डा ये तीनों याद रखने हैं ये तीनों इंपॉर्टेंट है ठीक है whenever there is defect in the enzyme which causes the which affect the heme synthesis pathway and there is increased porphyrin level excretion of porphyrin in the urine that is known as porphyria okay so ये acute intermittent porphyria में क्या होता है there is increase ALA amino levulinic acid and increase parphobilinogen in urine parphobilinogen there is increased level of ALA and PBG in blood and increased excretion in the urine so these are neurotoxic so there are neurological manifestations in the acute intermittent porphyria दो important manifestation रहते हैं acute intermittent porphyria में एक abdominal pain this is because of the neurovisceral involvement of the nerve is there also hemoglobin synthesis is decreased abdominal pain and the psychiatric manifestation is there neuropsychiatric manifestation तो ये दो प्रिंसिपल सिम्टम रहते हैं इसमें यहाँ पे द पोर्फायरिनोजेन जो है ना वो अभी तक बना नहीं मतलब जो बोलते हैं ना हम यूरोपोर्फायरिनोजेन वो अभी तक बना नहीं इसलिए यहाँ पे फोटो सेंसिटिविटी नहीं रहती है एक्यूट इंटरमिटेंट पोर्फायरिया में फोटो सेंसिटिविटी नहीं रहती है नो फोटो सेंसिटिविटी इन एक्यूट इंटरमिटेंट पोर्फायरिया ये जो है ये क्यूटेनियस पोर्फायरियाज है इसमें फोटो सेंसिटिविटी रहती है ये दोनों में फोटो सेंसिटिविटी मतलब फोटो सेंसिटिविटी थोड़े से भी बाहर निकलेंगे सेंसिटिविटी सन एक्सपोजर causes the cutaneous skin manifestations इसलिए ना ये रात में बाहर निकलते हैं नॉक्टर्नल एक्टिविटी इज देयर रात में बाहर निकलते हैं because of the repeated scarring even small exposure to the sun causes the lesion and scarring उसके वजह से disfigurement of the face is there so disfigurement of the face और रात में बाहर निकल रहा इंसान they are known as werewolf like appearance facial hairs repeated scarring and nocturnal activity is there so these are the cutaneous manifestation it is because of the on exposure to sunlight this porphyrinogen ये जो porphyrinogens है porphyrinogens they are converted into porphyrinogens these are converted into porphyrins UV light porphyrins this causes the generation of reactive oxygen species and release of the lysosomal enzymes release and that causes the skin manifestation that involve the skin cutaneous manifestation in this congenital erythropoietic porphyria and porphyria cutanea tarda there is no skin manifestation in acute intermittent porphyria अभी ये टेबल आपको इजी जाएगा acute intermittent porphyria it is due to the defect in uroporphyrinogen 1 synthase इसी के दो नाम है हाइड्रोक्सीमिथिलबिलेन सिंथेज या तो पार्फोबिलिनोजेन डी अमाइनेज 4 अमाइनो ग्रुप यहाँ से निकलते हैं 4 मॉलिक्यूल ये जो रहते हैं ना पार्फोबिलिनोजेन के 4 मॉलिक्यूल कंडेंस होके with the removal of 4NH3 there is synthesis of hydroxymethylbilane occur this is done with the help of enzyme कौन सा enzyme uroporphyrinogen 1 synthase इसी का दूसरा नाम है हाइड्रोक्सीमिथिल बिलिन सिंथेज या पार्फोबिलिनोजेन डीअमाइनेज, पार्फोबिलिनोजेन डीअमाइनेज। तो इसका अगर डिफेक्ट रहा तो होता है एक्यूट इंटरमिटेंट पॉर्फायरिया, एब्डोमिनल पेन एंड न्यूरोसाइकेट्रिक मैनिफेस्टेशंस आर देयर। पॉर्फायरिया क्यूटेनिया टार्डा मोस्ट कॉमन, यूरोपॉर्फायरिनोजेन डिकार्बोक्सिलेज डिफेक्ट, फोटोसेंसिटिविटी क्यूटेनिस मैनिफेस्टेशंस आर देयर। हेरिडिटरी कोप्रोपॉर्फायरिया, hereditary coproporphyria, it is due to coproporphyrinogen oxidase defect. All three symptoms are there in hereditary coproporphyria and variegate porphyria. हेरिडिटरी कोप्रोपोर्फायरिया एंड वेरीगेट पोर्फायरिया, इसमें दो तीनों सिम्टम्स रहते हैं, एब्डोमिनल पेन, न्यूरोसाइकेट्रिक मैनिफेस्टेशन एंड द फोटोसेंसिटिविटी इज देयर। कंजेनिटल इरिथ्रोपोइटिक पोर्फायरिया, इट इज ड्यू टू यूरोपोर्फायरिनोजेन 3 कोसिंथेज डिफेक्ट, co-synthase defect, autosomal recessive disorder, and there is photosensitivity. And protoporphyria, ferrochelatase defect, there is photosensitivity but mild, it is mild form, it is mild form. Okay, ये भी मैं आपको एक इसमें बताता हूँ, पहले पहले बता देता हूँ और बाद में इस पे टेबल में डिस्कस करेंगे, जस्ट वेट। ठीक है, कंजेनाइटल जॉन्डिस, कंजेनाइटल जॉन्डिस, congenital jaundice. There are two important categories in which congenital jaundice can be classified. One is congenital jaundice, one is increase in the indirect bilirubin. Indirect bilirubin, indirect bilirubin means unconjugated bilirubin. Indirect bilirubin increase, और दूसरा जो है that is increase in the direct bilirubin. Direct bilirubin increase, indirect and direct bilirubin increase. ओके ये बढ़ता है, ठीक है, डायरेक्ट बिलिरुबिन बढ़ता है या इनडायरेक्ट मतलब अनकॉन्जुगेटेड बिलिरुबिन बढ़ता है। दिस इज देयर इन द इनडायरेक्ट बिलिरुबिन, इट इज देयर इन द क्रिगलर नायर, क्रिगलर नायर, नायर टाइप 1, टाइप 1, टाइप 2 इज देयर, टाइप 2 इज देयर, एंड द गिलबर्ट, एंड द गिलबर्ट, ये तीन डिसीजेस है, गिलबर्ट सिंड्रोम, गिलबर्ट सिंड्रोम, टाइप 1, टाइप 2, क्रिगलर नायर एंड द गिलबर्ट सिंड्रोम, ये तीन है। पहला क्रिगलर नायर टाइप 1, दूसरा क्रिगलर नायर टाइप 2, तीसरा गिलबर्ट सिंड्रोम। इसमें इनडायरेक्ट बिलिरुबिन, अनकॉन्जुगेटेड बिलिरुबिन बढ़ता है, और डायरेक्ट बिलिरुबिन किसमें बढ़ता है? डायरेक्ट बिलिरुबिन इट इज डुबिन जॉनसन, डुबिन जॉनसन एंड रोटर सिंड्रोम, रोटर सिंड्रोम, इसमें डायरेक्ट बिलिरुबिन बढ़ता है। सो रिमेंबर डी आर डायरेक्ट बिलिरुबिन कॉन्जुगेटेड हाइपर बिलिरुबिनेमिया, इट इज देयर इन द डुबिन जॉनसन एंड द रोटर सिंड्रोम। क्रिगलर नायर टाइप 1, टाइप 2 एंड गिलबर्ट, देयर इज अनकॉन्जुगेटेड बिलिरुबिन इंक्रीज, देयर इज इंक्रीज इन द अनकॉन्जुगेटेड बिलिरुबिन, इनडायरेक्ट मतलब अनकॉन्जुगेटेड बिलिरुबिन। ये लेबोरेटरी में जब रिएक्शन देता है तो थोड़ा टाइम लगता है इसको कलर आने को, इसलिए इसको इनडायरेक्ट बोलते हैं। इसमें इमीडिएटली कलर आता है इसलिए इसको डायरेक्ट बोलते हैं, क्योंकि वो वाटर सोलुबल रहता है। ठीक है, क्रिगलर नायर टाइप 1 इज द कंप्लीट डेफिशिएंसी, कंप्लीट डेफिशिएंसी ऑफ यूडीपी ग्लूकोरोनिल ट्रांसफरेज, यूडीपी ग्लूकोरोनिल ट्रांसफरेज, यूडीपी ग्लूकोरोनिल ट्रांसफरेज की कंप्लीट डेफिशिएंसी, दिस इज यूडीपी ग्लूकोरोनिल ट्रांसफरेज, यूडीपी ग्लूकोरोनिल ट्रांसफरेज, इसकी कंप्लीट डेफिशिएंसी अगर है तो ये होता है क्रिगलर नायर टाइप 1। बिलिरुबिन 20 से 50 तक जाता है, इनडायरेक्ट अनकॉन्जुगेटेड बिलिरुबिन 20 से 50 मिलीग्राम पर डेसीलीटर। अफेक्ट द ब्रेन, कर्निक टेरस, कर्निक टेरस, it is unconjugated bilirubin level, it is uncoupler, it is toxic to the brain, there is no ATP synthesis, so it causes कर्निक टेरस, crosses the blood brain barrier, and it is causes the neurological feature, so it is 20 to 50 मिलीग्राम पर डेसीलीटर, बहुत ज़्यादा बढ़ जाता है क्रिगलर नायर टाइप 1 में। दिस इज टाइप 1, क्रिगलर नायर टाइप 1। टाइप 2 it is partial deficiency, partial deficiency of this enzyme UDP glucuronil transferase, 10% activity it is retained, 10% retention activity it is retained. Gilbert syndrome, it is decreased uptake of bilirubin, decrease uptake of unconjugated bilirubin, also decrease activity of UDP glucuronil transferase, near about 30%, 33% activity is retained, 33% एक्टिविटी इज रिटेन। गिलबर्ट सिंड्रोम में यहाँ पे टाइप 2 में इट इज अप टू 20 तक बिलिरुबिन जाता है, इसमें 4 तक जाता है, अप टू 4, अप टू 4 मिलीग्राम पर डेसीलीटर, माइल्ड रहता है, माइल्ड जॉन्डिस इज देयर, डिक्रीज अपटेक ऑफ बिलिरुबिन इन द गिलबर्ट सिंड्रोम। सो क्रिगलर नायर टाइप 1 टाइप 2 गिलबर्ट सिंड्रोम causes the indirect bilirubin increase and direct bilirubin increase there in the Dubin-Johnson and Rotor syndrome. Dubin-Johnson, it is due to the MRP2 mutation, there is, which is involved in the active secretion of bilirubin into bile canaliculi. So Dubin-Johnson syndrome, it is also known as black liver jaundice, because of accumulation of मेटानेफ्रिन मेटाबोलाइट्स, इपिनेफ्रिन के मेटाबोलाइट एक्यूमुलेट होते हैं डुबिन जॉनसन सिंड्रोम में। बिलिरुबिन ये माइल्ड जॉन्डिस रहता है, 4 से 5 मिलीग्राम पर डेसीलीटर तक ही जाता है दोनों में, डुबिन जॉनसन और रोटर में। हियर द इट इज डिक्रीज अपटेक ऑफ कॉन्जुगेटेड बिलिरुबिन, यहाँ पे अनकॉन्जुगेटेड अफेक्ट होता है, डिक्रीज अपटेक ऑफ अनकॉन्जुगेटेड बिलिरुबिन, यहाँ पे डिक्रीज अपटेक ऑफ कॉन्जुगेटेड बिलिरुबिन। दिस इज बिकॉज ऑफ म्यूटेशन इन ऑर्गेनिक एनायन ट्रांसपोर्टर 1b1 and 1b3 mutation, 1b3 mutation is there, organic anion transporter 1b1 1b3 mutation, which is required for the reuptake of conjugated bilirubin by the hepatocyte. This is MRP2 mutation causes the black liver jaundice, that is known as Dubin-Johnson syndrome. So indirect bilirubin increase, direct bilirubin increase. Now see the table. So Krigler-Nair type 1 type 2 complete deficiency, partial deficiency of UDP glucuronil ट्रांसफरेज, कंप्लीट डेफिशिएंसी क्रिगलर नायर टाइप 1, अनकॉन्जुगेटेड बिलिरुबिन बढ़ता है 20 to 50 मिलीग्राम पर डेसीलीटर, कर्निक टेरस वेरी हाई डेंजरस। क्रिगलर नायर टाइप 2 पार्शियल डेफिशिएंसी, बिलिरुबिन गो अप टू 20, अनकॉन्जुगेटेड बिलिरुबिन। गिलबर्ट सिंड्रोम, there is decreased uptake of bilirubin, also there is decreased activity of UDP glucuronil transferase, bilirubin go up to 3 to 4 मिलीग्राम पर डेसीलीटर, अनकॉन्जुगेटेड बिलिरुबिन बढ़ता है, Dubin-Johnson syndrome, it is defective excretion of conjugated bilirubin, MRP2 mutation, multi-drug resistant protein mutation, और MOATB बोलते हैं, multi-specific organic anion transporter, MOAT, या तो इसी को बोलते हैं ABCC2, ATP binding cassette transporter C2. There is black staining of the liver occur because of accumulation of metanephrine or the epinephrine metabolite accumulation. Conjugated bilirubinemia, direct bilirubin बढ़ता है 2 से 5 मिलीग्राम पर डेसीलीटर। This is Rotor syndrome, defective excretion of conjugated bilirubin. It is due to mutation in organic anion transporter 1b1 and 1b3. Conjugated bilirubin increases 2 to 5 milligram per deciliter. So these are the congenital jaundice, very very important, congenital jaundice. Okay, now these are the lipoproteins. So these are the lipoprotein characteristics. सो रिमेंबर दैट डेंसिटी इंक्रीजेस, क्योंकि उसका नाम ही है हाई डेंसिटी लाइपोप्रोटीन, और साइज जो है वो डिक्रीज होते जाता, डेंसिटी इंक्रीज होती जाती, साइज जो है वो कम होते जाता। नाउ रिमेंबर प्रोटीन कंटेंट अगर आपने याद रखा तो आपको लिपिड कंटेंट याद रहता। दिस इज 1%, VLDL 7 to 10%, दिस इज 11%, 21% इन द LDL एंड 30 to 60% इन द HDL। दिस इज द प्रोटीन कंटेंट। मेजर लिपिड काइलोमाइक्रॉन जो है ना वो TAG कैरी करता है, ट्राइएसिल ग्लिसरॉल, दैट इज एक्सोजिनस, जो हम डाइट में खाते हैं वो वाला TG लेके जाता है काइलोमाइक्रॉन। VLDL लीवर में जो TG बनता है वो कैरी करता है, तो उसमें TG इंपॉर्टेंट है। आइडियल बीच में है VLDL और LDL के। LDL इट इज कोलेस्ट्रॉल फ्रॉम लीवर टू द पेरिफेरल टिश्यू, इट इज HDL इट इज कोलेस्ट्रॉल फ्रॉम पेरिफेरल टिश्यू टू द लीवर। सो इसमें कोलेस्ट्रॉल मेन, ये दोनों में कोलेस्ट्रॉल है, ये दोनों में TG है, ये इंटरमीडिएट है VLDL और LDL के बीच में, फंक्शन याद रखो और अपोप्रोटीन याद रखो। अपो B48 इज देयर इन द काइलोमाइक्रॉन, अपो B100 is there in the VLDL, IDL and LDL। ये एग्जांपल है RNA एडिटिंग का, RNA एडिटिंग फ्रॉम द सेम जीन एडिटिंग, RNA एडिटिंग फ्रॉम द सेम जीन, अपो B gene, from the same अपो B gene, the two different RNA matlab because of the premature truncation of the protein synthesis, because of the conversion of cytosine into uracil, so CAA is converted into UAA, and from the same gene in the liver, the 100% synthesis occur, that is known as ApoB 100, and from the same G in the intestine, because of the premature uh, termination or truncation of the protein, only 48% is synthesized in the intestine. So that is known as RNA editing. Here 48% is produced in the intestine, that is known as ApoB48, which is a part of chylomicron. ApoB100, it is a part of VLDL, IDL, LDL. And ApoA is there mainly. Main is the ApoA in the HDL structure. HDL में सारे रहते हैं, बैड वाला पार्ट नहीं रहता, बी वाले नहीं रहते. अपो A is there, अपो C is there, अपो D is there, अपो E is there. ओके, इन द HDL. ओके, इसका क्या फंक्शन है? ट्रांसपोर्ट द TG. कौन सा TG ट्रांसपोर्ट करता है? एक्सोजिनस, जो हम डाइट में खाते हैं. कौन? काइलोमाइक्रोन. ये VLDL क्या कैरी करता है? जो लीवर में TG बनता है, एंडोजिनस ट्राइसाइल ग्लिसरॉल. एंडोजिनस ट्राइसाइल ग्लिसरॉल कैरी करता है. Okay, ideal it is intermediate between VLDL and the LDL. LDL carries the cholesterol from liver to the peripheral tissue, and this is reverse transport of cholesterol. HDL, reverse transport of cholesterol from peripheral tissues to the liver. ट्रांसपोर्ट ऑफ कोलेस्ट्रॉल फ्रॉम पेरिफेरल टिश्यू टू द लिवर, गुड कोलेस्ट्रॉल बोलते हैं HDL को, और LDL को बैड कोलेस्ट्रॉल बोलते हैं. LDL को बैड कोलेस्ट्रॉल बोलते हैं. ठीक है, दिस आर द फंक्शंस. 48 is there in the chylomicron, 100 is there in the VLDL, IDL, LDL. Okay. See, remember ApoC2, this is important. ApoC2, this ApoC2 activates the lipoprotein lipase. ApoC2 activates the lipoprotein lipase. And this ApoA1 activates the lecithin cholesterol acyl transferase, LCAT. ये दोनों याद रखो. ApoC2 activates the lipoprotein lipase and ApoA1 activates the LCAT. And AC23, that is ApoA2 and ApoC3 inhibit the lipoprotein lipase. ये चार चीजें याद रखो. ApoC2 activates lipoprotein lipase, ApoA1 activates the LCAT, A2 inhibits the LPL, and ApoC3 inhibit the LPL, lipoprotein lipase को. मतलब AC23 inhibit the lipoprotein lipase. तो ये lipoprotein और उनके मेन फंक्शन हो गए. अभी हाइपरलिपिडेमिया, हाइपरलाइपोप्रोटीनेमिया, द फ्रेडरिक्सन क्लासिफिकेशन ऑफ हाइपरलाइपोप्रोटीनेमिया. इट इज वेरी वेरी इंपॉर्टेंट. टाइप 1 एंड टाइप 2 दोनों बहुत इंपॉर्टेंट है. टाइप 1 एंड टाइप 2 रिसेंटली इस पे बहुत क्वेश्चन आ रहे. टाइप 1 एंड टाइप 2. सी, इफ द कोलेस्ट्रॉल लेवल्स आर रेज, कोलेस्ट्रॉल बढ़ा हुआ है, LDL कोलेस्ट्रॉल बढ़ा हुआ है, थिंक अबाउट द familial cholesterolomia. Think about the familial cholesterolomia, that is type 2A. There is tendon xanthoma, involvement of the tendon. Mainly the Achilles tendon is involved. Tendon xanthoma is there. There is xanthelasma, eyelid involvement. Eyelid के ऊपर येलो कलर का ये आता है, येलो कलर के लीजन्स आते हैं. So that is xanthelasma. The tendon xanthoma is there. Because of increased LDL level, there is risk of atherosclerosis in the type 2A. Type 2A. ट्राइग्लिसराइड किस किस में बढ़ता है? पहले में बढ़ता है और चौथे पांचवे में बढ़ता है. फर्स्ट, फोर्थ एंड फिफ्थ TG levels are raised. TG levels are raised. There is eruptive xanthomas. Eruptive all over the body. There is eruptive xanthoma, yellowish nodules because of increase of the TG level. Chylomicron अगर बढ़ गया, chylomicron which is there in the type 1, there is milky plasma. अगर आप सेंट्रीफ्यूज करते हो तो आपको मिल्की प्लाज्मा मिलेगा, मतलब वाइटिश कलर, लाइपेमिक प्लाज्मा बोलते हैं. मिल्की प्लाज्मा इज देयर. इट इज अ फीचर ऑफ टाइप 1, दैट इज लाइपोप्रोटीन लाइपेज और ApoC2 डिफेक्ट. familial chylomicronemia. So familial chylomicronemia, it is type 1. Familial chylomicronemia, this is type 1. And type 2A, it is familial hypercholesterolemia. Familial hypercholesterolemia. Okay. Type 4 and 5, it is triglyceridemia. Familial TG increase, type 4 and type 5. Type 1 is familial chylomicronemia. तो पहला और दूसरा बहुत इंपॉर्टेंट है. Type 1, it is familial chylomicronemia. It is due to lipoprotein lipase defect or ApoC2 defect which is required for activation of lipoprotein lipase, ये इसको एक्टिवेट करता है। ApoC2 का डिफेक्ट या लाइपोप्रोटीन लाइपेज का डिफेक्ट, इसमें काइलोमाइक्रॉन बढ़ जाता है। काइलोमाइक्रॉन टीजी कैरी करता है, तो टीजी लेवल बढ़ जाता है। टीजी लेवल मोर देन 1000, टीजी लेवल मोर देन 1000 मिलीग्राम पर डेसीलीटर। काइलोमाइक्रॉन लेवल बढ़ जाता है, उसके वजह से मिल्की प्लाज्मा दिखता है, मिल्की प्लाज्मा, लाइपेमिक प्लाज्मा, वाइट प्लाज्मा इज देयर, and there is, because of the increased TG level, there is risk of pancreatitis. Eruptive xanthomas are there all over the body. Small nodules are there. Small nodules are there because of the increased chylomicron and TG. Eruptive xanthomas are there mainly because of the TG, and because of increased TG, there is risk of pancreatitis in the type 1. Type 2, it is familial hypercholesterolemia. It is due to the LDL receptor defect, LDL receptor defect or ApoB100 defect. LDL receptor or ApoB100 defect, there is increase in the LDL cholesterol, there is increase in the cholesterol, so there is increased risk of atherosclerosis. There is xanthal asthma, there is tendon xanthoma, there is risk of atherosclerosis. There is xanthal asthma also, xanthal asthma. So eyelid पे yellow color के nodule आते हैं। See, ये it is not exact like this. This is just representation. So this is known as xanthal asthma. Xanthal asthma. This is there in the type 2A. Type 2A. And there is tendon xanthoma. Achilles tendon is involved. Tendon के ऊपर firm nodules रहते हैं. This is known as xanthomas. So tendon xanthoma बोलते हैं इसको. So this is there in the where when there is increase in the LDL cholesterol, there is increase in the cholesterol. There is risk of atherosclerosis in this condition. Okay. Then type 2B, it is familial combined dyslipidemia. Familial combined dyslipidemia. देन टाइप 3, इसमें सभी बढ़ते हैं जनरली। एलडीएल बढ़ता है मतलब कोलेस्ट्रॉल भी बढ़ता है, वीएलडीएल मतलब टीजी बढ़ता है, इसमें सभी बढ़ते हैं। फैमिलियल कंबाइंड डिस्लिपिडेमिया काफी कॉमन भी है, लेकिन जनरली पूछते नहीं क्योंकि ये मिक्सअप होते हैं सारे सिम्टम्स। टाइप 3, इट इज फैमिलियल डिस्बिटा लाइपोप्रोटीनेमिया, इट इज ड्यू टू द अपोईव डिफेक्ट। इसमें रेमनंट वाले बढ़ते हैं, रेमनंट वीएलडीएल और काइलोमाइक्रॉन रेमनंट बढ़ते हैं। फैमिलियल हाइपर ट्राइग्लिसरीडेमिया टाइप 4 एंड टाइप 5 दोनों में टीजी बढ़ता है। टाइप 4 इज एसोसिएटेड विथ अल्कोहलिज्म, इंसुलिन रेजिस्टेंस, ओबेसिटी। सी इट इज एसोसिएटेड विथ ग्लूकोज इंटॉलरेंस, हाइपर इंसुलिनेमिया, alcoholism, obesity and diabetes mellitus, it is associated. So this is overproduction of VLDL in the type 4, overproduction of VLDL and decreased clearance of chylomicron in the type 5. Overproduction of VLDL and decreased clearance of chylomicron in the type 5. So TG जो है वो फर्स्ट, फोर्थ और फिफ्थ में बढ़ता है। एलडीएल कोलेस्ट्रॉल टाइप 2 में बढ़ता है। जब टीजी बढ़ता है देयर इज रिस्क ऑफ पैनक्रियाटाइटिस, जब एलडीएल बढ़ता है देयर इज रिस्क ऑफ एथेरोस्क्लेरोसिस। जब कोलेस्ट्रॉल एलडीएल कोलेस्ट्रॉल बढ़ता है देयर इज टेंडन xanthoma, टेंडन नोडुल टेंडन पे रहता है या xanthal asthma इज देयर। एंड जब टीजी बढ़ता है देयर इज इरप्टिव xanthoma, पाल्मर xanthoma इज देयर इन द टाइप 3 dis beta lipoproteinemia, type 3 ApoE defect, Palmer xanthoma is there. Okay, so this is familial hyperlipoproteinemia. This is yellow orange color tonsil. This is a classical feature of Tanger's disease. There is reduced level of high density lipoprotein, 0 to low HDL level is there. There is hepatosplenomegaly. Tonsil appears as shown in the image, that is yellow orange color tonsil, low HDL level. The hepatosplenomegaly and neuropathy is there. This is a feature of Tanger's disease. It is alpha lipoprotein deficiency. It is ABC A1 defect. ATP binding cassette transporter A1, which is required for transport of cholesterol from peripheral tissues to the HDL core. जिसके वजह से HDL ऐसे spherical बनता है. So this is Tanger's disease. Now see the question. A 7-year-old child present with progressive fatigue, abdominal distension and recurrent bone pain. On physical examination, hepatosplenomegaly is noted. So there is hepatosplenomegaly. There is bone pain. द लेबोरेटरी इन्वेस्टिगेशन रिवील एनीमिया एंड थ्रोम्बोसाइटोपेनिया, मतलब आरबीसी कम हो गई है और प्लेटलेट भी डाउन है, हिपेटोस्प्लेनोमेगाली इज देयर, बोन भी इन्वॉल्व है. एक्सरे ऑफ द लॉन्ग बोन शोज एर्लेन मेयर फ्लास डिफॉर्मिटी. दिस इज द क्लासिकल फीचर ऑफ गाउचर्स डिसीज. बोन मैरोप्सी shows the wrinkled, it shows the wrinkled tissue paper appearance. Macrophages, this is wrinkled tissue paper. This is a classical feature of Gaucher's disease. Gaucher's disease. Lysosomal storage disorder, Gaucher's disease, wrinkled tissue paper, macrophages. There is involvement of bone. There is involvement of bone marrow, liver and spleen. Liver and spleen. So there is hepatosplenomegaly. There is hepatosplenomegaly. Megaly is there. Bone marrow involvement is there. Avascular necrosis of the bone is there. Macrophages shows the wrinkled tissue paper appearance in the microscopy. There is bone marrow involvement, decrease RBC count, decrease RBC, WBC, and the decreased WBC and decreased platelet, thrombocytopenia. So because of the decreased platelet, there is bleeding. There is bleeding. So these are the features of Gaucher's disease: Erlenmeyer flash deformity, wrinkled tissue paper appearance, anemia, thrombocytopenia, leukopenia is there, bone involvement is there, a vascular necrosis of the bone, X-ray feature Erlenmeyer flash deformity, and the wrinkled tissue. There is no cherry red spot on the macula. Lysosomal storage disorder जैसे निमैन पीक हो गया, टेसैक हो गया, इनमें चेरी रेड मैकुला दिखता है, इसमें चेरी रेड मैकुला नहीं दिखता है. ठीक है, दिस इज गाउचर्स डिसीज. सो दिस इज रिंकल्ड टिश्यू पेपर मैक्रोफेजेस, रिंकल्ड पेपर मैक्रोफेजेस, दिस इज रिंकल्ड पेपर मैक्रोफेजेस, ये वाले जो है. एंड दिस इज एर्लेन मेयर फ्लास्क, कोनिकल फ्लास्क, जैसे लोअर एंड ऑफ द फीमर लुक्स लाइक कोनिकल फ्लास्क. जस्ट वेट, it looks like conical flask. So this is known as the Erlenmeyer flask deformity. Which enzyme deficiency is responsible for this condition? It is beta glucocerebrosidase. ग्लूकोसेरेब्रोसाइड को जो क्लीव करता है, बीटा ग्लूकोसेरेब्रोसाइडेज, यहाँ पे लिख दूं क्या है आगे जाके. सो बीटा ग्लूकोसेरेब्रोसाइडेज, इसके वजह से ग्लूकोसेरेब्रोसाइड का डिग्रेडेशन नहीं होता और ग्लूकोसेरेब्रोसाइड एक्यूमुलेट होता है, उसके वजह से ये सारे फीचर्स है. गाउचर्स डिसीज. द फॉलोइंग फंडोस्कोपिक डिफेक्ट कैरेक्टरिस्टिक फाइंडिंग, ये कैरेक्टरिस्टिक फाइंडिंग है, इसको बोलते हैं चेरी रेड स्पॉट ऑन द मैक्यूला. क्या होता है, लाइसोसोमल स्टोरेज डिसऑर्डर में लिपिड बढ़ जाते हैं. सो लिपिड एक्यूमुलेशन, ये जो ग्लाइकोलिपिड्स है ये एक्यूमुलेट्स इन द रेटाइना, ये सारे रेटाइना में जमा होके पूरा रेटाइना पेल कर देते हैं. लेकिन ये जो सेंट्रल फोविया रहता, फोविया जहाँ पे ये रेटाइनल गैंग्लियन सेल लेयर नहीं रहती, वहां पे इट अपीयर्स ब्राइट ऑन द फंडोस्कोपी, दैट इज नोन एज चेरी रेड स्पॉट ऑन द मैक्यूला. इट इज अ क्लासिकल फीचर ऑफ लाइसोसोमल स्टोरेज डिसऑर्डर. निमैनपिक में रहता है, टेसेक्स में रहता है, सैंडॉप में रहता है. सो इट इज देयर but it is not there in the KGUP. Remember this, it is not there in the KGUP. It is Krabbe's disease, Krabbe's में नहीं रहता है, Krabbe's disease में नहीं रहता है, Gaucher's में नहीं रहता है, Gaucher's disease में नहीं रहता है, और Fabry's disease में नहीं रहता है. Fabry's disease, ये तीनों डिसीजेस में चेरी रेड स्पॉट ऑन मैकुला नहीं रहता. नो चेरी रेड स्पॉट ऑन द मैकुला इन द KGUP. Krabbe's, Gaucher and Fabry's disease. Okay, now see, these are the some silent features to remember this lysosomal storage disorder. See, cherry red macula without hepatosplenomegaly. cherry red macula है लेकिन hepatosplenomegaly नहीं है, organomegaly नहीं है. So it is hexosaminidase A defect, that is Tay-Sachs disease. It is Tay-Sachs disease. Important है, GM2 gangliosidosis, Tay-Sachs और सैंडॉप. सैंडॉप में ऑर्गेनोमेगाली रहती, Tay-Sachs में ऑर्गेनोमेगाली नहीं रहती. GM2 gangliosidosis, hexosaminidase defect, hexosaminidase A defect, Tay-Sachs disease. No organomegaly, but there is cherry red spot on the macula. Cherry red macula with hepatosplenomegaly, hepatosplenomegaly. It is there in the Niemann-Pick disease. It is there in the Niemann-Pick disease. Sphingomyelinase defect. This is due to sphingomyelinase defect. Sphingomyelin accumulate होता है. Niemann-Pick disease. Foam cell macrophages, cherry red spot on the macula, and hepatosplenomegaly is there. Bone crisis, Erlenmeyer flash deformity in the X-ray, crumpled tissue paper or wrinkled tissue paper, macrophages, and pancytopenia, decreased RBC, WBC, and the platelet and the bleeding tendency because of the decreased platelet. So this is seen in Gaucher's disease, beta glucocerebrosidase defect. There is no cherry red spot on the Gaucher's disease, and the mental retardation is rare in case of the Gaucher's disease. Then Fabry's disease, you can remember ABC, A, B, and C. Angiokeratomas, angiokeratomas. C, A, angiokeratomas, burning sensation in the hand and feet, and corneal opacities. Corneal opacities, this is C. Corneal opacities. A, B, C. You can remember Fabry's disease, X-linked disorder है, X-linked disorder है, X-लिंक इनहेरिटेंस है इसका, फैब्रिज डिसीज का. अल्फा गैलेक्टोसाइडेज डिफेक्ट, दिस इज अल्फा गैलेक्टोसाइडेज डिफेक्ट. Angiokeratomas, bathing trunk area is involved, burning sensation in hand and feet, that is known as acroparesthesia, corneal opacity is there, young age involvement at the young age involvement, so young age it is involved, young age group it is involved, and renal vessels are involved, renal vessels are involved in this disease, renal vessels. So remember, it is angiokeratomas means small telangiectatic lesion involving the below the umbilicus and above the knee joint. So it is known as bathing trunk area is involved, angiokeratomas. Then the burning sensation in hand and feet, that is known as acroparesthesia, and the corneal opacity, young age involvement, the renal vessels are involved, stroke is there. Stroke, there is chances of stroke in the Fabry's disease, alpha galactosidase defect, X-linked inheritance is there. Then Hurler and Hunter, these are the mucopolysaccharidosis. Hunter में clear cornea रहता है, ये एक ही important feature है इसका. Hunter there is clear cornea, no corneal clouding in the Hunter syndrome. It is X-linked disorder, and the behavioral aggressive behavior is there. Male, typical male involvement, X-linked disease, no corneal clouding in the hunter needs vision. hunter को hunt करने के लिए vision लगता है, तो उसका vision normal रहता है. Hunter, no corneal clouding is there, aggressive behavior, X-linked disorder. बाकी के सारे फीचर दोनों में सेम रहते हैं. हर्लर हंटर में there is coarse faces, mental retardation is there, hepatosplenomegaly is there, skin lesions are there, skeletal deformities are there, short stature is there. बहुत सारे features common रहते, सिर्फ no corneal clouding in the Hunter syndrome. It is iduronate defect, it is iduronate sulfatase defect. ये पहला है हर्लर. रिमेंबर, लेडीज फर्स्ट, हर्लर थोड़ा सा फेमिनाइन नाम है, तो हर्लर इज फर्स्ट एंड द हंटर इज सेकंड. हंटर क्योंकि पीछे दौड़ता है ना हंट करने के लिए, तो वो सेकंड है, और उसका कॉर्निया क्लियर रहता है. आइडुरोनिडेज डिफेक्ट, आइडुरोनेट सल्फेटेज डिफेक्ट. नो चेरी रेड स्पॉट ऑन द मैक्युला, इट इज देयर इन द केजीएफ, क्रैबेज, गाउचर एंड फैब्रिज डिसीज. Now coming to the nutrition topic, the BMR SDA of the food. See, इसमें 2 पॉइंट पहले बताता मैं, 2 पॉइंट. The calorie requirement of the individual, you can calculate calorie per kg body weight per day. It is depending upon the type of work. Sedentary work, अगर sedentary work है, मतलब बैठे बैठे काम कर रहा है, sedentary work, या तो moderate type of work है या तो heavy type of work है. You can calculate the calorie requirement, 30 calorie per kg body weight per day, 40 calorie per kg body weight per day, 50 calorie per kg body weight per day. Okay, 30, 40, 50 in case of the main. This is calorie requirement, approximate, not exact. And in case of the female, it is 25 calorie per kg body weight, 35 calorie, and the 45 calorie, 25, 35, 45 calorie per kg body weight per day. सपोज एखादा रिक्शा पुलर है, वो हेवी वर्क है और उसका वेट 50 kg है, 50 kg, so you can multiply 50 into 50, 2500 calorie is required per day. समझ में आया? So this is calorie requirement per kg. This is मतलब calorie requirement, this is approximate calorie requirement per kg body weight per day. Protein requirement कैसे calculate करते हैं? Protein requirement, for protein the formula is 0.83 gram per kg body weight per day. per kg 0.83. जैसे हम रफ कैलकुलेट करते हैं कि 50 kg अगर वेट है तो 50 ग्राम प्रोटीन रहना चाहिए. इट इज 0.83 फॉर मेल, 0.83 फॉर फीमेल per kg body weight per day. Additional requirement for pregnancy and lactation is there. For pregnancy, additional 350 calories should be added in the pregnancy. Additional 600 calories should be added in the lactation. Protein, in the second trimester, 9.5 gram of the protein should be added over and above this requirement. And in the third trimester, it is the कितना ग्राम रहता है, लगभग 22 gram. 22 gram in the third trimester, and the 17 gram in the lactation. So this is protein requirement in normal condition. Pregnancy and lactation, the protein requirement increases. Second trimester, additional 9.5 gram, and the third trimester, additional 22 gram protein should be added. In lactation, 17 gram protein should be added over and above this requirement. Okay. See, carbohydrate, SDA, specific dynamic action of the food. It is for the utilization of the food. SDA matlab it is for the utilization of food stuff over and above the SDA matlab specific dynamic action, calorigenic action of the food. This is required to burn this food, to process this food. Mainly it is required for digestion, absorption, transport, storage, and metabolism. Digestion, absorption, transport, storage, and metabolism. So it is 10% should be calculated over and above the BMR, considering the SDA of food. In case of the protein, it is much higher, that is 30%. 30% in case of the protein. This is attributed for, this is for the utilization of energy for the trans-deamination, utilization of energy for the urea loss or urea lost, some amount of urea, मतलब यूरिया अपने साथ कुछ एनर्जी लेके चले जाता है. सो अमोनिया इज कन्वर्टेड इनटू यूरिया, ट्रांस deamination is required. So urea, some amount of energy is lost in the urea, and some amount of energy is required for the protein synthesis. So for this process, SDA of the food should be calculated. Additional 10% SDA should be calculated. Protein is not a good food for the energy. Protein, it is important food for the bodybuilding. So 30% SDA is for the protein. So it is for the trans-deamination, urea synthesis, and the protein synthesis. The energy is lost. So utilization of foodstuff 30% in case of the protein. Caloric requirement over and above the BMR for the processing of the foodstuff. For the processing of the foodstuff, mainly digestion, absorption, transport, storage, and the metabolism of the foodstuff. Carbohydrate, it is mainly required to convert the glucose into glycogen. It is 5 to 10%. Lipid, it is for the utilization and storage. It is 0 to 5%. For the mixed diet, it is 10%. Caloric value means how much gram of carbohydrate, 1 gram of carbohydrate gives 4 calorie, 1 gram of the lipid gives 9 calorie, and 1 gram of the protein will give you 4 calorie. And respiratory quotient means it is a value of CO2 produced to the oxygen consumed, O2 consumed. CO2 produced to the oxygen consumed when particular foodstuff is utilized by the body. When particular foodstuff is utilized by the body. This is the ratio of CO2 consumed to the O2, CO2 produced to the O2 consumed ratio. In case of the carbohydrate, 6 CO2 are produced by the glucose and 6 O2 consumed. So it is 1 in case of the carbohydrate. In case of the fat, it is 0.7. In case of the protein, it is 0.8. And for the mixed diet, it is 0.85. Remember, in diabetic ketoacidosis and starvation, the this RQ approaches 0.7 because lipids are utilized as a foodstuff. It tells about the metabolic state of the individual. Okay, 0.7. The RQ decreases in the starvation and diabetic ketoacidosis because lipid is utilized as the energy fuel. Lipid is utilized as a energy fuel. These are the now inborn errors of protein metabolism, that is phenylalanine and tyrosine metabolism. Phenylketonuria, it is phenylalanine hydroxylase defect. There is mental retardation, seizure, and mousy odor of urine. Mousy odor of urine, it is because of the excretion of phenyl acetate in the urine. It is because of phenyl acetate excretion in the urine. Neonatal tyrosinemia, it is parahydroxyphenyl pyruvate hydroxylase defect. Tyrosinemia type 1, it is fumarate acetate. First, remember the first, fumaryl acetoacetate hydrolase defect. टायरोसिन में टाइप 2, दो टी रहते हैं इसमें, टायरोसिन ट्रांसअमाइनेज, अमाइनो ट्रांसफरेज लिखा है, टायरोसिन ट्रांसअमाइनेज डिफेक्ट causes the tyrosinema type 2. Alkaptonuria homogentisate oxidase defect, black color on standing, homogentisate oxidase defect, black color on standing because of elevated level of homogentic acid on exposure to the air or alkalinization of the urine turns the urine into dark color. So alkaptonuria, homogentisate oxidase. Albinism, it is tyrosinase defects, copper dependent enzyme tyrosinase defect, albinism. See, this is black coloration in the cornea. It is the ear cartilage and the palmar crease which appears the black. This is uchronosis. This is known as uchronosis. Black urine on standing, black staining of the cartilage and tendency to develop arthritis in the latter age. It is seen in the disease alkaptonuria. It is seen in the disease alkaptonuria. There is increased excretion of homogentic acid, which on alkalinization it is converted into black color. So the black urine on standing, deficient enzyme is homogentisate oxidase. Remember, black color of the urine on standing, this is a feature, black urine on standing often goes unnoticed. You can notice the black staining of diaper is there. Okay, there is tendency to develop arthritis because of the deposition of alkaptone pigment in the joint, that is known as uchronosis in the latter ages, because this homogentic acid is converted into benzoquinone acetate and which on polymerization form the alkaptone pigment. So there is alkaptonuria. This is albinism, generalized hypopigmentation is there. This is known as albinism. Photophobia, nystagmus is there. Hypopigmentation, fair color of the skin, eyes and hair. The intolerant to the light because direct entry of the sunlight into the eyes. So enzyme defect is tyrosinase, copper dependent enzyme tyrosinase. This is copper dependent enzyme tyrosinase. Now see, a 10-year-old child present with severe sensitivity to the sunlight, multiple freckles, ऐसे थोड़े छोटे ऐसे तिल आ जाते हैं. So multiple freckles and pigmentation on sun exposed areas. The parent report recurrent skin cancer. See, the recurrent skin cancer is mentioned here. So there is photosensitivity and recurrent skin cancer, delayed healing of the sunburn after minimal sun exposure. Which type of DNA repair is defective in this condition? So this is sun exposed dermatitis is there, sun exposed lesions are there. This is a UVB rays which causes this defect. There is formation of thymine dimer, covalent linking between two adjacent thymine residue. There is cyclobutane ring in between two thymine residue. This is because of the thymine dimer formation because of the UV light. If it is not repaired by the mechanism that is known as nucleotide excision repair, if it is not repaired by this mechanism, this thymine dimer is there. This is there in the disease that is known as xeroderma. Zero matlab dry, derma matlab skin, dry skin. Pigmentosum, pigmented lesion, xeroderma pigmentosum. This is a skin condition, precancerous lesion. There is 1000 time risk of getting 1000 time risk of getting skin cancer, specifically basal cell carcinoma, squamous cell carcinoma, melanoma. Basal cell carcinoma, squamous cell carcinoma, melanoma. There is increased risk of skin cancer on sun exposure. So it is repaired by the nucleotide excision repair. If it is not repaired by the nucleotide excision repair, it causes the xeroderma pigmentosum. So it is nucleotide excision repair defect. See the another case, a 45-year-old male present with rectal bleeding and abdominal pain. His colonoscopy revealed tumor in the ascending colon. Now see, it is tumor in the ascending colon. His family history is significant for colorectal cancer. Family history for colorectal cancer is there. Okay, to his father, diagnosed at the age of 48, and endometrial cancer to his sister, diagnosed at the age 42. So there is family history of cancer. Which of the following DNA repair mechanism is defective in? यहाँ पे diagnosis already दिया है, hereditary non-polyposis colorectal cancer. This is due to the fault in the mismatch repair. Fault in the mismatch repair. So this is, remember, HNPCC. It is autosomal dominant condition, familial condition. This is familial condition. Early age cancer is there. Early age cancer is there. Cancer is there. There is very few polyp, no polyp, no polyp, or few polyp, and these are cancerous. Turn into cancer, turn into cancer. These polyps, they are cancer, turn into cancer. Mainly there is cancer of colon and rectum, mainly. Also the endometrial cancer is there. Next frequent endometrium cancer is metrium is involved. Also other part of the body also involved. Early age cancer, family history, generations are involved. Familial members are involved. Early age cancer, detection at the early age due to fault in the mismatch repair. This is also known as Lynch syndrome. Lynch syndrome, fault in the mismatch repair. There is microsatellite instability. There is mutation. There is mutation in the gene, mutation in the MLH, mute L analog, MLH, MSH, PMS gene mutation, that causes microsatellite, मतलब DNA repeat sequences, microsatellite instability can be diagnosed on the basis of immunohistochemistry. Immunohistochemistry में ये marker identify कर सकते हैं, या immunohistochemistry में the specific proteins are detected in the microsatellite this microsatellite instability is detected in the immunohistochemistry. So these are the different points related with the hereditary non-polyposis colon cancer, also known as Lynch syndrome. See, fault in the nucleotide excision repair causes xeroderma pigmentosum. Fault in the mismatch repair causes the hereditary non-polyposis colon cancer. See, ionizing radiation, X-ray, and anti-tumor drugs causes the double strand break or single strand break, and these are repaired by the non-homologous end joining and homologous recombination. Non-homologous end joining मतलब क्या होता है, जहाँ पे ब्रेक हो गया उसको जैसे के वैसे कनेक्ट कर दो. That is known as non-homologous end joining. There is very high chances of mutation in the non-homologous end joining, but it is better than loss of the chromosome. So non-homologous end joining defect causes SCID, severe combined immunodeficiency. Non-homologous end joining. Homologous recombination defect causes the ataxia telangiectasia like disorder, or Bloom syndrome, or Fanconi anemia, and there is risk of the cancer, breast cancer. Breast cancer is also there in the defect in the homologous recombination. Then the UV light induced, if it is there, if thymine dimer formation is there, it is repaired by the nucleotide excision repair. If it is not repaired, it is known as xeroderma. Zero matlab dryness, derma matlab skin. Pigmentosum means hyperpigmentation is there. Xeroderma pigmentosum is there. Freckles, multiple freckles on sun exposed part of the body. There is risk of the cancer. Okay, and the this is very rare. Mute YH associated polyposis, this is very rare. Then if there is mismatch repair defect, this causes HNPCC, that is hereditary non-polyposis colon cancer. Very few polyp or no polyp is there in the colon rectum area mainly. There is autosomal dominant condition. Early age cancers are there, mainly involving the rectum and colon. Also other part of the bodies are also involved. There is microsatellite instability. There is mutation in MLH, MSH and PMS genes. So this is involved. The genes are involved in the mismatch repair. Fault in the mismatch repair causes the HNPCC, or also known as Lynch syndrome. Okay. नाउ दिस इज वेरी वेरी रिलेटेड, हमने बोला था, इनको छोड़ा था हमने थोड़ा सा लेके. A 16-year-old male present with progressive tremors are there, difficulty speaking and mood changes, KF ring. This is a classical feature, KF ring. Kaiser-Fleischer ring is there, was noted in slit lamp examination. It is there in the decimate membrane of the cornea. This is important MCQ from ophthalmology. Decimate membrane of the cornea, and it is there in the 99% of the cases with neuropsychiatric manifestation. 99% cases with neuropsychiatric manifestation is having the KF ring, Kaiser-Fleischer ring. It is the deposition of copper in the decimate membrane of the cornea. Deposition of copper in the decimate membrane of the cornea. This is KF ring. Decimate membrane of the cornea. There is Kaiser-Fleischer ring in the decimate membrane of the cornea. Remember this. This is MCQ ophthalmology. This is a copper excess condition. ATP7B mutation. ATP7B mutation causes the Wilson's disease. This is Wilson's disease. Wilson's disease. ATP7B mutation causes the Wilson's disease. This is Wilson's disease. That is known as hepato, matlab liver. Hepato. Lenticular, matlab lenticular nucleus of the brain. Hepatolenticular degeneration. Lenticular degeneration. Hepatolenticular degeneration. Because of the ATP7B mutation, there is failure to incorporate copper into a ceruloplasmin. There is failure to excrete copper into the bile. So there is copper excess. So this copper accumulates into the hepato, मतलब liver, lenticular मतलब brain. Hepatolenticular degeneration बोलते हैं, मतलब brain में और liver में copper accumulate होता है. उसके वजह से brain related symptoms are there, tremors, ataxia, these are the symptoms, and the hepato, matlab jaundice is there, hepatomegaly is there, hepatomegaly is there. There is KF ring in the decimate membrane of the cornea. Also the sunflower cataract can be there, accumulation of copper in the lens. The diagnosis of this condition, the diagnosis is done by the liver biopsy and quantification of copper in the dry weight of the liver. Liver biopsy and quantification of copper in the dry weight of the liver. So it is diagnostic test is liver biopsy and quantification of copper assay in the liver biopsy sample. It is more than 250 microgram per gram of liver tissue, dry weight of the liver, per dry weight of the liver. So this is definitive test. Also urine copper assay, that is more than 100 microgram per day. It is important in the screening. Ceruloplasmin level, it is important in the screening, not in the diagnosis. Decrease ceruloplasmin level. दोनों में ceruloplasmin कम होता है, विल्सन में भी और मेंकेज में. मेंकेज तो मेंकेज it is X-linked disorder. Mental retardation is there, hypopigmentation is there, lysyl oxidase enzyme is affected because of the decreased copper level. Because of ATP7A mutation, the lysyl oxidase activity is affected. Lysyl oxidase is required for the collagen cross-linking. That's why this is Menkes disease. This is Menkes disease. That is neurodegenerative disorder. Okay, just wait. कौन सा डिसीज होगा डायग्नोस करो, बहुत इजी है, प्यूरिन साल्वेज पाथवे से रिलेटेड है. A 3-year-old boy is brought to clinic with symptoms of delayed developmental milestone, self-mutilating behavior, biting of finger and lips, and involuntary movements, choreoathetosis is there. Laboratory investigation reveals hyperuricemia. Which metabolic pathway is primarily affected in this disorder? So this is purine salvage pathway, which is important in the pathway. This pathway is important in the brain. For the nucleotide synthesis. for the nucleotide synthesis. If this enzyme is defective, that is HGPRTase, hypoxanthine guanine phosphoribosyl transferase. If it is defective, it causes, it is there, this is X-linked disorder, affect the boy, matlab male, males are affected, aggressive behavior, सेल्फ बैंगिंग, हेड बैंगिंग एक्टिविटी, सेल्फ म्यूटिलेटिंग, थोड़ा बहुत नाखून हम भी खाते हैं क्रिकेट मैच देखते हुए. सो इट इज द सीवियर नेल बाइटिंग इज देयर, हेड बैंगिंग इज देयर, सेल्फ म्यूटिलेटिंग एक्टिविटी इज देयर, एंड हाइपर यूरेसेमिया इज देयर, HGPRTase deficiency, hypoxanthine guanine phosphoribosyl transferase deficiency, Lesch-Nyhan syndrome. It is known as Lesch-Nyhan syndrome. Lesch-Nyhan syndrome, complete deficiency of HGPRTase, complete deficiency of HGPRTase, hypoxanthine guanine phosphoribosyl transferase. ओके, तो अभी मैं ये एसिड बेस बैलेंस के पूरे डिटेल में नहीं जाऊंगा क्योंकि दिस इज वेरी वेरी इंपॉर्टेंट टॉपिक. इंपॉर्टेंट तो है लेकिन बहुत इसको बहुत टाइम भी लगता है. बेसिक पे जाऊंगा. सी, हाई एनायन गैप मेटाबॉलिक एसिडोसिस. एनायन गैप मतलब क्या होता है? एनायन गैप मतलब एनायन गैप इज इक्वल टू सोडियम लेवल्स माइनस बाइकार्बोनेट HCO3 बाइकार्बोनेट प्लस क्लोराइड. ओके, मेटाबॉलिक एसिडोसिस अगर हुआ तो बाइकार्बोनेट लेवल्स आर डिक्रीज. मेटाबॉलिक एसिडोसिस में ये जो मेटाबॉलिक एसिडोसिस है इसमें बाइकार्बोनेट लेवल डिक्रीज हो जाता है, HCO3 लेवल डिक्रीज हो जाता है. लेकिन सम कंडीशंस आर देयर, देयर इज इंक्रीज इन द क्लोराइड लेवल, तो उसके वजह से कॉम्पेंसेट होता है. तो उसमें होता है, उसमें जो मेटाबॉलिक एसिडोसिस होता है दैट इज नोन एज नॉर्मल एनायन गैप मेटाबॉलिक एसिडोसिस. वो जो होता है दैट इज नॉर्मल एनायन गैप मेटाबॉलिक एसिडोसिस जिसमें क्लोराइड कॉम्पेंसेट करता है. लेकिन यहाँ पे डिक्रीज बाइकार्बोनेट और हाई एनायन गैप, ये एनायन गैप जो 8 to 12 नॉर्मल रेंज है इसकी, 8 to 12 मिली इक्विवेलेंट पर लीटर, अगर इससे ज्यादा है तो उसको बोलते हैं हाई एनायन गैप मेटाबॉलिक एसिडोसिस. तो मड पाइल्स, दीज आर द कॉजेस ऑफ हाई एनायन गैप मेटाबॉलिक एसिडोसिस. मिथेनॉल पॉइजनिंग, यूरेमिया मीन्स रिनल फेल्यूर, diabetic ketoacidosis, propylene glycol poisoning, iron, isoniazide, and some inborn errors, lactic acidosis, ethylene glycol poisoning, and salicylate poisoning. These are the causes of high anion gap metabolic acidosis. और इसके साथ साथ ये भी याद रखो, normal anion gap metabolic acidosis, it is seen in main is, this is important to remember, diarrhea, there is normal anion gap metabolic acidosis, then renal tubular acidosis 1 2 का 4, 1 2 का 4, 4 2 का 1 आपको गाना पता है ना. सो renal tubular acidosis 1 2 का 4 and the that is gastrointestinal fistula, ureterosigmoidostomy, ureterosigmoidostomy. These are the causes of normal anion gap metabolic acidosis. जनरली डायरिया पे क्वेश्चन रहता है एक्सेप्ट करके, या तो renal tubular acidosis 1 2 and 4. So these are normal anion gap metabolic acidosis. This is high anion gap metabolic acidosis causes. Okay, see, interpret the laboratory report. कैसे करने का? पहले तो ये pH पता चाहिए. नॉर्मल pH इज 7.35 to 7.45. पहले इसके बेसिस पे एसिडोसिस अल्कोलोसिस लिख दो इसके बेसिस पे, ठीक है. फिर सी फॉर द PCO2 लेवल, नॉर्मल रेंज इज 35 to 45. अगर PCO2 मतलब कार्बोनिक एसिड, PCO2 मतलब कार्बोनिक एसिड, ध्यान में रखो, कार्बोनिक एसिड बढ़ता है तो एसिडोसिस, बढ़ता है तो रेस्पिरेटरी एसिडोसिस, अगर कम होता है तो रेस्पिरेटरी अल्कोलोसिस, कार्बोनिक एसिड है ना, एसिड बढ़ गया तो रेस्पिरेटरी एसिडोसिस, एसिड कम हो गया तो रेस्पिरेटरी अल्कोलोसिस. HCO3 बाइकार्बोनेट लेवल अगर ये अल्कली है, अल्कली बढ़ गया तो मेटाबॉलिक अल्कोलोसिस, अल्कली कम हो गया तो मेटाबॉलिक एसिडोसिस. And remember the ROMs. It is normal level is 22 to 28 millimole per liter. This is 35 to 45 mmHg. Okay, now see and remember the ROMs. Respiratory opposite, metabolic same. रेस्पिरेटरी अपोजिट मेटाबॉलिक सेम। अभी ये तो नॉर्मल ही है शायद से। इंटरप्रेट द लेबोरेटरी रिपोर्ट, पीएच डिक्रीज हो गया मतलब एसिडोसिस, पीसीओ2 बढ़ गया मतलब इट इज रेस्पिरेटरी एसिडोसिस। बाइकार्बोनेट क्या है, नॉर्मल है, बाइकार्बोनेट नॉर्मल है, सो इट इज रेस्पिरेटरी एसिडोसिस, रेस्पिरेटरी एसिडोसिस। दूसरा देखते, पीएच बढ़ गया मतलब अल्कलोसिस, पीसीओ2 35 टू 45 मतलब ये नॉर्मल है, बाइकार्बोनेट 32 मतलब बढ़ा हुआ है, मतलब ये मेटाबॉलिक अल्कलोसिस, मेटाबॉलिक अल्कलोसिस। ये सिमिलर वाले प्राइमरी डिफेक्ट है। ओके, इंटरप्रेट द लैब रिपोर्ट, पीएच डिक्रीज है मतलब एसिडोसिस, पीसीओ2 35 टू 45 नॉर्मल रेंज है, ये नॉर्मल है, बाइकार्बोनेट डिक्रीज हो गया, पीएच डिक्रीज हो गया, बाइकार्बोनेट डिक्रीज हो गया, मेटाबॉलिक एसिडोसिस, दिस इज मेटाबॉलिक एसिडोसिस। ये देखो, पीएच बढ़ गया मतलब अल्कलोसिस, पीसीओ2 28 मतलब डिक्रीज हो गया, पीसीओ2 डिक्रीज हो गया मतलब रेस्पिरेटरी, रेस्पिरेटरी अल्कलोसिस, अल्कलोसिस। तो पीएच के ऊपर से आप डायग्नोसिस एक ये कर सकते हो, मतलब फिक्स कर सकते हो। उसके बाद आप ये देखो, रेस्पिरेटरी अपोजिट मेटाबॉलिक सेम, अगर बाइकार्बोनेट और पीएच सेम डायरेक्शन में जा रहे तो मेटाबॉलिक डिफेक्ट है। बाइकार्बोनेट सी यहाँ पे देखो, बाइकार्बोनेट और पीएच सेम डायरेक्शन में जा रहे तो ये मेटाबॉलिक कॉज है, मेटाबॉलिक कॉज है। डिक्रीज है तो एसिडोसिस, इंक्रीज है तो अल्कलोसिस। कहाँ पे मेटाबॉलिक अल्कलोसिस, ये देखो यहाँ पे इंक्रीज है, दोनों सेम डायरेक्शन में जा रहे, मेटाबॉलिक सेम, रेस्पिरेटरी अपोजिट डायरेक्शन। सी रेस्पिरेटरी में ये कम हो रहा, ये बढ़ रहा, ये देखो, ये बढ़ गया, ये कम हो गया, अपोजिट डायरेक्शन। सो अपोजिट डायरेक्शन में जा रहे तो रेस्पिरेटरी कंपोनेंट है, और सेम डायरेक्शन में जा रहे तो मेटाबॉलिक कंपोनेंट है, ये उनकी नॉर्मल रेंज है। रिमेंबर द रोम्स, रेस्पिरेटरी अपोजिट, मेटाबॉलिक सेम। दिस आर द ब्लॉटिंग टेक्निक्स, इंपॉर्टेंट, अभी लास्ट 2-3 ईयर में बहुत बार पूछा गया है ये। सो नॉर्दर्न ब्लॉटिंग, इट इज फॉर द आरएनए आइडेंटिफिकेशन। सदर्न ब्लॉटिंग, एक्चुअली सदर्न ब्लॉटिंग एडवर्ड सदर्न ने दिया, उसके बाद जो भी आए वो सब लेबोरेटरी जॉर्गन्स है। सदर्न ब्लॉटिंग इज फॉर द डीएनए आइडेंटिफिकेशन। ईस्टर्न ब्लॉटिंग, it is for the post translational modification of protein, and this western blotting it is protein identification। हम कंफर्मेटरी टेस्ट करते ना इसमें एचआईवी में, तो इट इज वेस्टर्न ब्लॉटिंग, कंफर्मेटरी टेस्ट फॉर द आइडेंटिफिकेशन ऑफ प्रोटीन। Northern blotting is for RNA, southern blotting for the DNA, and eastern blotting for the post-translational modification in the protein. Okay, these are the tumor markers used for diagnosis of the certain cancer। मैं कुछ important पे focus करता हूँ। अल्फा पीटोप्रोटीन, it is important tumor marker, अल्फा पीटोप्रोटीन। It is for the hepatocellular carcinoma, germ cell tumor। Then carcinoembryonic antigen, CEA, CA is there in the colorectal cancer, breast cancer and lung, CBL, colorectal, breast and lung cancer, mainly carcinoembryonic antigen। Carbohydrate antigen 15-3, CA 27-29, CA 549, this is for the breast carcinoma। CA 19-9 for the pancreatic tumor, CA 19-9 it is for the pancreatic tumor, mainly pancreatic cancer। ER, PR मतलब estrogen receptor, progesterone receptor, and HER2/neu, it is for the breast carcinoma, it is breast carcinoma, HER2/neu। Then CA 125 for the ovarian cancer, CA 125 for the ovarian cancer। ACTH for the small cell carcinoma of the lung, ये सर्जरी में भी आपको रिपीट होगा। कैल्सिटोनिन, स्पेसिफिकली ये याद रखो, कैल्सिटोनिन फॉर द मेडुलरी कार्सिनोमा ऑफ थायराइड ग्लैंड, कैल्सिटोनिन मेडुलरी कार्सिनोमा ऑफ थायराइड ग्लैंड। Then prostate specific antigen and the prostatic acid phosphatase, it is for the prostate carcinoma, it is for the prostate carcinoma। PA से ज़्यादा स्पेसिफिक है प्रोस्टेटिक एसिड फॉस्फेटेज से। देन मेटास्टेसिस बोन में है तो अल्कलाइन फॉस्फेटेज। सो दीज आर द सम इंपॉर्टेंट ट्यूमर मार्कर्स। ट्यूमर मार्कर्स आपको काफी बार रिवाइज हो जाते हैं, याद भी रहते हैं। रिमेंबर कैल्सिटोनिन फॉर द मेडुलरी कार्सिनोमा ऑफ थायराइड ग्लैंड। रिमेंबर द CA 125, remember CA 19-9, then remember the carcinoembryonic antigen in the CBL, colon, breast, lung, and pancreatic tumor। For the pancreatic tumor, the CA 19-9 is there, For the prostate cancer, it is acid phosphatase, prostate acid phosphatase, and the PSA, that is prostate specific antigen is there. Okay, prostate specific antigen is there. Neuron specific enolase, it is there in the neuroblastoma mainly. सी रिसेंटली इस पे क्वेश्चन आ सकता है राइसिन पे या डिप्थीरिया टॉक्सिन पे, और काफी बार आके भी गया है. दीज आर द इनिबिटर ऑफ प्रोटीन बायोसिंथेसिस. इंपॉर्टेंट टॉपिक है प्रोटीन बायोसिंथेसिस, तो इस पे क्वेश्चन बनता है. दीज आर द प्रोकैरियोटिक इनिबिटर टेट्रासाइक्लिन, डॉक्सीसाइक्लिन, क्लोराम्फेनिकॉल, erythromycin and aminoglycosides. These are the inhibitors of the prokaryotic translation process. Then diphtheria toxin, cycloheximide and the ricin. These are the inhibitors of the eukaryotic translation process. And the puromycin. Puromycin, it is structurally similar to that of the tyrosinyl tRNA. Tyrosin tRNA के structure जैसा रहता है. Tyrosin tRNA incorporates during the protein synthesis and causes the premature truncation of the, causes premature termination. Puromycin, tyrosinyl tRNA, premature truncation, premature termination of protein synthesis, termination of protein synthesis. So it is inhibitor in both eukaryote and prokaryote. Diphtheria toxin causes ADP ribosylation of elongation factor, eukaryotic elongation factor 2. Ricin removes one adenine nucleotide, from the 28S ribosomal RNA. Cycloheximide binds to the 60S unit and inhibit the translation process. Okay, tetracycline, doxycycline binds to the 30S subunit and prevent the attachment of amino acyl tRNA to the A site. फिर से रिवाइज है आगे के इसमें. Prevent the attachment of amino acyl ARNA to the A site. Chloramphenicol and the erythromycin binds to the 50S unit. Aminoglycosides, streptomycin, neomycin and gentamicin causes the misreading of the mRNA. Now see, tetracycline, doxycycline binds to the 30S subunit and block the attachment of amino acyl tRNA to the A site. Block the binding of amino acyl tRNA to the A site of the ribosome. Okay, A site of the ribosome. Chloramphenicol binds to the 50S unit, erythromycin binds to the 50S unit. ओके, दोनों 50S को बाइंड होते हैं. प्रोकैरियोटिक जो राइबोसोम है वो 50+30 से बना हुआ रहता है, टोटल 70. 50+30 टोटल 70. दिस इज स्वेडबर्ग यूनिट, नॉट मैथमेटिकल एडिशन. ओके, इरिथ्रोमाइसिन, क्लोराम्फेनिकॉल inhibit the peptidyl transferase, and erythromycin blocks the translocation of the peptidyl tRNA. Blocks the protein synthesis, by attachment to the 50S ribosomal unit. Aminoglycoside, streptomycin aminoglycoside, this blocks the formation of initiation complex. They causes the misreading of mRNA. This aminoglycoside causes the misreading of the mRNA. Then these are the eukaryotic inhibitor. Diphtheria toxin causes the ADP ribosylation of the eukaryotic elongation factor 2 and block the translocation. It blocks the translocation. Ricin binds to the 60S unit. Remove one adenine nucleotide from the 28S ribosomal RNA. It removes one adenine nucleotide from the 28S ribosomal RNA. Cycloheximide bind to the 60S unit, bind to the 60S subunit and inhibit the peptidyl transferase activity. Puromycin is structurally similar to the tyrosine tRNA, incorporates into a growing peptide chain and block the translation, premature termination करता है. Resembles the amino acyl, मतलब tyrosinyl tRNA, incorporates into a growing polypeptide chain and causes premature termination of polypeptide chain. This is puromycin, inhibits both prokaryotic and eukaryotic translation process. This is very, very important, must read, must remember, must know topic for the recent INICET NEET PG examination. Now there are certain processes which are important सिर्फ पूरा डिटेल में मत जाओ इसके, जस्ट इंपॉर्टेंट चीजें याद रखो. वीडीजे रिकॉम्बिनेशन, this is this is because of the gene rearrangement, because this is because of the gene rearrangement. It is there before the antigen exposure. And what is the purpose of VDJ recombination or gene rearrangement? It is to produce diverse set of the antibodies against various antigen. This is to create millions of different antibodies, to create the millions of different antibodies, near about 10 to the power 9 to 10 to the power 11 antibodies are produced by this VDJ recombination. The immunoglobulin chain, it is coded by the different genes. It is coded by the different gene. So there is variable gene near about 300 variable gene, 300, near about V1, V2, V5, V6, V100, near about 300 genes are there for the variable region of the light chain. Then there is joining region J1 to J5, J1 to J5, and there is that is diverse region, it is D1 to D10. So three genes are there, three types of genes. Matlab, there is variable gene for the variable region, gene for the joining region, and gene for the constant region of the immunoglobulin chain. Okay, by the different combination, different genes are produced. For example, this is V2, J1 and D10, or the V3, J2, D1. So different genes are produced, and these different genes use the different antibodies. So 10 to the power 9 to 10 to the power 10 different antibodies are produced against the different antigen, by the VDJ combination. This is known as gene rearrangement. This is before antigen exposure. And what is the purpose? To create the antibody diversity. Large number of antibodies are produced by this VDJ recombination. Second, see, class switching. मतलब क्या होता है? The IgM class, it changes to IgG और IgA और IgE. ये क्लास में चेंज हो जाता है, क्लास चेंजिंग ऑकर. ये क्लास कौन डिटरमाइन करता है? M और G है, ये कौन डिटरमाइन करता है? हेवी चेन डिटरमाइन करती है. कौन डिटरमाइन करता है? कांस्टेंट रीजन ऑफ द हेवी चेन डिटरमाइन करती है. सो सी, इट इज आफ्टर एंटीजन एक्सपोजर, it is in the constant region of the heavy chain, it changes the antibody class of the antibody change hota hai. This is from IgM to IgG, IgA and IgA. This is known as class switching. Switching of the antibody. Class switching मतलब class change हो जाता है antibody का. और तीसरा है somatic hypermutation. This is again after antigen exposure. There is small mutation in the variable region which increases the antigen affinity, of antibody for the antigen. So increases antibody affinity for the antigen. So तीन चीजें मैंने आपको बताई. Gene rearrangement, VDJ recombination to produce diverse set of the antibodies. Class switching, it is to change the class of the antibody. And somatic hypermutation, it is in the variable region. It is to increase the affinity of the antibody for particular antigen. That is known as the somatic hypermutation. These are the major fuel in the well-fed state and the prolonged starvation state. Remember it for the brain. Brain mainly utilizes the glucose, but after 3 days of the starvation, it started utilizing the ketone body. After 3 days, 2/3 of the fuel source is the ketone body. RBC utilizes glucose in all stages of the whether it is well-fed state or whether it is starvation or prolonged starvation, RBC only utilizes glucose. Remember, RBC only utilizes glucose. So glucose is the only source for the RBC, anaerobic glycolysis. Liver mainly utilizes glucose and fatty acids. Skeletal muscle utilizes glucose, fatty acid and ketone bodies. Heart mainly it is dependent on ketone bodies, also utilizes ketone, mainly dependent on fatty acid, also utilizes ketone body if the ketone bodies are abundant. Adipose tissue utilizes glucose and fatty acids. Mainly it is, remember this for the brain, important for the brain. These are the collagen related disorders we'll discuss in short. Osteogenesis imperfecta, there is brittle bone disease, blue sclera, brittle bone disease, osteogenesis imperfecta, brittle bone, frequent fractures are there, blue sclera is there, there is affected collagen 1 is affected. So this is brittle bone disease, multiple fracture, blue sclera, hearing loss is there, and dentition problem is also there. So there is collagen 1A1 and 1A2, it is defective. Defective synthesis or defective synthesis of the type 1 collagen is there in the osteogenesis imperfecta. सेकंड इज द एलर डाउनलोड सिंड्रोम. आप ऐसे स्किन अगर खींचोगे तो इट इज हाइपर इलास्टिक स्किन. सो हाइपर इलास्टिक स्किन, हाइपर मोबाइल जॉइंट एंड क्या बोलते and easy tissue damage is there in the Ehlers-Danlos syndrome. There are various types of the Ehlers-Danlos syndrome. There is affected collagen. See, type 3 collagen, type 5 collagen. It is dependent upon the type actually. The classical Ehlers-Danlos syndrome, type 5 collagen is affected. The vascular type, type 3 collagen is affected. Then kyphoscoliotic type, it is lysyl hydroxylase defect. So remember, hyperextensible skin, hypermobile joint, and hyperfragile tissues. Hyperfragile tissues are there in the Ehlers-Danlos syndrome. Okay. Then in scurvy, the hydroxylation is affected. So it is prolyl hydroxylase and lysyl hydroxylase is defective. That's why collagen rigidity and cross-linking is affected. Menkes disease, ATP7A mutation, neurodegenerative disorder, lysyl oxidase is defective. Collagen cross-linking is affected in the Menkes disease. So it is the lysyl oxidase defect in the Menkes disease. ATP7A mutation is there. ATP7A mutation, neurodegenerative disorder, X-linked disease, the steel or wiry hair, kinky hair is there, neurodegeneration, hypopigmented patches, and mental retardation is there. Kinky hair, neurodegenerative disorder. Alport syndrome, it is type 4 collagen is affected, type 4 basement membrane, glomerular basement membrane is affected. There is hematuria, there is lenticonus, and there is deafness. So there is hematuria, hearing loss, and the electron microscopic shows basket view glomerular basement membrane in the Alport syndrome. Remember, lenticonus, hearing defect, and the renal failure is there. Glomerular basement membrane is affected. Epidermolysis bullosa, type 7 collagen is affected. It is anchoring fibril which is at the dermo-epidermal junction which is affected. There is skin blistering with minor trauma, chronic scars, and nail dystrophy. These are the features of the epidermolysis bullosa. Type 7 collagen is affected in the epidermolysis bullosa. Now see, this is important. Recently, there is question on this topic. 22-year-old tall, thin male present to the emergency department with sudden onset of severe chest pain radiating to the back. On examination, he has long limbs, hyperextensible joints, and arm span greater than his height. Marfanite features है पूरे. Ophthalmologic examination reveals lens dislocation upward and outward. This is a classical feature of Marfan syndrome. अगर होमोसिस्टीन यूरिया है तो टूवर्ड्स नाजल डाउनवर्ड सबलक्सेशन रहेगा. नाजल एंड डाउनवर्ड होमोसिस्टीन लेवल बढ़ा हुआ रहेगा. Echocardiography shows aortic root dilation with aortic regurgitation. So there is aortic regurgitation. Which of the following gene mutation is responsible for this condition? This is fibrillin 1 gene mutation. There is increased transforming growth factor beta, which affect with the anchoring role of this fibrillin. Anchoring role of fibrillin is affected. There is aorta, the periosteum of the bone, aorta, aorta, the lens, the ligaments of the lens, they are affected. So there is subluxation of lens occur. There is skeletal deformity, skeletal problem, long arm span, arm span. अब्राहम लिंकन को मार्पन सिंड्रोम होगा ऐसा बोलते हैं. May had suffer from the Marfan syndrome. The height is there, the long arm span is there, skeletal problem is there, the aortic root के problem होते हैं, aortic root, the media is involved, aortic media is involved, and the zonules of the lens is involved, so subluxation of lens is there. So this is fibrillin 1 gene mutation, that is Marfan syndrome. Marfan syndrome. So Marfan syndrome is autosomal dominant, fibrillin 1 gene mutation is there, lens dislocation upward and outward रहता है, and there is aortic root dissection is there. होमोसिस्टिन्यूरिया में सिस्टाथायोनिन बीटा सिंथेस का डिफेक्ट रहता है, होमोसिस्टिन लेवल एलिवेटेड रहती है, जो डिसलोकेशन या सबलक्सेशन रहता है लेंस, इट इज टुवर्ड द नाजल एंड मीडियल साइड, एंड देयर इज इंक्रीज होमोसिस्टिन लेवल दैट कैन कॉज atherosklerosis. Cardiovascular problem can be there, but it is thrombosis, not aortic root dilation. Okay, it is downward and inward subluxation of the lens, so there is thromboembolism, not dissection of the aorta. Tall and long limbs, it is similar picture in the homocystinuria, but intellectual disability is there in the homocystinuria. Here it is normal, it is intellectually normal. Normal homocysteine level in the Marfan syndrome, here elevated homocysteine and methionine level in the homocystinuria. Cystathionin beta synthase defect, cyanide nitroprusside test is positive, cystathionin beta synthase defect. Two different specimens from two patients are received in the laboratory. Which molecular method helps to confirm that they are from the different individual? ये DNA फिंगरप्रिंटिंग का क्वेश्चन है. DNA फिंगरप्रिंटिंग, इट इज उसके 4 मार्कर्स है, मेनली 4 मार्कर्स है. यहाँ पे आंसर है RFLP. 4 मार्कर्स कौन से है DNA फिंगरप्रिंटिंग के? DNA प्रोफाइलिंग या फिंगरप्रिंटिंग. DNA फिंगरप्रिंटिंग के 4 मार्कर्स है. कौन से 4 मार्कर्स है? एक RFLP जो सदर्न ब्लॉटिंग टेक्निक पे बेस्ड है, RFLP. दूसरा VNTR, वेरिएबल नंबर टैंडम रिपीट्स 10 to 100 बेस पेयर्स इन लेंथ रहते हैं, बेस पेयर्स इन लेंथ, VNTRs. अर्ली पहले यही यूज होते थे, VNTRs. Now the short tandem repeats they are used, they are known as microsatellite. 2 to 6 best pairs are there. Short tandem repeats nowadays, this is a golden method for the diagnosis of two individual. Paternity dispute, criminal, rapists, thieves. DNA fingerprinting का best marker है short tandem repeats. And also the single nucleotide polymorphism is there. SNP, change in the single nucleotide. So STR, short tandem repeats, are now commonly used for the DNA fingerprinting. Here the answer is RFLP. RFLP. By the action of restriction enzyme, you will get different fragments of the DNA in between the 2 points of the DNA, depending upon the restriction sites. See, pyrosequencing, it is the sequencing technique. Mutation analysis के लिए भी किए जाती है. Northern blotting, it is for the identification of the DNA. No, it is for the RNA. Northern blotting is for the RNA. Pyrosequencing, it is a gold standard technique for the point mutation, sequencing and the point mutation के लिए pyrosequencing की जाती है. Okay. Fish fluorescence in situ hybridization technique help to identify all of the following except. Remember, the fish, it is a technique. Karyotyping करते हैं क्रोमोसोमल नंबर और एनोमली देखने के लिए. तो जनरलाइज क्रोमोसोमल एनोमली देखने के लिए कैरियोटाइपिंग देखते हैं, लेकिन उसको प्रॉपर एरिया अगर टारगेट करना है तो फिश करते हैं. फ्लूरोसेंट इन सिटू हाइब्रिडाइजेशन. ओके. जीन डिलीशन, ट्रांसलोकेशन, एम्प्लीफिकेशन के लिए फिश करते हैं. पॉइंट म्यूटेशन के लिए देयर इज RFLP. Point mutation के लिए pyrosequencing is there. These are the technique done for the point mutation. Fish is used for gene deletion, translocation and amplification. Except है तो answer is point mutation. Fish is not used for the point mutation. Remember this. See, karyotyping मतलब क्या होता है? Staining and microscopic visualization of the chromosome. ये जनरली कब करते हैं? दिस इज बेस्ट फॉर द ग्रॉस क्रोमोसोमल एनोमली. ग्रॉस क्रोमोसोमल एनोमली के लिए कैरियोटाइपिंग करते हैं. ग्रॉस क्रोमोसोमल एनोमली जैसे ट्राइसोमी हो गया, मोनोसोमी हो गया, डाउन टर्नर क्लेनफेल्टर के लिए, या द लार्ज डिलीशन, इंसर्शन और द ट्रांसलोकेशन, इनके लिए कैरियोटाइपिंग करते हैं. फिश में क्या करते हैं? टारगेट करते हैं एक पर्टिकुलर particular part of the chromosome is target. Fluorescent DNA probes hybridize with specific chromosome region in situ. मतलब एक particular area target करते हैं chromosome का, that is fish. Okay. It detects the gene deletion, duplication, translocation, amplification based for targeted chromosomal analysis. Based for gross chromosomal anomalies. This is based for the targeted chromosomal anomaly. For example, BCR ABL translocation 922 in the chronic myeloid leukemia. HER2 new amplification in the breast cancer. This is identified with the help of FISH technique, fluorescent in situ hybridization. Okay. Then microarray, the large number of probes over a small area, it is placed in the DNA chips. Thousands of DNA probes on a chip hybridized with a labeled DNA. This is for the gene expression analysis. This is used for the large scale gene analysis, gene expression analysis के लिए यूज होता है ये कौन सा माइक्रो एरे या तो डीएनए चिप्स बोलते हैं इसको. और आरएफएलपी इट इज फॉर द डीएनए फिंगरप्रिंटिंग के लिए आरएफएलपी वीएनटीआर यूज होता है, एंड ऑल्सो म्यूटेशन एनालिसिस के लिए यूज होता है. म्यूटेशन एनालिसिस के लिए आरएफएलपी यूज होता है. डीएनए फिंगरप्रिंटिंग के लिए मेनली अभी आरएफएलपी यूज नहीं करते, अभी वीएनटीआर या एसटीआर यूज करते. बेस्ट इज द एसटीआर, शॉर्ट टैंडम रिपीट्स यूज करते. Pyrosequencing, it is a technique, it is a real-time technique for the sequencing. It is sequencing technique, it is a gold standard technique, real-time technique. Light is emitted and real-time light is emitted in the pyrosequencing. Sequencing by detecting the light released during the nucleotide incorporation. Exact base sequence, short means single nucleotide polymorphism, and small mutations can be detected by the pyrosequencing. तो RFLP और pyrosequencing point mutation के लिए यूज करते हैं. Point mutation, single nucleotide polymorphism, and based for base level mutation detection. This is pyrosequencing और RFLP point mutation के डिटेक्शन के लिए करते हैं. कैरियोटाइपिंग, लार्जर क्रोमोसोमल एनोमली के लिए कैरियोटाइपिंग करते हैं. शॉर्ट एरिया अगर ये करना हो, जैसे कि एम्प्लीफिकेशन है, डुप्लीकेशन है, डिलीशन है, तो फिश करते हैं, फ्लूरोसेंट इन सिटू हाइब्रिडाइजेशन. फिर माइक्रो एरे, इट इज फॉर द एक्सप्रेशन एनालिसिस के लिए माइक्रो एरे करते हैं, डीएनए चिप करते हैं. RFLP for point mutation and DNA fingerprinting, and pyrosequencing, it is for the single nucleotide polymorphism. Point mutation, exact base sequence पता करना है तो pyrosequencing करते हैं. Real time technique for the nucleotide sequencing, pyrosequencing, real time technique for the nucleotide sequencing. Now see, this is now end. A child with type 1 diabetes was brought in unconscious condition. Urine test was performed and the image is given below. Identify the test. So there is purple ring at the junction of two solution. This indicates the Rothera's test. Positive Rothera's test, it is given by acetone and acetoacetate, not given positive by the beta hydroxybutyrate, but beta hydroxybutyrate is the predominant ketone body in the diabetic ketoacidosis. Rothera's test. These are the tests. This is Benedict test. This is Rothera's test. This is Hayes sulfur test. Sulfur powder sink to the bottom of the test tube. This is Fauchet test for the bile pigment, and this is heat coagulation test. ये किस चीज के लिए करते हैं? This is for reducing sugar. This is for reducing sugars. Benedict test बोलते हैं इसको. Benedict's test. This is Rothera's test. Eurostrip करते हैं, अभी ये टेस्ट नहीं करते. Rothera's test for the ketone bodies. This is Hayes test, Hayes sulfur test for the bile salt. This is Fauchet test for bile pigment, biliverdin. Pista green precipitate indicates the positive test. This is sulfur powder sink to the bottom of the test tube, indicate the presence of the bile salt, sodium and potassium salt of glycocolate, taurocolate, glycochinodioxycolate, taurochinodeoxycolate. This is heat coagulation test for the protein. heat coagulation test for the protein. Also, multiple myeloma हीट कोएगुलेशन टेस्ट इज पॉजिटिव इन बिटवीन 40 to 60 डिग्री. उसके ऊपर गया तो कोएगुलम डिसअपियर हो जाता है, फिर से ठंडा हुआ सॉल्यूशन तो फिर से कोएगुलम अपीयर होता. दिस इज बिकॉज ऑफ बेंजोन्स प्रोटीन एक्सक्रीशन इन द यूरिन इन द पेशेंट विथ मल्टीपल माइलोमा. मल्टीपल माइलोमा में क्लासिकल हीट टेस्ट करते हैं जो 40 to 60 में कोएगुलम दिखाता है. दिस इज द हीट कोएगुलेशन टेस्ट विच इज डन. नेफ्रोटिक सिंड्रोम में अल्बुमिन रहता है, एक्सक्रीट होता है यूरिन में, वो पॉजिटिव देता है. नेफ्रोटिक सिंड्रोम, ग्लोमेरुलर नेफ्राइटिस, albumin urea is there, that gives the heat coagulation test positive. So these are the important topics related with, these are the important areas जहाँ पे हमेशा क्वेश्चन आता है. important topics related with INI-CET, NEET PG, entrance examination. तो ये जो इम्पोर्टेंट टॉपिक है ये तो करनी ही है, इसके बावजूद भी और थोड़ा सा एक्सटेंसिव स्टडी करना पड़ता है. थोड़े से कुछ जो चीज़ें जैसे कि आरडी है जो याद नहीं रहते, जो चीज़ें याद नहीं रहती वो एग्ज़ाम के पहले पढ़ के जाना पड़ता है. सो अपने स्टडी पे फोकस करो, जो आपकी स्ट्रेंथ है उस पर फोकस करो. एकादा बाउंसर आता है तो तब डक करो और बाकी का पेपर अच्छे से सॉल्व करो. बिलीव इन यूर सेल्फ एंड दिस इज all about this is the most important topics about the INI-CET NEET PG entrance examination. This is all for today. Thank you very much all of you. Thank you. Keep watching. Thank you everyone.